is not just merely acquiring knowledge. It is a powerful engine that drives innovation and saves lives. As I was preparing for this address, I remembered the days, our early days, when we were still in primary school and secondary school. This paper came out. I didn't read it at that time. I read it much later. And I'm sure many of you have read this paper. The News of Slim Disease, a new disease in Uganda, and its association with the HTLV infection, by our own scientists, who many of you know in the room. So this news came as a new disease that had recently been recognized in rural Uganda. And because the major symptoms were weight loss and diarrhea, it was locally known as Slim disease. We have since moved away from that picture. But how has science helped us move away from that picture of Slim disease? Science has enabled us to discover and understand the HIV virus itself, how it is transmitted, and how it causes disease in the human body, and how the disease progresses. Science has also helped us develop diagnostic tools and also formulate treatment regimens and monitoring systems. Science has also helped us advance effective prevention strategies. It has helped us shape policies, guidelines, and community action. On the slide, you can see that we have the schema of what we called the natural history of HIV disease. Science has helped us move away from that natural history. We no longer see people going down with AIDS until they die because of the scientific interventions. A few of them still pop up, but on the majority scale, we no longer see this picture in the majority of patients. I don't know where I'm supposed to point this. Okay. So science helps us to save lives. When I joined medical school, these pictures were very, very frequent. When I would go to the ward, these are the kinds of pictures that I saw. As Professor Ngonzi told you, I'm an internal medicine specialist. So I have seen thousands and thousands of patients. Right from the early days, when they came in with Slim disease, with extreme wasting, extreme diarrhea, with Kaposi sarcoma, with TB, with toxoplasmosis, with cryptococcal meningitis, name it. I have seen it all. You'd come to the ward. I was telling Dr. Ruth Senyonyi while we were seated, you come to the ward, perform a ward round, and come back the next day, and almost 3/4 of your patients are gone. Or they call you in the night, patients are convulsing, and in the morning, they are gone. So science has helped us intervene with innovations, with therapies that have helped to save lives. We don't see many of these pictures. Although time and again, we still see 1 or 2 people coming in with advanced disease, with AIDS. It is surprising that in this day and age, we are still seeing people coming in with advanced disease, with the AIDS, the typical picture. Once in a while, you go to the ward and you'll see them. So we need community action against this. But science has helped us with the innovation, with the evidence-based decisions, to get life-saving interventions that have given us sustainable responses to the point that we are not seeing these too frequently. So who are these scientists behind all this? I know in Uganda there is this discussion and arguments about who is a scientist, who is not a scientist. In this context, I'm referring to basic scientists, medical scientists, social scientists, health scientists, data scientists, name it. They all contribute across labs, across clinics, in the community, in the data centers, wherever they are. In the classrooms, the science teachers, but also the arts teachers contribute to science, I must say. So those are the scientists. I must say we are all scientists in one way or the other. When you look globally, what have we got from science, the global scientific achievements? We know that the HIV virus was discovered way back in 1983. We had those Petri dish experiments that led to the discovery of zidovudine very early on, that was used as the first drug to treat HIV that many of us came across. But over time, clinical trials went on and more drugs were discovered. So those of you who are old enough, about my age or older, have seen many of these drugs. From the time when we were using a single drug to when we use 2 drugs to 3 drugs, a combination of 3 drugs, multiple pills, to now when we are using a single pill and very simplified therapies. This AZT was approved way back in 1987. And from then until today, we have seen a pipeline of drugs coming through science, basically showing you that science can change lives and science can change society. We now have PrEP and PEP, pre-exposure prophylaxis and post-exposure prophylaxis. We have the long-acting injectables. We have the long-acting drugs for HIV prevention, and so on and so forth. All these have come through science. We also have heard about the functional cure cases, the Berlin patients, and I'm sure many of you have read about some of these patients. And all these are innovations coming through science. Science has led us to the current global HIV situation, where we have about 40.8 million people now living with HIV, 26.3 million in Africa, and we have the new infections, but they are going down. We see that they are going down, and we have to maintain these gains or protect these gains. Otherwise, we'll slip back to where we were. We see that the reduction in new infections is at 40% since 2010, and we have 1.3 million new infections in 2024. I'm yet to know the new statistics. We also know that the AIDS-related deaths have reduced by 56% since 2010, all because of science. What about Uganda? What has science done? What have we done and what have we achieved through science in Uganda? As you heard from the very first speaker, Dr. Sebutinde to Dr. Senyonyi, Uganda is a global model. And this, we must recognize our leadership of the country. His Excellency, the President of the Republic of Uganda, the government of Uganda, yes, please clap, the Ministry of Health, led by several people, but currently led by our own Dr. Jane Ruth Aceng Ochero, the Uganda AIDS Commission, and development partners, scientists and communities. Uganda is a model globally. Anywhere you go, they'll ask you about Uganda. I don't want to say that they'll ask you about Idi Amin, which is a frequent question, but on the side of science, yes, they will ask you about how Uganda responds to some of these epidemics and pandemics, including HIV/AIDS, including Ebola, and including Marburg. So Uganda is a model globally. And this global model has had significant achievements, where we have seen our HIV prevalence as a country reducing from 18% in the early days to the current national prevalence of 4.9%. We've seen our new infections reducing from about 96,000 in 2010 to about 37,000 in 2024. The AIDS-related deaths have also similarly reduced from about 56,000 to 20,000, and over 1.5 million people are currently receiving antiretroviral therapy, which represents about 90%. And we have achieved 96% viral suppression with a strong mother-to-child prevention strategy. However, we still see that about 4,700 infants were still infected or born with infection in 2024, which Dr. Ruth Senyonyi talked very well about, and which we all have to combine efforts to strengthen to prevent that kind of transmission. So the power of science has infiltrated other sectors, not only patient care, not only bringing down this HIV prevalence, but we see that science has strengthened the national research institutions. talk about institutions like the JCRC, Joint Clinical Research Institution Center, talk about Uganda Virus Research Institute, talk about Infectious Diseases Institute, talk about Mbarara University of Science and Technology. Science has strengthened national research institutions. Science has helped us build human capital and expertise. You see the people here seated in front of you, they are all experts in their own ways. But it is all because of science. And also the response to HIV/AIDS has contributed to this human capital development. We've also seen a number of innovations and local solutions at the national level, all because of science. So, having said that, the past that we have benefited from science, what is the role of science in the sustainability of the national HIV/AIDS response going forward? What is the role of science? So, science for sustainability. We need to strengthen research and development. We need to use science to monitor the emergence of new strains and to monitor the emergence of drug resistance and to fight this drug resistance. Science will help us to continue optimizing antiretroviral therapy regimens and monitoring treatment for those who have accessed treatment. Science will also help us to advance research into getting the HIV cure. I'm glad that Dr. Senyonyi has thrown that challenge to us as Mbarara University to continue our research efforts to try and advance the research towards obtaining the cure as well as the HIV vaccine. This is not simple science. It's very complicated science, and it takes a lot of effort and a lot of goodwill from our leaders to be able to go on to conduct this research. Science also, going forward, will help us continue the science-driven prevention rollout and strengthening the pre-exposure prophylaxis, strengthening the post-exposure prophylaxis scale-up, as well as the voluntary medical male circumcision. We still need a lot of science to continue monitoring these interventions, to continue monitoring if they are still working at this level or if we need some modifications to be able to achieve better and sustain and even improve the response that we have seen. We need science on behavioral and structural strategies. We need new technologies. We need the implants and long-acting injectables. We talked about stigma. Dr. Senyonyi talked about stigma. If stigma is still present with us, we still need those interventions that people can use without their neighbor knowing that I am using this intervention, and so on and so forth. In terms of data science, we need to harness data for impact, to use data-driven resource allocation strategies, to know where resources should be put, where we should put effort. We can only do this if we have the data to be able to guide these decisions. Targeting the high-burden populations. We still need science to find out, to do surveillance, to find out which are the high-burden populations that we should target, that we should concentrate on. Digital health and artificial intelligence. We are very lucky to have artificial intelligence and this technology all over the place. Now you can communicate. Everybody can access information. As easy as just click your phone and you'll have all this information available. Young people have smartphones. They can access information. So we need to harness these tools to be able to reach the population as much as we can with information. We need real-time surveillance systems. I'm glad that the Ministry of Health has taken on the integrated approach to care for patients with HIV/AIDS, but also for prevention. We need to strengthen this integrated approach. When we were in medical school those early days, the same clinic would treat diabetes, the same clinic would treat HIV, you're the same doctor treating hypertension, treating malaria. And as we progressed through medical school until the time we finished, there were differential clinics for every disease. And that meant a lot of resources, you know, a doctor to only treat diabetes, another doctor only treating HIV, another one only treating hypertension. And I kept wondering, I have been trained as a doctor to treat a whole human being. Why should I fragment, you know, concentrating on diabetes? I'm glad that the Ministry of Health has taken on the integrated approach to care. And we need science to monitor this integrated approach to ensure that we strengthen it to work with the same resources that we have to be able to reach majority of our patients. The increased efficiency and reduced patient costs. Through the integrated approach, we shall reduce the costs and we shall reduce our dependence on donor funding. We also need to strengthen our health system, especially now with the integrated approach and with the reduced funding. We definitely have to strengthen our health system to achieve better than what we are seeing now. We need to strengthen community engagement using science. If we wait to go to our labs or our clinics or where the science is, we shall not gain much more than where we are now. We need to go out into the community. We need community engagement, community-led monitoring, community-led research to tailor interventions to the local realities, to get evidence-informed stigma reduction. What's happening in our communities with stigma? We can only understand that if we go out into the communities to understand why is the stigma still persevering in these communities. Above all, we need poverty eradication. Dr. Senyonyi, I think Uganda AIDS Commission needs to talk strongly about socio-economic transformation. Without poverty eradication, it's going to be very difficult for us to end or to reduce new HIV infections. As I was preparing for this talk, I saw this on social media that was in the Observer, that HIV rates surge in Soroti as schoolgirls sell sex for 1,000 shillings. Can you imagine that? Selling yourself for 1,000 shillings. What does that tell us? People are extremely poor. And as long as people and young girls continue to be extremely poor, they are going out to look for the men to give them that little 5,000 shillings to be able to survive for the day. You asked about the 45-year-old men who have higher HIV prevalence. And I started to formulate a hypothesis in my mind about these 45-year-olds and the younger girls, but I will not say my hypothesis. I will not say it out. Anyway, so back to the science here. Oh, the slides are not moving. Local organizer, please. Okay. I don't know where I'm supposed to point the... Can we move back one slide, please? Okay, yes. So I was emphasizing the point on community engagement and my point on socio-economic transformation and poverty eradication. Without poverty eradication, it's going to be a tough one for us to stop new infections. So what is the future? We need a balanced and integrated approach, and this integration must be high-quality, people-centered, and non-stigmatizing, supported by functional systems, from logistics to human resource to information system, and so on and so forth, guided by implementation science. I'm glad that in this country, we have implementation science now on board, and everybody is training in implementation science. I hope that those implementation scientists will be able to cause change. We need to preserve the strengths of the HIV movement for community-led accountability, community participation in decision-making, community-led service delivery, for sustainable financing, and evidence-based scale-up. Challenges that science must address going forward. We are seeing reduction in funding, the funding gaps, and reduced donor support. What can we do with what we have to overcome this reduced donor funding, to continue achieving gains that we are seeing? We need to reduce stigma and discrimination, and this is still a hot topic. Some people think stigma has reduced, but it's still there. When I was a medical student and when I started my practice on Ward 4A in Mulago Hospital, the stigma was high up there. And we were forced at that time as clinicians to try and tell patients, if you have malaria and you can accept me to test you for malaria, why can't you let me test you for HIV? But the patients would resist. I'm glad that today I have the mandate to walk in and test a patient for malaria and HIV and give them treatment. But the stigma is still there, and we need to continue fighting this stigma. The challenge of vulnerability of adolescents and young women is still a big challenge. Young women and adolescents need to be empowered to speak out, to say no. The challenge of drug resistance coming on board, this only needs time, and we need monitoring systems to continue to monitor and come in to strike it when it happens. The hard-to-reach populations, the key populations, the hard-to-reach populations, these are areas that we need to concentrate on. Above all, the social determinants of health, poverty, education, gender-based violence. I don't want to ask in this room how many people suffer gender-based violence, but it's a silent killer. People are suffering out there, and this is one of those that actually continues to fuel the HIV problem. Then access to proven interventions for all. As I was preparing, I reviewed some literature. Of course, I knew about lenacapavir, but I had to dig up this paper. This is research that was done here in Uganda. As you can see, the authors are Ugandans. The senior author, Dr. Flavia Matovu Chiwewa, works at the Muju. This paper tested twice yearly administration of lenacapavir compared to the tablets of TDF, to be able to check if they reduce the incidence of new infections in a community. And what were their conclusions? I didn't paste the whole abstract. What were their conclusions? And I won't go into the science, because I know the congregation has a mixture of scientists and non-scientists. The conclusion here was that no participant receiving the twice yearly lenacapavir acquired HIV infection. No participant. Compared to the other arms, no participant received this injectable preventative intervention acquired HIV. The news went out, and I copied that from the US Embassy page. The US Embassy Uganda announces introduction of lenacapavir, a groundbreaking HIV prevention medicine, demonstrating American excellence in science and American leadership in HIV prevention. How available is this to the ordinary Ugandan? How available is it? That is the question we need to ask ourselves. This is research done here by Ugandans with Ugandan participants. It showed results that are significant, that the world is celebrating, but how available are these drugs to us as ordinary Ugandans? So we need to ensure we increase access to proven interventions. In conclusion, the role of science in the sustainability of the national HIV/AIDS response, we see that science has guided us since the beginning of this problem of HIV/AIDS, including Ugandans discovering the slim disease here in Uganda. It remains key to sustaining the Ugandan HIV/AIDS response. We need to harness science and all the scientific measures to continue to sustain this response. Science is essential for ending AIDS as a public health threat by 2030, and I'm glad that we are all hopeful. Let us invest in science, innovation, partnerships, resilience, poverty eradication, and community engagement if we are to stop new infections with HIV. With science as our compass, an AIDS-free generation is within our reach. So, what is the role of Mbarara University of Science and Technology? In all this science, we are empowering young people through science. Of course, we are doing a lot in terms of strengthening science education, research, and innovation. We have great scientists, including those that are seated here in front. We are doing community engagement, and our university was founded on a philosophy of community engagement. Our students go out into the community, and they engage the communities. But also our scientists disseminate their research findings to the communities. So we contribute a lot. We are contributing to building the next generation of scientists, researchers, innovators, and leaders. And there are some of them are here with us. Research, innovation, and dissemination of research findings is our core mandate. And last week, we had, was it last week? I'm disoriented. We had our annual research dissemination conference where we had over 100 papers presented, and most of them were on HIV and related infections and interventions. We are participating in clinical care of patients with HIV and related infections, as well as clinical care in an integrated approach. We are offering prevention, 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 prevention. Every time we receive new students, we take them through orientation, and HIV is one of the topics that we talk to them about. In addition, our budget has a protected percentage that goes to HIV/AIDS prevention. We are also talking about socio-economic transformation and poverty eradication. We have moved our curriculum all to the competence-based education curriculum, and the reviews are still going on. We want to prepare our students to be either job-ready or to be able to go out and create a job or go out as an entrepreneur, so that we fight and contribute to this socio-economic transformation to stop this poverty, and therefore contributing to stopping new HIV infections. We empower the youth, the girls, and the young women, and I'm very expectant to see them coming in so that they can listen to whatever discussions are going on here. Finally, as I end, to reflect on World AIDS Day message, the theme, overcoming disruption, transforming the AIDS response, calling for sustained political leadership, international cooperation, and human rights-centered approaches to end AIDS by 2030. I picked this direct from the WHO website. And they say, after decades of progress, the HIV response stands at crossroads. Life-saving services are being disrupted, and many countries face heightened risks and vulnerabilities. Yet amid these challenges, hope endures in the determination, resilience, and innovation of communities who strive to end AIDS. Thank you very much for listening to me, and I thank the Uganda AIDS Commission for inviting me to give this address. Thank you.
Thank you. Yeah. Thank you, Vice Chancellor, Mbarara University of Science and Technology, Professor Biachika. I think she deserves another big clap. Nice. She prefers taking a seat back where she started from. We thank you for your keynote speech and science. I want to thank the previous speakers, Canon Dr. Ruth Senyonyi. We are very grateful, and no wonder you did your PhD research in HIV/AIDS. I want to thank my brother, Dr. Sebutinde. Dr. Sebutinde Peter is a seasoned clinician. He is an administrator, and is always a forefront fighter against HIV/AIDS. No wonder his wedding and honeymoon was fully sponsored by his clients. Thank you so much. The Uganda AIDS Commission continues to welcome you members to Ankole, and more so to Mbarara University of Science and Technology. We continue to appreciate the members who are already here. I see very many distinguished guests who were invited. We thank you for honoring this day. You are very much aware we are still together for the next 2 days here. And I still appreciate that more members are still registering in. I just want to inform our ushers that we have more seats in this direction. we see our invited guests coming and crowding in one corner. We are slightly behind the schedule, but as you already know, HIV/AIDS is of global, it has caused a global impact. We have got some global perspective of it, and we clearly know that different countries have been offering different responses. The only person with that information is one and the only Miss Jackie Makoha. Jackie Makoha is a UNAIDS country director. She was here before any other person, and now we welcome you here. Thank you. We continue clapping. We want to give her energy. Our sugar levels are going down. Thank you. Thank you.
Thank you, Master of Ceremony, for the clap. Vice Chancellor, Mbarara University of Science and Technology, thank you so much for hosting us here. It's my first time to visit Mbarara University, so I'm very excited. The chairperson of the Uganda AIDS Commission, the DHO, Dr. Sebutinde, thank you for your welcome to Mbarara. DG and the senior management team of Uganda AIDS Commission, the board members here present, development partners, including my colleagues from the UN, people living with HIV, this is your week. So thank you so much, Flavia. I recognize your presence and your leadership of people living with HIV. Civil society colleagues, symposium organizers, ladies and gentlemen, all protocols observed. Globally now, we are talking a lot about the disruptions to the HIV response. And the Vice Chancellor has already hinted to this, and also the chairperson of the AIDS Commission. So I will focus on these disruptions and what we are seeing in the data. On Monday this week, UNAIDS launched the World AIDS Day report, and it's titled Overcoming Disruption, Transforming the AIDS Response. The report demonstrates the profound impact of disruptions on the HIV response due to funding cuts, but also highlights the resilience and hope for ending AIDS as a public health threat by 2030, which is still within our reach. After decades of progress, 2025 has been a year of profound disruption for the global AIDS response. Hard-won gains built through science, solidarity, and the leadership of communities have been shaken by funding cuts, rising inequalities, and new barriers to essential services. Yet amid these challenges, there is also a story of resilience and opportunity. With renewed commitment and smart investment, we believe that ending AIDS as a public health threat is still within our reach, and particularly for Uganda. At the end of 2024, over 9 million people living with HIV globally were not on treatment, and 11 million people living with HIV had unsuppressed viral loads. Here in Uganda, I think we've seen the data that was presented by the chairperson and also by the Vice Chancellor, that we are, you know where we are on the cascade, that 90% of people living with HIV know their HIV status, 94% are on treatment, and 97% are virally suppressed. That is in 2024. We are still looking at the picture in 2025, and we'll have this data around March. 1.3 million people globally acquired HIV in 2024.
Abrupt reductions in international HIV assistance in 2025 have deepened existing funding shortfalls. The Organization for Economic Cooperation and Development has projected that external health aid will drop by 30 to 40% in 2025 when we compare to 2023 figures. This will cause immediate and severe disruption to health services in low and middle income countries, including Uganda. Across the world, the AIDS response has suffered these major shocks. Abrupt reductions, we saw that start happening in January, but it has been on a decline. It just became worse in January when the new US administration came into place. But we know that also other donors are reducing their development aid. So abrupt reduction in international funding have disrupted prevention programs, particularly. They've closed community clinics and strained treatment services. Prevention has been hit the hardest, with access to medicines to prevent HIV, PrEP, declining in several countries, and programs for adolescent girls and young women being scaled back. Key populations, including men who have sex with men, transgender people, sex workers, people who inject drugs, and here in Uganda we also talk about the fisher folk and people around the fishing communities who are already carrying a disproportionate burden of HIV, have been among the most affected. Programs including DREAMS for adolescent and young women, medical male circumcision have been hugely affected with no funding. And there is no indication that this funding will return, particularly for prevention. The recent cuts will potentially flatline previously increasing treatment coverage and reduce HIV prevention services. In 2024, a high proportion of foreign assistance was directed at prevention programs and community services. That is in 2024, but 2025 we saw a change. Effects are apparent in diverse countries, with a 31% decline in the number of people receiving PrEP. Here in Uganda, we've seen a major decline, 31% decline when compared to what we had in December 2024, when we compare with September 2025. So between December and 2024 to September 2025, we've had a 31% decline in access to PrEP. Vietnam has seen 21% decline within the same period, and Burundi has seen a 64% decline over the same period. Access to proven HIV prevention tools such as male condoms is declining in some countries. Between December 2024 and March 2025, the number of male condoms distributed globally in Nigeria, for example, fell by 55%. Cuts in international HIV assistance are having especially negative consequences for community-led services, which often depend fully on external assistance. Over 60% of women-led HIV organizations globally have lost funding or been forced to suspend essential programs, leaving entire communities without access to vital services. Organizations of key populations have also lost funding, and some have closed offices. We know that here in Uganda we had 84 DICs. Only 24 of those are within facilities, and those seem to be okay. The community DICs are affected. UNAIDS modeling of the impact of these funding cuts demonstrates that in 2030 there will be 1.4 million annual new HIV infections, and that over the period 2025 to 2030, this would result in an additional 3.9 million new people acquiring HIV. compared to a scenario of reaching the global HIV targets by 2030. So it's not time to stop. As we discuss in these 3 days, let's think about how the story for Uganda will be like. What are we going to do differently to ensure that we are still on track to end AIDS by 2030? Almost half of all new adult HIV infections globally were among key populations in 2024. Outside of sub-Saharan Africa, people from key populations and their sexual partners accounted for 2 in 3 new HIV acquisitions in 2024. There were 570 new HIV infections among adolescent girls and young women globally per day in 2024. These disruptions have real human consequences, with huge proportions of people still lacking access to treatment. Testing volumes have dropped in many settings, and some of the most effective prevention programs have been weakened just when they are needed the most. Without urgent actions, these reversals could lead to rising new infections and stalled progress towards 2030. But this is not the full story. Even in a difficult year, countries and communities have demonstrated remarkable resilience. Many governments, including those with limited fiscal space, have increased domestic investment in health and HIV programs. For example, here in Uganda, the government of Uganda has stepped up and increased funds to the Ministry of Health through supplementary budgets, and our neighbors here in Tanzania have introduced a new AIDS levy. So there is also a story of hope. Communities have stepped up to protect access to treatment and support people at greatest risk. New sustainability roadmaps are being developed and implemented, including here in Uganda, and we will later hear from Dr. Bagambe on where we are with our sustainability roadmap. And despite immense pressure, several countries have managed to expand treatment, access, or maintain strong levels of viral suppression. Examples of signs of countries and community resilience are emerging, and global solidarity will be essential, and we are encouraging that this global solidarity continues. For example, countries have taken swift action to close funding gaps. As a result, many countries are showing resilience when it comes to HIV treatment delivery. Monthly data reported to UNAIDS indicates that the number of people newly initiated on treatment remains fairly stable over the first half of 2025, despite the funding cuts. Regional leadership is stepping in. In 2025, African leaders in the African Union roadmap to 2030 and beyond pledged to ensure diversified and sustainable financing for HIV and other health programs. Communities of people living with HIV, communities of people living with or affected or at risk of acquiring HIV are also rallying all over the world to support each other and to continue supporting the response. Developments in the second half of 2025 with respect to the 2 primary funders of the global HIV programs, the Global Fund and the America First Global Health Strategy, provide opportunities for countries to invest in programs and reach the people who need services the most. This can only be achieved when communities of people living with, affected, or at risk of HIV are engaged in developing these programs. We know that here in Uganda, the US government is discussing the Memorandum of Understanding with the Ugandan government, and so this gives us a lot of hope for the next 5 years. Building on the new Global AIDS Strategy 2026 to 2031, we can end AIDS by 2030 and build a sustainable response. But this will only happen if countries scale up HIV services to reach the 2030 HIV targets, including preventing new infections, maintaining people on treatment, but also retaining HIV prevention services at the 2024 coverage levels. Most importantly, we have new tools, and the Vice Chancellor has spoken to the long-acting injectable PrEP, lenacapavir, an innovation that can protect people for months at a time, which offers us a chance to transform HIV prevention, especially for young women, adolescents, key populations, and communities where daily pill taking is difficult. Countries are also exploring new ways to strengthen integrated, people-centered service delivery, including here in Uganda, where we have moved ahead with integration at a national scale. And global partners are reaffirming their commitments, from the renewed US support for frontline health workers to strong early pledges for the Global Fund's replenishment. Let's clap for Uganda. I think we committed that we will give $3 million to the Global Fund. Countries like South Africa committed 36.6 million. Nigeria, 15 million. African countries are stepping up. African countries have taken this strongly, and they will step up and ensure that we sustain the HIV response. The message for this year's World AIDS Day report is overcoming disruption, transforming the AIDS response. It's clear. The world has the tools, the knowledge, and the evidence to end AIDS, but only if we protect current gains and scale up innovations that work. We cannot afford to step back. Ending AIDS is not only possible, it is necessary for a healthier, more equitable, and more secure future. And we know that by investing in communities, embracing new technologies, and sustaining global solidarity, we can overcome disruption and accelerate the progress the world has worked so hard to achieve. This World AIDS, the choice is ours. Let us choose action. Let us choose equity. Let us choose to finish the job. And just to finish off, we are also in the 16 days of activism against gender-based violence. So we are wearing orange for the next 16 days, starting yesterday, and I believe it ends on the 10th December. So let me encourage you all to not only wear the red ribbon, but also wear orange and promote actions against gender-based violence during this critical period. I thank you.
Thank you. Thank you. Thank you so much, Madam Jackie, for the wonderful speech. And I want to appreciate that we have all been very, very thank you. Can you resume your seat? Thank you so much. We are very grateful for your attention, and because of these good previous speakers, they have earned us a breakfast. So we encourage, I think I would request the Chief MC, that's the name we baptized you this morning. Yes, Chief MC, you can guide us how we are going to enjoy the heresy break and the real breakfast. Thank you.
Thank you. I think we give a round of applause to our chair and co-chair. And of course, another round of applause to our facilitators this morning. And now, the chair says we are hungry. And I can tell, you can tell from that vantage point. But I want to beg for your indulgence. For record purposes, I would want to ask for a picture of the Vice Chancellor with our board chairman. It is not there in records. It will be the first time it is taken. So the presenters in this morning, together with the chairs, I would request you to take seats for the single purpose of taking a picture of you, for the report, for our records, to report about the campaign and the resolutions we make today, for the future reference. I humbly request our guests of honor, our board chair, that you leave your comfortable seats and you sit at the front, the podium. Then the cameraman, Dr. Mutu, you come and record this. We need it in records, and it will appear in so many of our reports, because yes. Oh, yes. The chairs, you can stay. All the presenters of this morning, please take the platform. And we'll request our Director General to join them. I hope. So you need to clap for Dr. Septin again for that inspiring and passionate speech. Dr. Septin, they give you a clap on my behalf. It was a revolutionary speech, charging us to move forward in spite of whatever is happening. Is there somebody missing? Thank you. We can take that picture. And I want to request now the board members of the Uganda AIDS Commission and top management of the Uganda AIDS Commission to stand behind our presenters. The board and top management, we need this for the records that you know. We need this. See, this is the first time we're having this picture. I remember when we decided, when it was proposed that the Vice Chancellor of Makerere University becomes the guest of honor, it was total calm and total agreement. So it's a very important picture. So University. I am sorry for that. The Vice Chancellor of must will lead. So thank you. Let's have that picture. These are the board members and top management of the Uganda AIDS Commission. And me and the co-MC, we shall also come. But I want to request our development partners, people from UNAIDS, the board member, the staff, the top management, you can come and resume your seats. So our development partners, the team from UNAIDS, team from PEPFAR, let's have your picture, please. Development partners, UN Family, PEPFAR, CHAI, our development partners, all of you in your categories, I humbly request that we have a record.
Yeah, these are for record purposes, and also once again allow me pass on this small announcement that we are taking very many pictures and they could be posted on different platforms. So let this be a way of asking for formal consent in case you see your picture in any of our records.
This is a public platform. I promise you we shall post these pictures. Dr. Terakwate, you come from the development partners. You are from Mumbarara. Dr. Terakwate, so finally, not finally, before final, it is the Reverend, myself, and the co-MC.
Yes, the
standing
MC.
Behind, the guest of honor and the board. And so, the Reverend, please come with me. We already performed the duty. We need this picture. And my co-MC. Thank you very much. I want to invite the representatives of people living with HIV now. The representatives of people living with HIV. We would want to have a picture with our guests.
Yes, they already recognize the commendable work done by Dr. Stephen towards advocating for people living with HIV.
Thank you. Our advocates, I want to ask the representatives of MDS, Ministry of Health, Ministry of Gender, please, this is an opportunity. This is the first of its kind. Dr. Mdiope, Dr. Mina, Lucy, Minister of Gender, MDS, we need this picture. I will pay you if you want to be paid, but I promise you that we need this record. Representative of MDS. Representative of MDS. Now, we are being hosted by Mbarara University. I hope I got it right.
Yes.
I am sorry for that error.
For this time, it is right.
So we shall request the professors and the staff of Mbarara University to take this time it will be to take a picture with our important guests this morning, Mbarara University staff.
The deans.
Our hosts would want to take a picture with you.
Staff.
And we shall be flashing it around, that I can promise you. The local organizing committee, but let's start with the staff. The staff of MAST, the professors, we are here strategically.
Yeah, these have been our hosts. We've worked
we recognize the impact of Mbarara University.
To make this day very colorful, and I think they deserve a hand clap as they are moving. We've
Please.
been generous hosts, haven't we?
Mbarara University staff, thank you for the hard work you did in organizing this event and the hard work you are going to do for the remaining several years, several days of this meeting. I can promise you this picture, we shall flash it, and you'll be proving me right. I want to request the staff of the Uganda AIDS Commission. You would kill me if you miss this opportunity, taking a picture with your favorite Vice Chancellor. I already disclosed that once they announced that the Vice Chancellor is our guest of honor, there was calm and contentment. So, yes, Dr. Wakoba, I know you love this picture. I know you'll flash it. The staff of the Uganda AIDS Commission.
We are seeing one person moving. Staff, please.
The staff. It was top management first, but the staff. I know you love this picture. So don't delay. I don't want to risk making our guests tired. The staff. The staff of the Uganda AIDS Commission.
Yeah, not forgetting to say that these are the main organizers for today's symposium, the Uganda AIDS Commission. So we are here because you are, and we are more than grateful for the great work you're doing. The smiles from Uganda AIDS Commission really, they can't go unnoticed.
Our guests, I beg for your indulgence. This is important for us and for the participants. I will ask for two favors. Local governments, I see so many DHOs from the region. It would be a mistake for us not to have a record that we're with you here when we make those decisions and start communicating them. So our DHOs, our leaders of the local governments, the CAOs who are here, I humbly request you to have a picture with our guests. The representatives of the DHOs yourselves, let's have a record that we made this decision with you, the decision we shall make today. Yeah. The DHOs, thank you for sacrificing and coming to be part of this conversation. And we appreciate the work you do. I can see there's a DHO or a DHE who is moving slowly.
Yes, this picture provides evidence that you're protecting the gains of the Uganda AIDS Commission in our struggle to end HIV by 2030.
Thank you. We have a committee of technical experts. You will forgive me. I am the MC, my friends. So the committee of technical experts. The committee of technical experts of the Uganda AIDS Commission. Members of the committee of technical experts. Okay, since there was a sign that people are getting hungry, you will, I thank you for your indulgence, for allowing me to delay you with this excess, and I thank you. I am being lobbied now. This is lobbying, this is not me. HIV focal persons, wherever you are, we need this report. Thank you. And I have given you the permission. HIV focal point persons of ministries, local governments, of institutions. HIV focal point persons. That would have been an omission. HIV focal point persons. I know all of us would have loved to have a picture with our important guests, and we shall create an opportunity as the symposium progresses to make sure everybody gets to take a picture with our board chair, with the vice chancellor, with our DG. You will have these opportunities. So thank you so much. So this is how we shall go. Let's clap for our guests for their indulgence. Thank you. Now, we are breaking for tea. There are two tents. In a typical African culture, we shall have to separate a bit. So the upper tent is for the board chair and her guests. And the lower tent is for the other people. So the board chair and the other dignitaries will use the upper tent. Myself and the MC and others, we shall use the lower tent.
I thought you were going to the upper tent.
No, for us, we shall use the lower tent. We have to live by example. We shall go to the lower tent. So we have a break of 20 minutes. We have made 2 tents so that service is quick. We are back in 20 minutes. We are told that the people of Must, you are very cautious with time. We are sorry for delaying you. Starting late was our fault, not Must. It was not your fault. So I request Hope, come and lead the board chair and her guests to the tent. The rest of us, you will come with me and the MC and must go to the lower tent. I promise you the breakfast is the same.
Yeah, and let us use strictly 20 minutes. We have quite a lot
20
in store.
minutes, we'll be back for the JAR report, the report card of our performance, and then it's a discussion whether we are inspired or heartbroken. Whatever the outcome is, then we shall start from there and make resolutions on how we move forward. Ladies and gentlemen, let's move for tea. I start counting now.
Yes, leading by example, those going to the lower tent. We've left. Follow us.
I have the honor to welcome you to Mbara. I have the honor to welcome you to Mbara University of Science and Technology, also known as MUST. At MUST, we believe in success. Our motto being, succeed, we must. Why should you choose to come to MUST? The programs we offer. We offer a wide variety of programs. Health science programs offered under the Faculty of Medicine. Science education offered under the Faculty of Science. Engineering programs offered under the Faculty of Applied Science and Technology. Computing and Information Technology offered under the Faculty of Computing and Informatics. Business and Management Sciences offered under the Faculty of Business and Management Sciences. And interdisciplinary programs offered under the Faculty of Interdisciplinary Studies. Our emphasis as we offer these programs is on community engagement. Our students are trained in the communities where they can get hands-on training and experience real-life settings. Some of the programs in that category are community-based education, research, and service. The other reason why you should come to MUST is we have highly qualified faculty and very friendly. We also have good administrative staff who are key in ensuring that our students complete their programs well. We offer affordable education. Our tuition and fees policies are friendly. The interaction between students faculty and management is cordial. We aim at supporting students to complete their studies. A student can choose to walk into the office of the academic registrar, the office of the vice chancellor, and ask for whatever service, and they will be welcomed and supported. At MUST, we guarantee uninterrupted education. During the COVID-19 pandemic, we did not stop interacting with our students. We went online and our students studied and completed, graduated on time, and took with them their transcripts and certificates. So we do guarantee that when a student chooses MUST, they will walk away with their academic documents. And finally, why should you choose MUST? We offer an intellectually stimulating learning environment at an affordable cost. Should you choose MUST as your university, we guarantee you success. Succeed, we must. You're welcome. I have the honor to welcome you to Mbarara University of Science and Technology, also known as MUST. At MUST, we believe in success. Our motto being, succeed, we must. Why should you choose to come to MUST? The programs we offer. We offer a wide variety of programs. Health science programs offered under the Faculty of Medicine. Science education offered under the Faculty of Science. Engineering programs offered under the Faculty of Applied Science and Technology. Computing and Information Technology offered under the Faculty of Computing and Informatics. Business and Management Sciences offered under the Faculty of Business and Management Sciences. And interdisciplinary programs offered under the Faculty of Interdisciplinary Studies. Our emphasis as we offer these programs is on community engagement. Our students are trained in the communities where they can get hands-on training and experience real-life settings. Some of the programs in that category are community-based education, research, and service. The other reason why you should come to MUST is we have highly qualified faculty and very friendly. We also have good administrative staff who are key in ensuring that our students complete their programs well. We offer affordable education. Our tuition and fees policies are friendly. The interaction between students, faculty, and management is cordial. We aim at supporting students to complete their studies. A student can choose to walk into the office of the academic registrar, the office of the vice chancellor, and ask for whatever service, and they will be welcomed and supported. At MUST, we guarantee uninterrupted education. During the COVID-19 pandemic, we did not stop interacting with our students. We went online and our students studied and completed, graduated on time, and took with them their transcripts and certificates. So we do guarantee that when a student chooses MUST, they will walk away with their academic documents. And finally, why should you choose MUST? We offer an intellectually stimulating learning environment at an affordable cost. Should you choose MUST as your university, we guarantee you success. Succeed, we must. You're welcome. I have the honor to welcome you to Mbarara University of Science and Technology, also known as MUST. At MUST, we believe in success. Our motto being, succeed, we must. Why should you choose to come to MUST? The programs we offer. We offer a wide variety of programs. Health science programs offered under the Faculty of Medicine. Science education offered under the Faculty of Science. Engineering programs offered under the Faculty of Applied Science and Technology. Computing and Information Technology offered under the Faculty of Computing and Informatics. Business and Management Sciences offered under the Faculty of Business and Management Sciences. And interdisciplinary programs offered under the Faculty of Interdisciplinary Studies. Our emphasis as we offer these programs is on community engagement. Our students are trained in the communities where they can get hands-on training and experience real-life settings. Some of the programs in that category are community-based education, research, and service. The other reason why you should come to MUST is we have highly qualified faculty and very friendly. We also have good administrative staff who are key in ensuring that our students complete their programs well. We offer affordable education. Our tuition and fees policies are friendly. The interaction between students, faculty, and management is cordial. We aim at supporting students to complete their studies. A student can choose to walk into the office of the academic registrar, the office of the vice chancellor, and ask for whatever service, and they will be welcomed and supported. At MUST, we guarantee uninterrupted education. During the COVID-19 pandemic, we did not stop interacting with our students. We went online and our students studied and completed, graduated on time, and took with them their transcripts and certificates. So we do guarantee that when a student chooses MUST, they will walk away with their academic documents. And finally, why should you choose MUST? We offer an intellectually stimulating learning environment at an affordable cost. Should you choose MUST as your university, we guarantee you success. Succeed, we must. You're welcome. I have the honor to welcome you to Mbarara University of Science and Technology, also known as MUST. At MUST, we believe in success. Our motto being, succeed, we must. Why should you choose to come to MUST? The programs we offer. We offer a wide variety of programs. Health science programs offered under the Faculty of Medicine. Science education offered under the Faculty of Science. Engineering programs offered under the Faculty of Applied Science and Technology. Computing and Information Technology offered under the Faculty of Computing and Informatics. Business and Management Sciences offered under the Faculty of Business and Management Sciences. And interdisciplinary programs offered under the Faculty of Interdisciplinary Studies. Our emphasis as we offer these programs is on community engagement. Our students are trained in the communities where they can get hands-on training and experience real-life settings. Some of the programs in that category are community-based education, research, and service. The other reason why you should come to MUST is we have highly qualified faculty and very friendly. We also have good administrative staff who are key in ensuring that our students complete their programs well. We offer affordable education. Our tuition and fees policies are friendly. The interaction between students, faculty, and management is cordial. We aim at supporting students to complete their studies. A student can choose to walk into the office of the academic registrar, the office of the vice chancellor, and ask for whatever service, and they will be welcomed and supported. At MUST, we guarantee uninterrupted education. During the COVID-19 pandemic, we did not stop interacting with our students. We went online and our students studied and completed, graduated on time, and took with them their transcripts and certificates. So we do guarantee that when a student chooses MUST, they will walk away with their academic documents. And finally, why should you choose MUST? We offer an intellectually stimulating learning environment at an affordable cost. Should you choose MUST as your university, we guarantee you success. Succeed, we must. You're welcome. I have the honor to welcome you to Mbarara University of Science and Technology, also known as MUST. At MUST, we believe in success. Our motto being, succeed, we must. Why should you choose to come to MUST? The programs we offer. We offer a wide variety of programs. health science programs offered under the Faculty of Medicine, science education offered under the Faculty of Science, engineering programs offered under the Faculty of Applied Science and Technology, computing and information technology offered under the Faculty of Computing and Informatics, business and management sciences offered under the Faculty of Business and Management Sciences, and interdisciplinary programs offered under the Faculty of Interdisciplinary Studies. Our emphasis as we offer these programs is on community engagement. Our students are trained in the communities where they can get hands-on training and experience real-life settings. Some of the programs in that category are community-based education, research, and service. The other reason why you should come to MUST is we have highly qualified faculty and very friendly. We also have good administrative staff who are key in ensuring that our students complete their programs well. We offer affordable education. Our tuition and fees policies are friendly. The interaction between students, faculty, and management is cordial. We aim at supporting students to complete their studies. A student can choose to walk into the office of the academic registrar, the office of the vice chancellor, and ask for whatever service, and they will be welcomed and supported. At MUST, we guarantee uninterrupted education. During the COVID-19 pandemic, we did not stop interacting with our students. We went online and our students studied and completed, graduated on time, and took with them their transcripts and certificates. So we do guarantee that when a student chooses MUST, they will walk away with their academic documents. And finally, why should you choose MUST? We offer an intellectually stimulating learning environment at an affordable cost. Should you choose MUST as your university, we guarantee you success. Succeed, we must. You're welcome. I have the honor to welcome you to Mbarara University of Science and Technology, also known as MUST. At MUST, we believe in success. Our motto being, succeed, we must. Why should you choose to come to MUST? The programs we offer. We offer a wide variety of programs. Health science programs offered under the Faculty of Medicine. Science education offered under the Faculty of Science. Engineering programs offered under the Faculty of Applied Science and Technology. Computing and Information Technology offered under the Faculty of Computing and Informatics. Business and Management Sciences offered under the Faculty of Business and Management Sciences, and interdisciplinary programs offered under the Faculty of Interdisciplinary Studies. Our emphasis as we offer these programs is on community engagement. Our students are trained in the communities where they can get hands-on training and experience real-life settings. Some of the programs in that category are community-based education, research, and service. The other reason why you should come to MUST is we have highly qualified faculty and very friendly. We also have good administrative staff who are key in ensuring that our students complete their programs well. We offer affordable education. Our tuition and fees policies are friendly. The interaction between students, faculty, and management is cordial. We aim at supporting students to complete their studies. A student can choose to walk into the office of the academic registrar, the office of the vice chancellor, and ask for whatever service, and they will be welcomed and supported. At MUST, we guarantee uninterrupted education. During the COVID-19 pandemic, we did not stop interacting with our students. We went online and our students studied and completed, graduated on time, and took with them their transcripts and certificates. So we do guarantee that when a student chooses MUST, they will walk away with their academic documents. And finally, why should you choose MUST? We offer an intellectually stimulating learning environment at an affordable cost. Should you choose MUST as your university, we guarantee you success. Succeed, we must. You're welcome.
Define the health of a family. Mommy and daddy, we the youth should close the tap for new infections. No more death in Uganda related to HIV. Together we win as youth in fighting HIV. Together we win as men. Everything we can do. Together we end the scourge of HIV. Together we end the scourge in the whole of Africa. Jenga nchi yetu inaomba afya njema, marafiki tusimame tupiganishe ugonjwa wa ukimwi leo. Naomba tuungane tusaidiane kidole, moja vunje chawa. Naomba tutetee, naomba tujipange, tuwasiliane, kwa mwisho tujiandae, ndio wakati. Hakuna utani. Vision 2030, 1990, yeah. Mother,
turn it low. Yeah, thank you. I would like to, as we're exercising our muscles, the jaw muscles, as we are refilling, refreshing. I hope you're enjoying it. I hope you're liking it. And I'd like to inform you all that our 20-minute break is fast spent. And due to the long lineup that we have ahead, we cannot afford to, wait for everyone. So I want to encourage you to please wind up and resume your seats again. I would like to take this moment and recognize our online presence. We have a lot of people following us online via Zoom. We recognize your dedication to catching up with us through this symposium. We're going to be resuming our session with a joint annual AIDS review, and that will be giving us a report and progress of the JAR 2024 and its undertakings. And then thereafter, we shall have a JAR panel discussion that will be also coming up next. And maybe just a recap from what the previous speakers said. I remember Dr. Peter Sevutinde. He reminded us that in the early days, the HIV was quite really terrible to witness. And I can also confirm to this because currently we are not able to see the very not good images that our professor portrayed of Kaposi. I'm currently finishing my medical school and I've hardly seen any Kaposi sarcoma patient. That is such a milestone that we've taken really significant steps towards combating HIV. And that should only gear us to go to our bigger dreams of ending HIV by 2030. Regardless of such milestone, a number of our presenters have pointed out that currently the young people and the older men stand at a higher risk for getting HIV, and it kind of got me thinking. Dr. Ruth shared that there is quite increased engagement of the people of my age, I will not exclude myself, people of my age in behavior that is termed as risky. And why is that? We've been thinking girls are exchanging themselves or their bodies for as low as 1,000 shillings or a plate of supper. And it is absurd that it is our fathers that are affording or paying that price to pass on the pandemic that we are trying to solve. And as youth, it is really a problem, I think, in one or another, underprivileged, that unlike our Vice Chancellor, who happened to get the visual evidence of Philip Bongole then, who came and showed them what slim disease looks like, currently you barely see that kind of textbook patient of HIV. It's no longer slim. And I'm thinking that has kind of reduced the stigma, the fear that we should have. Currently, the youth, we really feel so energetic, so invisible to HIV. We think it is something that someone can live with. Yes, you can, but it is also undoubted that the impact is quite significant. And I think the lack of fear towards HIV among the youth has kind of increased this prevalence in that risky group. And then, because recently, it beat my understanding, I was talking to some friend of mine, a girl, and discussing. I was intrigued at how she was audible enough to say that she would rather have HIV than being pregnant. I'm sure you've heard that from a few of our fellow young people. But that shows you how much these people maybe do not know the impact of being or living a life as an HIV positive person, but also shows you how much they do not fear HIV. It is also not news to say that I have a number of friends of mine who were adventurous enough to start engaging in different risky behaviors, and our team at Regional Referral, I usually visit them and they give me these oral quicks, different diagnostic tests to just give them to my colleagues. I tell them, you give them to me. I can easily give. They can easily access them from me. And these people, a young man will ably tell you that I cannot test myself for HIV because I know I have it. It's like, hey, So if you have it, why then can't you test? It's like, I would rather live happily and die all of a sudden than knowing I'm HIV positive and I live stressed. But which happiness is there when you know you're not assured of tomorrow? So we really have a lot of work to do in regards to our young people, especially those that have managed to attend this symposium, to portray this message and deliver it to our colleagues, that you can join this movement in terms of combating HIV. I would like to thank all of you for coming and joining in, and also inform you that we have quite a number of events or things that are happening apart from the discussions here. We have a number of screening activities happening on my left at the GCRC tent. Pass by, get tested. The chair lady of Uganda AIDS Commission dictated that all men should test before leaving this symposium, and that is done at the tent on my left under GCRC. We have different health education on teaching you how to use these different self-diagnostic kits. And I forgot to say that HIV, you cannot, nowadays with this improved treatment and care, you cannot diagnose HIV by aesthetics. Nowadays, as a young man, we are filled with prejudice. You look at a girl, she's too beautiful to be positive. And that will be the stop or the end of your taking conscience. So please let us be vigilant. Let us test. In one of our targets, there was 95% of people positive should be aware of their diagnosis. And that can only happen once we embrace this testing kit. So let us test and let us guard your life. Once you're negative, guard that. That is the ultimate prize that you have. Guard it justly. Meanwhile, we are almost resuming. I hope our chair and the co-chair, they are already in the room. We're going to resume our session, which I already said is going to be about the JAR report and progress. If our next presenters are ready, I'm going to ask the chair, Professor Ngozi, and co-chair, Dr. and the co-chair, the executive director, Mbara General Referral Hospital, to resume your seat and invite on the next presenter as we go forward. Otherwise, thank you all for coming, participating. I hope these 3 days become an impactful one. The Professor Ngozi, is and also the co-chair is here, so I will leave the podium to you.
Hello? Hello? Yeah, thank you so much. Members, welcome back from break. As you are aware, we are slightly behind our schedules. Our humble request is that we summarize our break and convene back. But meanwhile, we continue to thank the Uganda AIDS Commission, one, for inviting us, again, for organizing and convening this very, very important meeting. We continue to recognize many distinguished members who are already here. My co-chair, he called himself a local chair, and apparently is locally conducting another local meeting behind the tent. He will join me soon. But I want to be sure that the presenters are near here. Beautiful. Thank you. I have a feeling that we need to start. Dear members, I will request the technical team on podium to be as fast as possible. We don't want to interrupt the most significant and beautiful speech coming here. Otherwise, for people who have never been here, this is Ankole. This is western part of Uganda. And the westerners look like me. Yes. So when you see me, you know you've seen a person from Ankole. Please, don't hesitate. If you move around and you see whoever looks like me, then you know that one comes from Ankole. Yes, dear members, please settle back. Settle back. We don't want to interrupt the upcoming report. It is very, very important for all of us who are here. And we are very sure it will clearly give us a nice way forward. As you've heard before, this has been the habit of Uganda AIDS Commission. Every financial year, they get such kind of joint review meeting. And therefore, today we have an opportunity to listen to the 2025 Joint Annual AIDS Review Report and the progress on 2024 Joint Annual Review undertakings. And this one is going to be presented by one and only Dr. Vincent Bagambe, who is a DPSI, Uganda AIDS Commission. Dear doctor, please, you're welcome on the podium. Thank you. Another clap of hand as he comes. He deserves it. He is smart, he is informed, and is carrying a sweet package. Thank you. Come here, please.
Thank you very much, Session Chair. Before we went for break, I had hoped that I would make this presentation in the presence of the Vice Chancellor. Unfortunately, I've missed the opportunity. And the reason is because when we were starting our careers, hers and mine, we worked together in some certain place. And so I wanted to remind her, but I've missed the opportunity. I think let me ride on the protocol that has already been established and start straight away on the presentation, especially in the interest of time. So I am Dr. Vincent Bagambe, as you heard. I work with the Uganda AIDS Commission as the Director, Planning and Strategic Information. And the presentation that I'm going to make is structured as you can see. I'll give highlights of the process that we go through to compile this report. Then there is a section where I'll give the status of the HIV epidemic as of December 2024, we already have heard about the global picture. So what I'll be giving is the national picture. And then, those of you who have the PFTI report, we also have regional picture highlighted in there. So if you are interested in knowing what's happening in Mbarara, then you can look through the PFTI report. We have one at least on each of the tables, and you'll see that picture. Then I will also take you through the progress by thematic area. And I think the progress against the Presidential Fast Track Initiative goals, you'll be able to see that again in the PFTI report, so that I take you straight to the progress against the undertakings of the PFTI. Sorry, of the commitments that we made last year. So ladies and gentlemen, as the session chair has already indicated, today I have the privilege to represent Uganda AIDS Commission management to present the national annual AIDS, joint AIDS report. How do we compile this report? It's a mixture of approaches and methods. One, we do document review, we do secondary data analysis. And I would say that the reason why we have 2024 data, not 2025, is because before we present that data, we need to do quality check. Because what we have now is program data. And sometimes there are duplications, sometimes there are errors. And before we convert it into a national report, we have to first correct those errors. What we call validation of the meeting, of the reports. So the databases that we used are for 2024. But then we compared with what is coming in now, especially to give us trends, what has been the impact of the executive orders on the services. But also in addition, we conduct a workshop to consult with stakeholders, to engage them so that they can assure us if what we are seeing tallies with what is on the ground, or if we need to review our assumptions. And then we draft the report. After drafting the report, we again call a national meeting, which validates the final report that we are presenting to you today. So what is the status of the HIV in Uganda? Let me start with performance against the cascade. You have heard from the chair and several other presenters that came before me that we are doing well in terms of the 95, 95, 95. The first 95, which is, of course, people testing, people living with HIV, testing and knowing their positive status. Our target as of 2025 was 95%, and we are at 94%. In terms of those who have tested and have started on treatment, we are at 90%. And in terms of those who have started on treatment and have been virally suppressed, we are at 96%. It's actually 96 point something. Now, I want you to focus or to pay attention to when you disaggregate across the ages. So the picture then changes. That for children 0 to 14 years, actually then people who have tested and know their status is no longer 94%, but rather 80%. And then, of course, those who have been started on treatment, out of those who have tested, becomes 91% and 89% viral suppression. You will also see that the other problem we have is among adults, among the men 15 years and above who are actually taking our average low. So what we pick from this slide is that children 0 to 14 years indeed registered a notable improvement in the third 95, because last year they were at the 82%, and now they have improved to 89%. But they continue to lag behind on the first 95. As I pointed out, they are at 80%. In fact, they dropped from last year's record. What about progress in terms of epidemic control? I want to add my voice to that of the chair, who said we should pat ourselves at the back, that we are progressively reducing the burden of HIV. And why do we say so? If you compare where we were in 2010 and where we are right now in 2024, both new HIV infections and AIDS-related deaths have been on the decline. The stagnation or flatlining of people living with HIV is actually an indication that we have succeeded in keeping people alive. Previously, this wasn't the picture, because there were high rates of death. We did not get that plateau. We are getting that plateau because people who are positive are put on treatment, and of course, as the number becomes smaller, then you see that plateau. So the success is that new HIV infections and AIDS-related deaths have reduced. Now, if we look at the impact indicators, and the impact indicators include HIV incidence rate, and we measure this for the age group 15 to 49 years. We look at prevalence, again, in the age group 15 to 49 years. We look at new infections. We look at the HIV-exposed infants who are test positive on both the first DNA test and after 2 months. Sorry, within 2 months, first DNA test within 2 months, and then the AIDS-related death. We note that we have achieved, or to a large extent surpassed, the targets for indicator number 1, incidence. We had targeted that by 2025, the incidence would be at 0.14%, sorry, at 0.2%, and right now we are at 0.14. Similarly, we have surpassed the prevalence. Instead of hitting 5.5, we've surpassed it. We are at 4.9. When you are looking at the prevalence, you would want it to be as low as possible. So we moved from 5.8, wanted to take it to 5.4, 5.5, and we are at 4.9. In terms of new HIV infections, we are reducing, as I said, but unfortunately, we did not hit the target that we had wanted. We had hoped that by 2025, new HIV infections per year would be 18,000 or less. And as you heard, they are 36.6 or 37,000 in the year. And then the other target that we are not able to achieve is the annual AIDS-related death. Instead, again, of 10,000, we registered double the number that we would have wanted to see. So all these targets are what we set in the National Strategic Plan that it has just ended. And we set these targets in 2020. So we are now standing at the end of 2025 to say how did we fare in terms of the targets. We would want to see green everywhere. Allow me now to take you through the performance against the National Strategic Plan objectives and outcomes, specifically looking at the past 1 year. No, specifically looking at the 5 years. And the thematic areas of the strategic plan are prevention, care and treatment, social support and protection, and systems strengthening. Those are the 4 strategic thematic areas of our strategic objective. Now, in terms of prevention, we registered a 61% decline in new HIV infections. To compare ourselves, Uganda, with the rest of the world, UNAIDS set for us a baseline of 2010. So when we look at the new infections, where they were in 2010 and where they are now, we have registered a 61% decrease. Now, for PMTCT coverage, between when we developed the strategic plan and now, we have achieved 95% coverage. What this means is that out of every 100 pregnant mothers who are HIV positive, who in Uganda, 95%, 95 out of 100 are actually receiving PMTCT drugs or antiretroviral drugs to protect their children. And because of that, we see that mother-to-child transmission has reduced significantly to now 6.12%. Voluntary medical male circumcision over the 5 years period, we circumcised over 2,165,000 individuals. Over 800 million condoms were distributed. Pre-exposure prophylaxis was given to over 864 eligible people, and 722 of these were initiated on treatment. And because of this coverage, only 0.9% of those who received this coverage seroconverted. Post-exposure prophylaxis was also given. We gave it to 152,000 individuals, and this represents 87% of the target that we had set. And we initiated on treatment 84,000. And when we protected them with post-exposure prophylaxis, 1.3%, only 1.3% seroconverted. In terms of HIV testing, over 37 million tests were carried out. Remember, we are talking about over a period of 5 years, which means if I tested last year and I test again, those are 2 tests. Don't say, but we have 40 million Ugandans. Where did you get the 37 million to test? So what are the key gaps in prevention? We still have challenges with adolescent girls and young women. Services for packages for these people are only in 50 out of the 146 districts. We also have a gap with pre-exposure prophylaxis, that we have many people who are eligible for this service, but only 3% out of those eligible are actually accessing it. You heard that we distributed 800 million condoms, but this is only 62% of the need. If we are going to use condom use as a preventive tool against HIV, we need to see more condoms and more people who are engaging in risky sexual behaviors using it. And only 57% of the national target for voluntary medical male circumcision was met, while HIV self-testing confirmatory test, people yes, are taking up self-testing, but those who go on to have the confirmatory test are still low. So we think that the opportunities for increasing prevention interventions, access and utilization is to use the assisted partner notification and SNS. If we improve these, we should be able to get, especially people who are vulnerable, testing and starting into care, being enrolled into care. Recency testing is a new technology. We've been talking about new technologies since morning. Recency testing is a new technology that we are using to be able to support targeting so that we know where we are likely to get people who need the service and make sure that they get it in time. And drop-in centers also are very effective and efficient in reaching high-risk populations, as well as total market access, which helps in segmentation, and therefore being able to identify and distribute condoms to where we have gaps. So moving forward, we will be expanding adolescent girls and young women services. As you know, this is one of the services that was largely supported by partners, and in the new sustainability roadmap, we are saying government must take it up and integrate it amongst the already existing government social programs. Of course, improving last mile distribution for condoms, integration of circumcision so that it is conducted alongside other surgical procedures in health facilities, and then strengthening testing for male engagement, strengthening male engagement as a way of improving self-testing and, of course, confirmatory tests. Beyond the health facility, prevention is done in partnership with the key stakeholders. And here you see engagements with cultural institutions to be able to reach young people. We partner with the Buganda Kingdom in the Kabaka's birthday run, in the Masaza Cup, and so many other interventions, which then give an opportunity to the young people who want to listen to their cultural leaders to also listen to the HIV message. And as you know, the Kabaka is the UNAIDS Goodwill Ambassador for, I think, Eastern Central Africa. Yeah, thank you. And then for the Toro Kingdom, similarly, we have been partnering with the Omukama of Toro, and is a strong advocate for HIV prevention as well as gender-based violence. We also partner with the ministries, departments, and agencies. The example I have here is partnering with the judiciary, and the judiciary actually participated in pre-World AIDS Day engagements, and while performing their judiciary health camp, they held a judiciary health camp in Fort Portal, and they were able to deliver HIV prevention messages to the staff that they work with. As well as Ministry of Education, as you very well know, the sexuality education framework has been completed, and we know that with this in place, we'll be able to deliver HIV prevention messages effectively in schools. So that is in regard to HIV prevention. What about care and treatment? We have again scored in this area. We have been able to reduce AIDS-related deaths by 63% since 2010. Remember I said why 2010? Because that is the best year for UNAIDS and all the countries around the world for us to be able to compare and see who is doing well and who is not doing well. But in the last 5 years, this reduction has been by 8%. I have already mentioned about the cascade, but we are also doing well in terms of those who test and are linked to care, 93%. And if you look at those who are like me, 50 years and above, those who come and test, 97% are actually linked into care. In terms of retention, of 12-month retention for those who enrolled on ARVs, it is 79%. So this average needs to be improved. Viral load suppression, we are doing very well. And TB, HIV integration, 93% of HIV, people living with HIV, we are screened for TB. So that is also a good progress. But what are the gaps? As you can see, the first and third 95 in the cascade have not been achieved. The first and second, only the third has been achieved. And also to note that we still have about 230,000 individuals out there who are eligible to start treatment but have not been identified and therefore are not on treatment. That's a huge gap because it means that they are out there infecting, causing transmission. The other gap that befell us was when the executive order was issued, the health workers who were supported by implementing partner programs were affected, and that caused a gap in the care for patients and clients who need HIV services. So moving forward, we look at the following opportunities. We think that differentiated service delivery models, especially at community levels and the drug refill pharmacies, are a good opportunity to ride on. The young people and the adolescent peer support services are also going to help us to make sure that we don't see defaulting or dropping out from care, but also to be able to bring people for testing and put them on treatment. Integration of services, cervical cancer screening, reproductive and health services, reproductive health services, and others, which Ministry of Health has taken on strongly, is also another opportunity that we need to ride on. And then peer-led and community-based art models will really enhance access to services. So moving forward, we are going to expand peer-led and DSDM models and optimize integration of HIV care with other primary health care services, including nutrition, non-communicable diseases, mental health, TB, malaria, and others. The third thematic area is social support and protection. How have we fared in this thematic area? The civil society organizations, culture and FBO organizations have been engaged to ensure that HIV awareness is created, but also they support strongly in fighting stigma and discrimination. So they have participated in many campaigns, including Inokati, Y+, and others, and the beauty pageants. Community-based testing by TASO, Reach Out Mbuya, Mild May, and other partners have also been ongoing and very effective in reaching the people in need, the vulnerable people. And then inclusion of people with disabilities through accessible materials and policies. We were able to continuously develop Braille materials and materials for the deaf to enable them to be able to get HIV messages, which was before that impossible because they had not been provided for. And so the key gaps, we still see high mobility of some high-risk populations, and we need approaches or strategies that will help us to reach and serve this group of people. Disclosure hesitancy is still there among people living with HIV and high-risk populations. We see persistent stigma in the schools, health facilities, and the rural communities. And the older people living with HIV with comorbidities are faced with barriers to comprehensive care. We think that multi-sectoral engagements, especially with faith and cultural institutions, law enforcement organizations, will do a lot in reducing stigma and discrimination. But also use of digital tools to break into the rhythms of the young people. Perhaps the radio stations that we use are not listened to by the young people, but they are on TikTok, they are on their social media platforms, and we think that we are going to continue breaking into that. We also use Candlelight Memorial as an avenue. Sorry, community-led monitoring as an avenue for actionable data. They get us data, real time, but also real people, which then we use for programming. As a way forward, we shall optimize integration of HIV services in social protection, institutionalize stigma monitoring and accountability in schools, sustain investment in digital platforms, and strengthen multi-sectoral partnerships, especially with faith-based organizations, cultural institutions, and law enforcement institutions. Here, again, we show multi-sectoral engagement where we engaged with the human rights to disseminate information in 31 districts and supported them to hold dialogues and mobile legal aid camps conducted in a number of districts to reach out to over 3,000 people. Of course, the Fire Retire Memorial Day is also one of the avenues we use to make sure that we promote human rights and access to justice by people living with HIV. The last thematic area is system strengthening. How did we perform in this area? We have developed a sustainability roadmap, and it's a huge milestone. If you remember, in January this year, when the executive orders were announced, we were thrown into disarray, and it clearly showed that our response is not resilient. So the sustainability roadmap has been developed, charting out, first of all, documenting the strengths and weaknesses of Uganda's HIV response and identifying those strong points and building on them, while at the same time identifying the weak areas and strengthening them so that the response is domestically led. Resources are largely coming from in-country, and we are using in-country systems and structures to deliver services. So the roadmap has just been approved by the Joint Steering Committee, which was chaired by the Honorable Minister for the Presidency, and later in the afternoon, there will be a presentation that gives more highlights into what this roadmap entails. But we have also developed the National Strategic Plan. We shall be distributing copies maybe by end of December. I know that signatures were being obtained so that we have a harmonized way of implementation of our interventions towards our goal of ending AIDS as a public health threat. In addition to that, HIV mainstreaming is ongoing in all ministries, departments, and agencies. Health facilities are well stocked. 75% of the facilities had no stock out, especially for the tracer antiretroviral medicines. And health center 3s, 100% of all the health center 3s have been accredited to offer HIV services. This means that anywhere in the country, if you go to Health Center 3, you'll be able to access HIV services. I talked about district AIDS committees. They are functional, and the networks of people living with HIV, 91% are also active. We also have gaps in this. For example, the human resources for health, only 33% of the positions are filled, and this is according to the new staffing norms. Government funding for the HIV response has remained low at about 15%. What we compiled for this reporting period was 15%, and it has been hovering between 13 to 15%. And yet we had a target that by 2025, 40% of the HIV funding would be from government and in-country partners. Zonal coordination units are not yet operationalized, and many of the civil society organizations don't have the capacity to deliver, to mobilize resources and deliver the services. But I think the big gap was when we received the disruptions in community service delivery, in community delivery systems, which affected most especially the grassroots access to services. The opportunities in this thematic area, we will continue to strengthen linkage. So what we noted was that the DACs, district AIDS committees, and the technical planning committees of the districts were not in sync. They were not well harmonized. So moving forward, we want to strengthen that linkage. Absorption of donor-supported staff into government payroll so that we lift the staffing norms. And then integration. Integration is the way to go. Ministry of Health has taken lead and provided guidelines and trained health workers. And as leaders, we need to support this and importantly make sure that it is done in a quality way so that people receive the quality services and keep in care. Community-led monitoring and civil society organization accreditation will help us to be able to track who is in, who needs support, who needs mentoring, and perhaps if there are resources, how do we apportion those resources? And of course, strengthening private-public partnerships. As a way forward, under system strengthening, we are going to operationalize the pending 7 zonal coordination units. We will ensure that the district AIDS committee outputs are systematically fed into the planning, technical planning committees of the districts and the cities, and strengthen the human resource for health, recruitment, retention, and payroll absorption, especially Ministry of Health and Ministry of Public Service. We will build the capacity of civil society and secure predictable domestic funding for community systems. And as I said, we have a sustainability roadmap. So in the next year and subsequent years, we'll be operationalizing and monitoring if the sustainability roadmap is guiding implementation. For monitoring and evaluation, this is part of systems strengthening. We have a costed M&E work plan. We have been receiving timely reports, and we think that we have improved significantly in data utilization. We also see good alignment between research and what we had anticipated in the research agenda. But we see limited interoperability between health and non-health sector M&E systems, and this is where we need to focus on. Data quality and timeliness of reporting, duplication of reporting from parallel donor and government systems, and fragmented data systems governance, which limit real-time access for research, for financial and other administrative information. So all these gaps is what we think we'll be able to address. Allow me, ladies and gentlemen, to just quickly highlight what we are seeing, and I think the UNAIDS country director hinted on the impact of the executive orders. We are also seeing that it has, based on the data, that it has impacted us. But I need to quickly put a disclaimer that the data we are looking at is not yet validated. It is data that we see in the system, but like I said earlier, for us to start using it, we need to examine it, to get back to those people who generated it, and be sure that the figures we are seeing match with what they had. So we had the executive orders in January 2025, and then soon after received a waiver, but the waiver was for some interventions. In fact, they called them life-saving interventions. But nevertheless, there was a lot of uncertainty, and that caused a shock and a limited access to services initially, but we are beginning to see recovery. So the immediate impact was the shortage of HIV prevention commodities, like condoms, PrEP drugs, and voluntary medical male circumcision kits. The outputs for voluntary medical male circumcision actually declined instantly because most of these services were offered by implementing partners or civil society organizations supported by implementing partners. There was closure of drop-in centers and safe spaces, which caused reduced access to high-risk population-friendly services. And the two medical-assisted therapy centers of Utabika and Mbale were also shut down, which affected access to services by over 800 people who were accessing this service. But now, what are we seeing? And I have picked a few of the indicators. One is the HIV-exposed infants who received the first DNA test. And I compare this, where we were in 2024 and how we are moving in 2025. So you see that in the quarter starting in March, that was following the executive orders, 2025 is the pink color. We noted that fewer tests were done for HIV-exposed infants than the previous year, 2024, which is in blue. Similarly, HIV-exposed infants who started on ART reduced by almost 50%. And this seems to be not to have recovered even as of September 2025. Again, since we know that health workers and staff were some of the people that were affected, we can't tell whether this is the real picture or it is a data issue. But as I said, when we validate the data, we'll be able to tell. So HIV-exposed infant services were affected. In terms of people testing for HIV and receiving results, there was an initial shock, but one can say that we quickly recovered, or we are still on the recovery path. And one can say that this is because maybe of Ministry of Health quickly coming in, and of course HIV testing is easier to integrate than, for example, HIV exposed infant services. And testing, those who tested positive and received their results, there was a reduction. As you can see, it's also recovering, but not as much as the testing. Of course, what this means is that then people who test, some of them go without receiving their results. The third area that we looked at is the impact on HIV treatment. Again, immediately following the shock, we see that the number of people who initiated ART reduced compared to 2024. It reduced by 7,000 in March, and by Q4, it was also less by 6,000 compared to what we had in June 2024. And of course, as you can see, by September, the difference is about 5,000. So again, to say that they don't want to call it raw data, but data that has not been validated is showing us those reductions. The difference is in the number of people currently on ART. There was a slight reduction, but immediately we recovered. And if you compare September of last year and September of this year, the number of people who are on ART has slightly increased. But in March, it had reduced. So this picture shows that maybe we are absorbing the shock. Integration is helping, but we need to relook at this data a little bit more carefully and see if there is something more that we can do, and what else is the data telling us. But there are other services that were impacted by the executive orders, like orphans and vulnerable children. They were largely supported by PEPFAR, and these operations ceased. Sexual and gender-based violence, care for survivors was disrupted, and households faced more severe financial strain due to loss of the free services. I should hasten to also add that the government of Uganda has taken steps to address the shock. That already a supplementary budget was provided to cover especially commodities and the frontline health workers. I already talked about the policy of integration, which with the circular issued by Ministry of Health and training of frontline health workers, but also we developed a sustainability roadmap, which is now at the level of cabinet approval. It is waiting to be presented to cabinet. We are also recommending in the sustainability roadmap that we need more money for health, because we know if there is more money provided for health, then HIV will get a bigger share of that money. And how can this be done? There is need to increase the health budget to 10 to 15% of the GDP. And of course, 15% is the Abuja Declaration target. Right now, it hovers between 5 and 7%. We think the tax base can be expanded by adopting innovative financing approaches. We are told oil money is about to start flowing. We know that we are increasing discovery and extraction of minerals, but we can also use blended financing, and other countries have used debt swap and other approaches. But the low-hanging fruit is the National Health Insurance Scheme. We think it should be, if it is fast-tracked, then some of the packages for HIV care can be embedded in there, and it shoulders the need, the financing need for the response. And then, of course, strengthening private sector participation. So that is that we need more money for health. But also, we think with the money available, we could get more health. And of course, integration is one way of getting more health for money, with the same health worker seeing more patients for HIV and other services. Harmonizing donor funding so that we remove duplications, and allocating 30% of health funds to primary health care and community health, but importantly, boosting efficiency via digital system, procurement systems, diagnostics, and human resource. Last year, at a meeting similar to this, we committed undertakings that we shall be implementing in the year. Allow me now to take you through what the report shows. So under prevention, we disseminated adolescent girls and young women policies and guidelines, especially focusing on risk and vulnerable groups, and we provided tools, peer implementation strategy, and the minimum package for adolescent girls and young women was harmonized. We conducted mentorships on youth-friendly services. We supported districts to set targets for adolescent girls and young women. Advocacy for adolescent girls and young women inclusion in district HIV and AIDS technical working groups were done and are still ongoing. We supervised PrEP, technical guidelines and training materials. We piloted and rolled out pharmacy refill models and expanded PrEP to mental national hospital clinics. Sorry, to maternal and neonatal health clinics and community pharmacies. In terms of care and treatment, we rolled out integrated community differentiated service delivery models across all districts and facilities. We disseminated TB, differentiated service delivery guidelines, integrated TB into community pharmacies and electronic medical record, and rolled out TB HIV mortality surveillance framework. We have also engaged with stakeholders to draft undertakings that will be conducting this year, 2025, up to June 2026. And they are under prevention, expand adolescent girls, young women HIV prevention interventions. Remember, we said we are in 50 districts. We want them expanded to additional high-burden districts to strengthen male engagement in HIV testing and the responsibility centers are as indicated. In terms of care and treatment, optimize integration of HIV care with the non-communicable diseases, TB, maternal health, mental health, nutrition, hepatitis B, cervical cancer screening, and others. Again, Ministry of Health and districts take lead, health facilities, and development partners. Scaling up peer-led and differentiated service delivery models nationwide, Ministry of Health, DHO's office, civil society organizations, and development partners. Social support and protection. Here we will institutionalize stigma monitoring and accountability mechanisms across schools, health facilities, and communities. And the lead here is Uganda AIDS Commission, supported by Ministry of Health, Ministry of Education, civil society organizations, and faith-based organizations. Strengthening multi-sectoral partnerships, including law enforcement, faith-based and cultural institutions. This, again, USC takes lead, Ministry of Local Governments, Ministry of Gender and Labor, Social Development, and Ministry of Public. Strengthening recruitment, retention, and payroll is Ministry of Finance, Ministry of Health, Ministry of Public Service, USC, and Parliament. USC will do the advocacy. Monitoring and evaluation, strengthening subnational reporting and analytical capacity, strengthening MDA reporting and interoperability of data systems, USC, Ministry of Health, but also the MDAs who actually are hosting the data sets. We'll be working with them. So ladies and gentlemen, there is going to be a panel discussion which will, I think, digest this much more and also bring out the risk factors. But I want to thank the chair, USC board, because in her remarks, she really clearly highlighted what are the risk factors in spite of the technology that we have in the country. Why are we seeing more new infections and AIDS-related deaths? So, in conclusion, Uganda has made progress in the fight against HIV. However, we've not yet achieved epidemic control, and the gains we have made are threatened because of the reduced funding, most especially that from the external sources, development partners. However, together, we can protect the gains that we have made so far and make sure that we don't slip back to the years of the 1980s and 1990s when we were in a hopeless and a helpless situation. So let's work together to end AIDS as a public health threat. Thank you very much.
Yeah, thank you. Thank you so much, Dr. Bagambe Vicente, for this extensive, insightful, and very informative presentation. I think it was long enough. That's why we decided it comes after the break. So we thank you, and he deserves another big clap. Yeah, the tent is becoming hot. The beauty, we have a registered and a recognized rainmaker here. So if it becomes too much, we can consult him. He makes a change on the weather. But you have to pass through me. I also take this chance and recognize Dr. Tumusherure Edison. You can stand up for recognition. He is a district health officer in Sinjiro. I do this deliberately because in this congregation is the only gentleman we've exchanged the cows. So I'm proud that he's here. I take this. Dear members, we have little activity standing between us and our lunch. And this activity involves the panelists. So we have our strong technical team. And as I read your name, I request that you come up here and take a seat. We have an expert in HIV/AIDS prevention. That is Dr. Peter Mudiope from Ministry of Health. Yes, sir, you are most welcome. You can take a seat on a podium. We've got an expert in HIV/AIDS care and treatment. That is Dr. Mina Nakauka from the Ministry of Health. Do it again. Yes, yes, thank you. We are missing the cow of Mbarara local government. Is chairing another important meeting back at their headquarters. But we have a technical person for social support and protection, and that is Madame Iruse Oto, Assistant Commissioner, Ministry of Gender, Labor, and Social Development. Let those hands escort her up here. Yes. You know, I told you that this is the only session between us and our lunch. When Uganda AIDS Commission decides to do it, it does it. We've just come from a meal, and soon we are breaking for another meal. It does it passionately. Yes, we have our community systems expert. That is Mr. Julius Muhumuza, a senior counselor from the mighty Tasso Mbarara. Thank you. Yes, I think I would prefer we just take this mic in the order we came in. Our Dr. Bagambe Vincent has really clarified most of the areas. We expect you to use 2 to 5 minutes, just fill in few gaps, and then you settle here. It becomes a true dialogue time. Members have been seated here, synthesizing all these presentations. This is the time for them to really, get involved and question us. But we are very confident that answers will come from you. So for that matter, I will request Dr. Peter to come here and fill the missing gap. Thank you.
Thank you, the MC. In the interest of time, our facilitator is distracted by Dr. Mina. I am thanking you for giving me the opportunity. In the interest of time, I will stand on the protocol, but in the interest of self-care, I will request all of you to stand and stretch a bit. Yeah, stretch. Okay. Thank you. Thank you. You can now sit down. Yeah, I want to thank Dr. Bagambe for dissecting the JAR report. It is usually a very big elephant, which probably many people would be presenting. The task that we have been given is to pick out a key highlights that may have been missed out in the presentation or that require emphasis going forward. and I would start from here. Right from the leadership of this country, our guidance on HIV prevention has not changed. We still have the abstinence, behavior change, and the C. I see most of the time we jump deep and dive into the C before we look at the behavior change. It is still very active. We have made a lot of differentiations in what we call it. We had the, I think, sexuality education framework, which has now been changed to life skills education for young girls. And as Dr. Vincent said, this is under, they are signing it off, and it will be launched, I think, before the end of this year. So the A is still very active. Let's not go away and throw away the A. The abstinence is going to be, or it has been prioritized in the life skills education framework, which was the sexuality education framework. We have changed a bit to make sure that we accommodate everybody. So that is the first thing to note. The behavior change has been talked about, and the condoms. We are not doing very well on condom use. You all know that most of you here who are above 40 years, 45, you are alive because of the condom. When you are in university, when you are in your youthful stages, the condom saved you. If there is anybody who was saved by a condom, can clap. Yes. Most of you, I know you've been saved by a condom, somewhere in one way or the other. But when you look at the data, we are still at 61% coverage as presented in the JAR. So we still have a lot to do in the condom. We are rebranding. We are getting in new condoms. But I know most of you can afford to buy a condom. There has been a condom man. Where is the condom man? I've seen a condom man moving around. This is all we need to do. We need to go back to that kind of campaign and put the condom on the forefront. It is one which has the highest percentage of prevention, more than all the other prevention intervention. If you use it, you are over 95%, over 97% sure that using it correctly and consistently, you will not get HIV/AIDS. So we are rebranding. Some people have given us feedback that the condom we have, there is fatigue, they are tired, it smells, the sizes are not enough. Some of them are really stigma, but we are rebranding and working on that. Very soon in January, you will see very good condoms. The HIV testing services we have had, the access has been a challenge. We had initially, some 2-3 years ago, changed our reprogramming for HIV testing and looking at testing for diagnosis. But of recent, now from the new evidence, we are testing for both diagnosis, but also for your protection. When you are negative, we have enough options to refer you and access those services. So we have increased the platform of our testing options, which have been mentioned. The self-testing, which is very, very available now. And we have, actually this morning, I saw an email coming up from the medical stores. We have so many test kits, HIV self-testing kits, that are available in the stores. And the focal person at the ministry was saying people should pick them, and has written out to the different stakeholders. So self-testing for those who are stigmatized and those who want to get testing in their comfort, privacy, is still available and promoted. We have the APN, or Assisted Partner Notification, which goes hand in hand with index testing, is still also very, very available, and we are promoting it. And this one has yielded so many, actually the percentage yield is ranging from around 8 to around 13% compared to our user testing, which has been yielding around 2.7%. So when we reach you out and give you a call that you've been exposed to HIV/AIDS, don't hesitate to come and test. I forgot something. Actually, all of you on your tables, you have a small handbook on the PFTI. Do you have it there? Do you have the handbook read? Please, you can. That handbook is very important. It contains all the information you need, and at the end of it, there is a call to action. At the end of that book, there is a call to action. I know we have a very not so good reading culture, but please read it. The PMTCT, we have had our transmission rate to the babies is still high at 6.1, although the new infections are stagnated at around 4,700 over some years. We really need to work hard to bring down that infection. We are prioritizing the young girls, adolescent girls and young women, where we are seeing that most of the new infections are coming from. And we are giving them a package of group antenatal, and they can support each other. But this is not enough. We are also giving them a package for PrEP. We are prioritizing them for PrEP. And as Vincent presented, and our guest speaker, we are expanding our options for PrEP coming January 2025. We have gotten some doses for the new innovations or options, that is the long-acting injectable PrEP, injectable LEN. We shall have around 35,000 doses. That is 70 doses, 35,000 individuals that will access LEN come starting January 2026. All we shall need is to have a very good communication plan such that the people who access it are fit to access it. Because when this was announced, and I saw in the room when Professor Pauline was presenting, there was a lot of excitement because this is a drug or an injection which in the research, it was 100% or zero new infections. So when that news comes out and in Uganda it's not there, everybody will push us. But I'm telling you, we have had this before in our interventions. People push us, a lot of advocacy. But when we start the real implementation, people will shy away. So we need a very good communication plan that we are going to use. I have very limited minutes. Yes, I've talked about PrEP. VMMC was a vertical program almost supported 100%. And this now has been deprioritized by the donor who was supporting almost 95%. So to move from the current 57% coverage to the desired 80 or target, we need to integrate. And this is supposed to happen. Lastly, AGYW in our undertaking was mentioned as something that we are going to expand. At the ministry or within the country, we are working with Uganda AIDS Commission, the Ministry of Education, Ministry of Gender, and we have developed a country-owned VMMC rollout framework, whereby we are moving away from the previous donor structures, the CSOs mainly, and we are going to use government structures through the schools, through the community development officers, and through our health units. Ladies and gentlemen, thank you for listening to me.
Yeah, thank you. Thank you so much, Dr. Modiope Peter, for using exactly 5 minutes. I'm very sure Dr. Mina Nakauka will beat you at that. So for that matter, I request you to come up here. Thank you.
Thank you very much. I hope I do. Knowing I talk slowly, please do not doze, do not go to sleep. But Dr. Bagambe clearly spelled out the issues around care and treatment. And before I even begin to talk about whether he was right or wrong, of course, he was right. I need to say that as I start to talk, I wish community could listen, because in care and treatment, this is where I need you more than ever. Looking at our second 90 and third 90, it looks okay at 90. But when we go down, our issues are with the children and adolescents. And these are the population that is still supported by the caregivers and by the peers. And these people, some of them could be expert clients, but more so, they are the community members. So, community, when it comes to looking for the children and adolescent, I'll go back to the community. And with the treatment, I would say that for the children, we are doing our best. We have rolled out an easy medication for them. In fact, right now, it's in all facilities, but that is not enough. In the community, we need to work with the VHTs, with the expert clients, with the mentors, with the peers, to make sure that we know where the adolescents are. Let us face it, when it comes to adolescents, they are hormones. There's disagreement, miscommunication between the caregivers and them. So we need community on board. But for community to help us, we need treatment literacy. And that is what we are trying to do, and to roll it out further, because they need to understand where we want them to report, to work with us. So treatment literacy is key, both at the facility and the community. And then the strengthening of adolescent-friendly services, because it is one thing to be children, and we are trying as much as possible, but the transitioning also has its issues, and that's where we need to all work together. And we think that when we strengthen that, and education here is very key, because much as we think that our adolescents in the community having it, or they are being hit hard, the ones in schools are really hit hard. So we know that there we will work together. That said, we know we have integrated our services, and it is a way to go for us to be able to look at our recipient of care as a person rather than a disease. So integration of management is key. But most importantly, as we integrate, we are ensuring that we do not lose the quality of care. So we love to integrate, but we should not be, or we should be mindful that we need to provide quality of care that is patient-centered. So that calls for still bringing in the recipient of care to tell us what is the best modality for their service delivery. More than ever, facility, they are now wanting to move to the community. And we are strengthening the community approaches, the peer-led, the health worker assisted, as well as the pharmacy models. Now, as we are excitedly doing all that and giving the multi-month, where we give them 3, at most 6 months, we have to be also mindful of the fact that we need to monitor them to come back so that we decrease our AIDS-related deaths. One, we make sure that we monitor them and they are doing well on treatment, but also to note that most of our recipients of care are aging. So they're not really dying of HIV or AIDS, but the other, like the NCDs. And I would say that among our patients, 26% are hypertensive. So we are looking at making sure we screen them at the facility as well as in the community. So community, there's a lot you can do for us, and that is why our treatment literacy has all that in it. Now, we know that every year we talk about stigma and discrimination, but we have to find a way around it because we have got to achieve our epidemic control. So we need to work together to make sure that we address our stigma and discrimination, because one, it's leading to delayed diagnosis. People are not coming out, and they are coming out late with advanced disease. We are saying that we have limited human resource, but how can we make sure that we strengthen the human resource we have that provides integrated care? Because generally, we have issues with human resource, even when there are plans to absorb the 29,000 that was laid off. But we still have to find ways of how best are we going to work together. We need to provide psychosocial support. That one I cannot underscore. Because when we look at our recipients of care, 36% have mental health issues. They are not mentally disturbed, but there are issues we can address and actually improve more our viral suppression. That said, we know that the funding is decreasing, so we have to brace ourselves. I do remember in the early 90s, yes, I was still in school, but I do remember the strong community engagement, because we didn't have a lot of funding then, but we had community engagement. I do wish we could go back and harness that, hoping that it is not too late, and make sure that we address the issues at least of psychosocial support that will probably address our poor adherence, non-disclosure, treatment fatigue. Some of them have been on treatment for more than 25 years. They are tired, but how do we strengthen? That said, there's a lot I could say, but we are looking at making sure that we give the best treatment as much as possible, and we make sure that we monitor them well. Dr. Bagambe, you did a good job, so allow me to stop here for now, and thank you very much for listening.
Yeah, you've made it. Thank you so much, Dr. Mina Nakauka, for that elaborate explanation. I think we are doing well. And for now, I would request the Madam Commissioner to come here and you commission the social support and protection. Please come here.
Thank you. Good afternoon, everyone. I'm going to focus my discussion on social support and protection for people living with HIV/AIDS. Globally, we all know that resources are dwindling, for HIV response and is giving stress to the entire country, including people with HIV/AIDS. Under this thematic area, what is important that we need to emphasize is reduction of vulnerability of people with HIV/AIDS and increasing social support. We are looking at a balanced scale where we increase support for people with HIV/AIDS so that we reduce on the vulnerability status. From the presentation of Dr. Bagambe, we did not score very well in the following areas. Under outcome number 1, on stigma reduction, we made a slight improvement from 66.8 to 74%, which is still below NSP of 80%. That means our people are still suffering in relation to stigma and discrimination. We need to put more efforts at children in school. We tend to focus more on targeting the children at school, forgetting to target their parents at home where they come from. So we need to sustain that at community level, at family level, and at school level. We have just emphasized that economic support is very important to improve the livelihood of people living with HIV/AIDS. We are still not scoring also very well. We are scoring at 51%. There's a slight reduction, increment, versus 70% according to the NSP. So this still needs more efforts on our side. On reduction of GBV and discrimination, most of the GBV cases are reported by women, so we need to step up reporting and handling of GBV cases among men. We need to promote male involvement at all levels, at national, at district, and community levels. On output under child protection and reducing violence against children, we are still encouraging the use of multi-sectoral approach so that we have Ministry of Health, Ministry of Gender, Ministry of Education, Judiciary, TASO, etc. We want to promote life skills so that the young people are able to take care of themselves with or without the presence of an adult caregiver. We also want to strengthen support, parent support on guidance and promoting positive behavior. We want to reduce on new HIV infections. We want to reduce on child marriage and teenage pregnancy. And we also want to increase on enrollment, retention, and to reduce on school dropout. Under legal and the policy framework, we are concerned that the number of cases prosecuted under malicious infection with HIV/AIDS is not coming out very clearly. So we need to bring judiciary on board so that we take a second look at this, so that we make a tangible score in the next reporting. Under institutional strengthening, we have brought on board and full-time. On top of the multi-sectoral team, we have brought on board the cultural and the religious institutions who are the gatekeepers of culture and who contribute a lot to mindset change pillar. We need to take this lower by promoting parent involvement at all levels so that people living with HIV/AIDS are covered from home like the children from school, and as they come back to the community, they get a safe environment that will promote their survival. Of course, not forgetting what we have already focused on as a country, on institutional strengthening, using multi-sectoral approach, capacity building, financial strategy, effective government and non-governmental organizations, promoting leadership, improving service delivery, addressing structural barriers, working with the cultural and religious institutions and other community-based organizations, and strengthening the family and parent support. Thank you so much.
Thank you. Thank you so much, Assistant Commissioner. Before we invite the last speaker for this session, can we clap again for these people? That's a handy exercise for us. So the last presenter is our friend, the neighbor of Mbara University of Science and Technology. He is a common visitor of Mbara Regional Referral Hospital. We respect you, sir. And that is other than Mr. Julius Muhumuza from Tasso Mbarara. Please come here and make presentation on community systems. You are most welcome, sir.
Yes, thank you. Good afternoon, ladies and gentlemen. Yeah, and I am here to talk about the community involvement and then the community system strengthening. I want to begin like this. Science has enabled us to come up with good innovations, but with a target. Any innovation that we make is targeting a particular group of people or groups of people. But these innovations are developed from former offices, but we aim to have them reach out to communities, and these are different communities. So, running a successful intervention requires understanding each individual we serve, and then we dwell on that individual to be able to associate ourselves with the community where the individual comes from. And that's when we can be able to have our services tailored to the communities based on the community's interests and needs. So, when we have the interventions, or when we have identified the communities, then of course we need to build the capacities of the communities to be able to have, to contribute effectively to our programs so that we can have good results, good impact, and then good outcomes. So, with HIV having so many challenges that are social, economic, and many others in nature, so we need to understand the communities very well so that we can be able to deliver directly to the people that are having challenges. How do we do this? You begin with the individual who comes in for the service, then the individual links you to the community where he or she comes from. Then you look at the needs of the community in relation to the service that you wish to deliver. And then after that, you identify individuals that would help you in effectively delivering a service to such a community. You build their capacities by training, to equip them with the necessary skills, and where possible, you also provide them with resources so that they can also be able to implement their activities and manage their systems very well. So this is what we say, or what we call system strengthening. And when you have already built the systems, then you are able to effectively mobilize. You are able to effectively implement the programs. You are able to monitor and evaluate the programs, but you're also able to improve on the programs by looking at what is failing to work out, and also coming out with what is able, or what can enable you deliver successfully to the community, the targeted community. So, then, with a very effective community system, you are also able to collaborate with other partners, because you can't be one man providing each and everything in the process. So you are able to link, to refer, and also to receive as well from other referral systems as well. So that will lead to a successful implementation of different programs to address social and health challenges. So when we are doing the system strengthening, also what we have to bear in mind is also to create an enabling environment which includes so many key players. Because for an organization or a local organization or an organized community to deliver on the mandate, there must be an enabling environment. So that is the policy and the legal framework and social challenges must be addressed. So that the system is not interfered in the process of delivering services. So with a very strong and strengthened community systems, then we are able to deliver on our mandates, and we are able to receive results at a lesser cost, but also in the desired time. And that's what I can say. I thank you.
Yeah. Thank you so much, Mr. Muhumuza. This service, of course, I told you, I'd warned you about it. It has come at a free cost. Don't get scared. It is given in doses. And we expect more in case we need it. Now, time has come. The chief MC, my boss, Doctor, I hope lunch is about to get ready. Beautiful. That's okay, he's checking. I love him. Na nchiza sente muchize bizibu. But he remains my friend. This is time now for the congregation. This is time for us to ask questions to these giants who are here. So request, beautiful. Yes. Yes. Good hands are already up. Yes, my roommate, please follow this direction. I love that man. We shared a lot as undergraduates. He was always short but strong. I looked tall but thin and weak. He protected me. Please, you'll make the choice. I don't know how you'll do it, so that questions are fired. And we can receive the first 5 questions. Then we take care of them. Again, receive more. Can we go in that order? Thank you.
Thank you very much, moderator. My name is Karieja Benon. I'm the district chairperson in Mitoma. Mr. Facilitator and the presenters there, mine is not a question. But when I look at our concern, is to end HIV/AIDS. To end AIDS here. Now, to me, there are very many redundant cadres. And when I portion them, I may find we may be able to do a commendable job. Number one, when we look at our villages in Uganda, each village has got 10 leaders. You go to parish, 10 leaders. You go to the sub-county, there are around 16 leaders. You go to district, we are just a minimum of 30 leaders. You go to the country, we have 500 and almost 57 members of parliament. You go to the municipalities and cities, leaders are there. I'm talking about cadres who can help us on this phenomenon. Now, when you come to civil servants, the staff, Mzee has been saying they are around 500,000 people in the civil service. And when you come to the boards and the commissions of this country, and even advisors, there are so many. And when you come to religious leaders who have the greatest following, even commanding more than we do, they are there in the system. Now, what is the problem? While we are looking at the gains, I hear everyone talking about gains. I hear the gains are satisfied desires that have been achieved. But then, under here, we need to look at unmet desires, which are the pains now. Therefore, when we come to the pains, why is it that we are not becoming successful? Yesterday, we were having some statistics from my brother here, Dr. Watiti, and Hope in Bushenyi. But the challenge is here and there. We have free airtime on radio, members who are here, of government. And you find when you are talking about health worker to go there to talk to the people, the challenge we have is the facilitation syndrome. I cannot go to the radio because I don't have facilitation. Our radios are being used. I use this word, whoever is affected, I'm not worried. Quack, health workers, from morning to evening. Even they are selling some soft drinks and kombucha drinks, where they say even some can help to cure cancer, hepatitis, hypertension, and others. Now, me, I'm ending my submission, saying, why is it that this AIDS is not ending very soon? Those who studied history, the slave trade, it was not easy to end it because the African chiefs were gaining money from those people who are coming to buy slaves. Therefore, they could not participate. So once we eradicate the issue of facilitation syndrome and we go full blast, we shall be able to succeed. That is my submission.
Thank you, Chair. Besigensa Alfred is my name. I have a few questions to our presenters. Thank you for the presentation, our director. And my first question goes to you. You coordinate multi-sector approach in controlling this epidemic. Have you ever evaluated the performance of each sector? Do you know their contribution to ending this AIDS in Uganda? because we may think that we have multi-sector approach when others are not doing anything, and we are there saying multi-sector approach, yet we don't know what they are doing. Secondly, to my friend Mudiope, you have really talked about these things and you are an expert for the time I have known you. We've seen partners pushing out from the drivers of the epidemic. And you know, even our colleagues have said, in the cities we have the high prevalence. We know why we have high prevalences in cities. And we have reduced our visibility because most of the interventions were being managed by partners. As a ministry, what do we have to address that if we are not going to see a rise in the new HIV infection? Thirdly, to my Dr. Nakauka, you've talked about care and treatment, and I've also been in care and treatment for the last almost 20 years, and I am passionate about seeing very many people getting treatment, but we've seen also clients getting lost, and one of the areas that was being supported by partners. And if we are to have viral suppression, we need to keep our patients in care. So which modalities should we use, or which modalities do we have to address that so that we keep retention of our clients to 100%? Finally, to our Assistant Commissioner, I have two questions, or three. You have talked about psychosocial support, which is a very good strategy. But I would like to know where the Ministry of Labor and Social Development works with other ministries. One, to address gender-based violence as a driver for HIV transmission, because we see most girls getting pregnant early because of the gender-based violence in their homes, but also we see a lot of teenage pregnancy, and yet we would also see interventions the ministry is putting forward to address that, which would be very, very important. And also, I would like to hear the social support that is available for the key drivers of this epidemic, because we know they are there, and we need to really support them to see if we can address that. Thank you very much.
Thank you, panelists. Edward Bitarakwate from Elizabeth Glazer, Pediatric AIDS Foundation. My question is going to cut across, but it will start on the gender side. I'm so happy to see Ministry of Gender, Labor and Social Development here. HIV is a social problem, in as much as it's medical. But my question goes to everyone, all the experts there. We've all seen that the pediatric and adolescent group hasn't recovered as much as the adult population, either in terms of newly enrolled on ART or for retention. We've also heard that a lot of this is because of the breakdown in psychosocial support for the younger individuals. There are no YAPs, peer educators, and all that social support group and community seems to have fallen apart, yet it's the bedrock of African society. So my question goes to the programming between gender and health, not repeating question about how you work together. What do we need to do to build self-efficacy into the preparation of young people as they transition from the pediatric and adolescent clinics to the adult clinics? We've seen a dependency on that nice care they've received. When it dropped, everything crumbled. So should we be building our programming around self-efficacy? How do we help them take care of themselves? We've seen it happening in SRH for some of the programs. But what's on our minds about this if we are to sustain the gains and have hit our goals for 2030. Thank you.
Chair, it's not a question. Should I apply the gender thing? Gender? 3 men, 3 gentlemen. Can I go to 2 ladies?
Come again.
Should
Come.
I give the mic to the ladies?
Yes, I agree with you.
Okay.
So that we get this mix.
Good afternoon, ladies and gentlemen. I'm not speaking because I'm a lady. I'm speaking because I have worked 25 years on traditional medicine. My name is Engineer Anke Weisheit. I'm one of the co-founders of Farm Biotrack, Pharmaceutical, Biotechnology and Traditional Medicine Center. My director is just behind me, Dr. Carsten Bartolo. He's a director. Now, we have very positive outcome of a research where we integrate traditional medicine into ARV-based treatment and management of HIV. Now, the outcomes are very positive. My question is to all of you, how is the status of integrating traditional medicine and indigenous foods as to strengthen the ARV management of HIV/AIDS? It's very important to integrate indigenous knowledge and practice into the HIV management, not only ARV or drug-related activities. Now, I'm requesting, we have here different stakeholders, I'm requesting that we continue to be supported to get more research, product development, ideas, community outreach on the integration of traditional medicine, indigenous foods and vegetables to support the HIV eradication in Uganda. We have stakeholders like donor community. We have MOU, Minister of Health. We have Commissioner. We have other technical and financial people. Please support our work, and we support you to eradicate HIV. Maybe not by 2030 is a bit short, but we are working on it. Thank you very much.
Thank you very much, the panelists and the organizers of this conference. I am Flavia Chomkam and I work for the National Forum of People Living with HIV. And I'm glad to start on the last note from Tasso about community system strengthening. And for me, whatever we are doing is and should be hinged on community systems, but particularly individuals living with and affected by HIV. And as this HIV research is founded on that premise, I just, I'm thinking the issue of ensuring we sustain the gains following the funding cuts rotates now more about targeting the recipients of care. We know that we have a very high loss to follow up, and Dr. Mina has talked about it, and I think in the morning it was also reiterated. We have about 200,000 loss to follow up. And what does that mean? It means that people who have been on treatment have actually withdrawn from care. And the implications are that there will be advanced HIV disease. And the people who are presenting with advanced HIV disease are not people who are newly diagnosed. They are people who have been on treatment but have retracted from the services. And I do know that integration and much of what we are doing is going to be another factor that is going to increase the loss to follow up. The other critical factor we need to look at now, and I think we need to very much, as implementing partners, support the interventions around non-suppression. We have about 60,000 non-suppressed as of April this year. And that is before we get any annual report to understand how many more are non-suppressed. And the final one I would like to talk about is that of the 1.5 million people who live with HIV, only 1.3 are in care. Therefore, we still have the 200,000 who are still not in care, who could have been brought into care, but have been curtailed, and the barrier is the resources. And the other factor I would like to talk about is that we, as people living with HIV, we are not just people, we are public servants, unrecognized, invisible, and counted. And I think the funding grants from the USG has indicated the importance of community public service. We volunteered, we have worked over the years. We have volunteered to bring people out of their shells. We have held them by the hands, provided psychosocial support, provided treatment literacy. We have also provided adherence support. We have also ensured that we monitor the quality of services. We have also been able to do community-led monitoring to see what is happening, what are voices of community doing, which we understand the government is trying to do through some of the satisfaction surveys, but we all know that they have weaknesses and barriers. How do we ensure that going forward, in the spirit of greater involvement of communities that we have sung over the last number of years, that this community of people with HIV, the structures that have been built over the last 30, 40 years are not dismantled, are not erased because a donor decided to pull out. I do understand we have been doing a lot of engagements with the Uganda AIDS Commission, Ministry of Health. We have even petitioned the Parliament. But for a year, we have not had resources to even just go and educate the communities about integration, the recipients of care, the benefits they would get from understanding integration. We have been broken over the year. We have been disrupted. We have been emotionally drained. First, by the cuts. The second time was when we had the circular that TB, HIV clinics were closing. And then we saw reprogramming by the Global Fund, and we continue to see no resources coming deliberately to our networks, to our support groups. And as we speak now, the Secretariat of the National Forum is internally displaced and hosted by the Uganda AIDS Commission. We don't have a home. We have to work on air, which you all know is very difficult. We need an office. And we can only coordinate if we have an office. But we can also coordinate if we are together. And you know, team building requires that we are in spaces. Our national networks, to mention, the UNERELA for religious leaders living with HIV, the Positive Men's Union, the Uganda Young Positives, the Support on AIDS and Life, they have been demobilized. How do we support to ensure that the gains are sustained? And suffice to note that we as a people living with HIV would like to be involved and recognized and participate and share our experiences because we are experts. We are experts in this. And these 2 weeks are because we are. We are here because we are. And we would like to see a little bit more recognition, a little bit more participation, a little bit more support. For instance, here, we are only 4 PLHIV who stood up there, but the region has district forums. I would wish to see more representation from the regional networks. And I'm imploring the IPs in the region, is it possible that we try to be more innovative and creative, particularly around these days that rotate around HIV, where we are big stakeholders? And finally, I would like to say, for the morning session, we didn't have an opportunity to speak. But I'd like to say that in light of research, we are the bodies that the research is rotating about. We are the guinea pigs. I would give you an example. In 1994, I'm one of those first ones who was experimented on by prevention of mother-to-child transmission, A. When we would get the ARV, you go into labor and you deliver, and that was it. And we informed this government and researchers that you can not only think about protecting a baby without protecting the mother. And we moved from prevention of mother-to-child transmission A to A+, and we have moved up to B+. In the same 1994, when I discovered I was HIV positive, I was one of those guinea pigs who were on the oral treatment of oral research for TB treatment, isoniazid rifampicin. I'm one of those who were on that project that has led to groundbreaking innovation that we see in use. Because at that time, people were being injected 60 injections, streptomycin, and we were the ones to initiate. We adhered, and we had groundbreaking science saying we can have treatment for TB, which is oral. In the year 2003, we had the development of antiretroviral treatment. I'm one of those who were on that program. For 8 years, we gave our blood. Every 3 months, it was collected. Every 3 months, we came and we shared and we supported and we were supported. You learned from us, you the professors. But we also gave you a source of your careers, a source of your program, a source of growth. And we also got health. And the DAT has worked. The tenofovir, the zidovudine, we used to live today. And as we speak now, groundbreaking research has happened for lenacapavir. And it is us, the communities, who have been tested on. And lenacapavir is not only coming for prevention. It was first tested for HIV positives as a treatment for HIV positives. But it later on, they said we have already other drugs, let us use this for prevention. Even for oral PrEP, it is the communities that have been mobilizing, that have been supporting. So we would love as much as possible, even when we look like we are invisible, to be part of this programming, because whatever we are doing is because we are. And I'm saying this because without funding to our networks, to our forums, to our expert patients, about 8,400 who were demobilized with the funding cuts. We are not seeing mentor mothers holding hands of mothers. You are talking about vertical transmission. Of my 6 children, 1 was born with HIV. Unfortunately, he passed on with cancer in 2016. 2016, yes. But we've been on research. Our children have been on research. We are the research. We are the involvement you are looking for. Is it possible that we work together? That we target the laws, Madam Commissioner? We have defilement. And I think from the annual police crime report, about 11,000 annually. And last year, we are reported as cases. And of these, maybe only 3% reached conclusion, were reported, but it also relates to the annual national report on new infections. Uganda AIDS Commission has shared this fact sheet. 37,000 people were infected last year. And of these 14,000 are adolescents and young people. And of these 14,000, 11,000 are our daughters who were born free, have been infected along the way. But also it's very unfortunate that we still see mothers bearing 4,700 new infections. And when the funding is cut, no one is coming directly to us as a people living. How do we work at this time to ensure that we reach these communities? I'm not lamenting. I'm only saying that as we program, as we make policies, as we budget, the invisible cannot count if they are not counted. If the voice is not listened to, then we are just like this water running is what we're going to see. But I want to thank you for this event, and I want to thank you for allowing me to speak, but I also want us to reflect on what the HIV response will be like after the report for this year. I want to thank you.
For now. Yeah, thank you so much. Thank you so much, members, for the questions. And I'm sure the panelists have been sieving through whatever concerns each individual. And again, I want to believe that the tent is a bit cool now. The dust has been disturbing us, but stay calm. The water will come slowly, gets you where you are seated, and will force the dust to settle down. I'm very sure. Just stay calm. Before we get the answers, I take the honor and the chance to announce the presence of our city mayor, Mr. You allow me use that, Mr. Kachevezi Robert. Thank you. Thank you so much for honoring our invitation. We clearly know that this is a hard time for you because you are trying to secure your future. So I'm happy that you're here. I take this same honor to welcome our friend, the very Reverend Bobs. Please stand up for recognition. Thank you. This is one of our own. We clearly know your schedules, you have tight programs, but you've endeavored to reach here. You came with a gentleman, a reverend. I'm sorry I haven't got the names, but humbly I request that you stand and we recognize your presence. Thank you. Thank you for coming. And again, I want to assure you that the church and other religions have been represented by the same reverend in front of you. He has been with us here from our All Saints. We had an opening prayer, and consistently is here. He hasn't even taken any step out of this place. I don't know how he manages it, but most of us, we've been in different corners to make ourselves comfortable. Now, how do we answer this? We start from the extreme corner. Which order? Guide me. Okay, so we start from Assistant Commissioner. Beautiful, thank you. Yes, if you have any question that came to you, please answer it.
Thank you. I'll start with the question on gender-based violence and psychosocial support. The Ministry of Gender, Labor and Social Development has the whole department for gender and women affairs. That department is the one that works with the Department of Culture and Family Affairs, the Department of Youth and Children, Equity and Rights, and Community Development and Literacy on issues of GBV. Apart from the general roles of developing policies, guidelines, standards, and regulations, the Ministry of Gender has a multi-sectoral team at national level that oversees GBV issues with Ministry of Health, Ministry of Education, Judiciary, and TASO. TASO is a key player as well. We have the National GBV database at Ministry of Gender, and information is fed from the districts. We also have the Child Helpline that still contributes information to the National GBV database. The working group meets on a quarterly basis with other partners, including the UN. At the district level, we have the Community-Based Services Department, who works with the Uganda Police GBV desk and Police Child and Family Protection Units on cases of gender-based violence. At sub-county level, we have the CDOs, the Community Development Officers, whose cardinal role is to prevent and respond to GBV. At the lower level, we have parasocial workers, we have the GBV champions, and we have the male action groups. And we have the cultural and religious leaders. We have also the LC system with a clear GBV referral pathway. Every district has a GBV referral pathway, and we have clear standard operating procedures on how to handle GBV cases. The challenge is, it is very difficult to handle GBV cases because at times the very survivor who reported the case can decide to withdraw it for a number of reasons, like harassment from the family level. From nowhere, when the case is already filed, they can withdraw it at some point. Some cases are negotiated. Some cases are tampered with by the very parents who should take care of the children under the GBV cases. These are the same channels we use for providing psycho-social support. The multi-sectoralness is very important because when you look at the service points at community level, we have the structures I've given you. A patient may not get all the services at the health facility. That is why we have the community entry point, we have the health facility entry point, we have the district and other community-based structures. None of us, even Ministry of Health, cannot do it alone. Because when we look at prosecuting cases of GBV, which I hinted on earlier on, under that multi-sectoral cooperation, we have realized there is a gap with the judiciary that we need to sit and iron out what could be the challenge. I've already told you about some of the challenges. Some cases are reported, some are not reported, some cases are withdrawn. That is beyond the prosecution. So let us sit and see what else can we do in order for us to maybe increase on prosecution of sexual violence cases to deter other people from committing the same. As I sit down, I still emphasize on the importance of us using the multi-sectoral approach because each ministry has its own mandate. At times the mandate can spill over, but still, when you look at the mandate of Ministry of Gender is social protection, and at the end of it all, we focus more on the community and the out of school. We can come in to support the in-school because when you look at the child, for example, comes from home, he needs the parent, goes to school and still comes back home to the what? To the parent and the community. That is why we can at times have a spillover. We cannot intervene in the mandate of the Ministry of Health because that is not our mandate. The judiciary has its own mandate, so we only need to work together so that we fill the gaps where your mandate stops or where your mandate ends. I stop here for now.
Yeah, thank you. Thank you so much, Assistant Commissioner. As we agreed, straight away welcome Dr. Mina Nakauka here. Thank you.
Thank you very much. And clients are getting lost. Which modalities do we have in place to retain clients in care? I just need to say one thing that we have realized. Whereas we think that many clients are getting lost, some of them are not actually getting lost, but they are probably transferring themselves, number one. So one of the things that we have to do is to make sure that we will improve the way we record our data. And it is something that we are working on because it has something to do with the recipients of care's identifiers. That is when we'll be able to know that, you know what, they're actually not out of care. They just transferred. But that said, we are looking at the fact that with the integration of services, there are some DSD approaches, differentiated service delivery approaches, that initially were not so much taken up because the facility was easier. But now we are looking at different approaches of community, either peer-led approaches for service delivery in the community or the pharmacy model. And that way we've actually realized they are not getting lost. We also are trying to roll out or scale up the community integrated model, delivery model. And when I came up the first time, I said, now more than ever, we need to work with the community. And it cannot be underscored, because I just might not have the transport to get to the facility, to get to the community. I might have airtime, 200 shillings, 300, to talk to my community health workers and the peers. And we are working around mapping where our recipients of care are, or where are our patients that actually need that integrated care, and then seeing how we connect them to the patients that need the care. It is work in progress, and where we have started, it is working. And sometimes we usually say that it is your life, it is your care, take care of yourself. But we are doing that extra mile of saying, as you're taking care of yourself, we borrowed something from TB, and we are saying that we can do it beyond HIV, beyond the patients that sometimes have treatment fatigue, directly observed therapy, and we are doing it, and it's working, especially for the children and adolescents and some of the adults that are having treatment fatigue. Now, regarding integration of traditional medicine and HIV treatment, actually it has been ongoing. And I remember many years ago, I think I was executive director for Theta, and we were working well. The key issue that you should not forget is that you cannot come to me before you go to the National Drug Authority. And they have their different committees where they listen in, you present, they send you to the lab, and then the process goes on. We have never stopped. But the thing is that now, honestly, if you're talking about money, and when we are trying to work around resources, dwindling resources, how innovative can we be? You just need to work with National Drug Authority and see how innovative can we be. Flavia, we are hearing you, and we are saying we are trying as much as possible to work with the community. But how can we work with the community in our dwindling resources? We have to be innovative. The way we were innovative in the 90s is how we have to go back and be innovative. We had the... Thank you, Dr. Blabkam. We had the VHTs. We had these community groups. We had... Because I remember, without money being there, there was a way information trickled. Let us see how we can go back and see how we send down this information, because it affects our treatment, it affects our linkage, it affects our looking for those that we are missing. So we need to go back. Transitioning from adolescents to adults, we need to work together, and it is the one thing about our pediatric unit in the ministry is trying to strengthen, because much as we want to accept the fact that they need to transition, We know that when they were adolescents, when they were kids, you babied them. But you see, as they are transitioning, we have got to see, and we are looking for strategies of how we win them off before we shock them. So those are the things we are trying to do as in the different facilities right up to Health Center 3. So for now, that is what I can say. Thank you very much.
Yeah, thank you so much. I think on your table, I'll still go back to this handbook of the PFTI. Have you all read that book? There's a call to action. Have you read it? Because the chairman asked a question, what aren't we doing? Everything seems that we have it in our hands. But we are not just reading the call to action. All the knowledge that we want has been written there on the last pages. Each one of us, our responsibility is clearly prescribed there. The few people who asked questions are really very few. I know there are a lot of questions out there, and I think we shall continue discussing. But just to allay the anxiety and frustration in the room, I would like to follow up from what Flavia said. Flavia, now you can look this side. So there is a course called Philosophy of Research when you're doing a PhD. A researcher never has the knowledge. The knowledge is with the people you're going to ask the questions. And in this case, from what you're saying, already I could write a book about the HIV evolution in Uganda. What am I saying? If the HIV positives and the negatives did all what it takes in this country, we would end HIV. Isn't that right? Do you agree with me? If all the HIV negative did what they are supposed to do, we will not end HIV in this country, right? If all the positives did all what they are supposed to do, we would end HIV in this country, right? Maybe right, maybe not. I may be wrong or I may be right. Dr. Watiti Papa, you said all the time you have lived with HIV, you have not transmitted it to anybody else, which means in your life you have ended not only AIDS, but even HIV. Is that right? Now, we know what to do to end HIV/AIDS, but we are not doing it. Flavia has given us a call to action. Engage the people who are living with HIV. They not only have the knowledge, but they can act. I end there. Thank you.
I also want to make a contribution on some of the submissions that have been made by the experts who are seated with me here. And I will scan through a number of areas. One of the areas is from Flavia. I will not have the order, but I will be scanning through. There are some which are not in my area of management. She talked of the interruption in treatment and in relation to the integration and community systems. I want to say that when we say client-led delivery, we are also linking it to the community system strengthening, because you cannot have, or you cannot build the capacities of the local organizations or organized groups before you get the members who belong to those groups. And usually, members who belong to those groups are clients or service recipients. So, when we, like the organization I work with, when you look at those who are served under organized groups and those who are served as individuals, you find that the challenges, like the challenges of treatment interruption, are actually common among those patients who are served as individuals, but those who are in groups, they remain coordinated, and if one misses a service, then the fellow peers are able to track the patient, and these keep on the services. So I would strongly emphasize that in whatever we do, we embrace community involvement, and we assess the community structures that are there. Then we build strong community systems that will help us to be able to track, to mobilize the people that we serve. On the issue of transitioning the adolescents, usually it is a process, and it requires that you begin this process as early as possible by working with the caretakers or the parents of the adolescent who is receiving services. Where it has failed is that the psychosocial support in that part is now getting weaker and weaker, the priority being that we look at life-saving interventions. And life-saving interventions actually prioritize that probably you receive drugs as a priority and you get blood for viral load monitoring. So, but with the few manpower that we still have, and if we dwell very much on members of the different communities that we serve, then we are able to keep this process continuous, and the transitioning of these adolescents won't be a very big challenge in the processes of serving these adolescents and transitioning them to adult clinics. There was a concern about the teenage pregnancy, and this was directed to the commissioner, assistant commissioner. Still addressing, when we have a strong community systems, then the information flow to the responsible individuals remains at almost at 100%. It may not be 100%, but at least it remains almost at 100%. And such information will help to prevent the occurrence of gender-based violence. And of course, you know, when gender-based violence happens, of course, then even HIV also gets an opportunity to penetrate the communities. So, still working with people who receive services in their own structures will help us to address, or to go a long way in addressing most of the challenges that we face in service provision, including the GBV and the ultimate result of teenage pregnancy. I close from here for the time being.
Thank you. Thank you for the questions that came through. I think most of the issues have been handled by the experts. I want to maybe comment on 2-3 things. One, the issue raised by Mr. Karyaija, the LC5 chairperson of Mitoma. The facilitation syndrome. I will tell you that when we were developing the sustainability roadmap, we undertook an assessment. And what clearly came out was that apart from His Excellency the President at the top, the rest of the leaders rarely communicate about HIV. If you list the speeches that leaders make throughout the year, maybe the president in 60% of his speeches, he will mention HIV. Maybe in 80% health, at least health. But the rest of the leaders, no. And that also translates into the resources that actually we've been committing locally into the HIV response. So the issue is, and for me, actually, I want you, the seasoned leaders, to tell us, how can we help so that you feel accountable, to the new HIV infections that are happening amongst our people and amongst the people that vote you. When there is no bridge for people to cross from one village to another, you will run to every office looking for resources. But when there are 10 new HIV infections, 20, it's like it's not our leaders' business. Secondly, yes, the facilitation syndrome. We've relegated this problem as if it's not ours, it's for the donors. Even when we generate reports, the HIV reports, or have you submitted their reports? So for me, it's how to own this problem and know that it is our problem as a country. By the way, it's not even resources to begin with. If you are committed, that's why you find ragtag armies, they defeat government soldiers. So long as you are defeated, you will find a solution around the problem. So I want leaders to really tell us what we need to do. In addition to the leadership information toolkits that we have developed, in addition to the free airtime that the government has provided for leaders to go out and speak to their people, including the so many fora that you have, every event in the community, leaders are given an opportunity to speak, and so on and so forth. So I can list the opportunities that the leaders have, which they are not using. So I would want really to know from the seasoned leaders, what is it that we can do to make sure that our leaders feel accountable and responsible for the infections. Number two, do we have evidence that multi-sectoral approach works? Multi-sectoral approach works, and it has worked. And we showed the trends in new HIV infections, in AIDS-related deaths, in enrollment onto care. All those are improving. And they are not being done by only one entity. In fact, there are people who subscribe to the notion that you can treat yourselves out of the epidemic, of the HIV epidemic. No, we can't. In fact, we have the technology, but now we need everybody to put their hands on the deck. The religious leaders have their role that they have been playing, but they can play more. The media, the same. We now have to compete with the TikTok and other social media platforms, which instead of promoting good behavior, they are in actual sense promoting the negative one, and they have the power to attract the young people. So yes, multi-sectoral approach works. We have recently undertaken a study on structures, the coordination structures. And yes, there are positive things that we found, but there are also areas of weakness which we found, and we have revised the manual for multi-sectoral partnership coordination, which will be circulating shortly. So there are areas really for improvement. My last comment is to Francis or Patrick about what can we do in the absence of donor support. The Waganda say, "Nanyine mufu yakwata awaunya." So it's good that now we know the donor support is not there. But we know that, for example, through mainstreaming, we have opportunities where you can ride on another funded activity and you piggyback on it and implement an HIV prevention activity, including reaching to the communities, including convening meetings, including sensitizing your health workers, your staff, because they are also at risk, including picking guidelines or condoms and distributing them. There is a lot that we can do before even we think of the donor support. The donor support was good when it lasted. Now it is not there, and we have to do with our meager resources. Thank you.
Yeah, thank you so much, the panelists and members who raised these questions. It is very clear we have overstretched. It is time for lunch, but I will request members that we give a minute to our Director General. We are hungry for your voice. Thank you.
Thank you, sir. Thank you for the exceptional emceeing. I think we give him a round of applause. I'm definitely very pleased to be here because for me it is like going to the birthplace of Jesus or returning to Mecca for the Muslims. Because I was here about 30 years ago, so I am on holy ground. I'm on holy ground. That's on a personal note. But I wanted first to appreciate, all of you appreciate the high quality presentations. I think the tempo of the meeting, the way it has started, we've pitched it at the right place, and it was not by mistake that we chose this collaboration with MAST. We are very pleased and we look forward to many more collaborations. Let me respond to a specific question from the colleague on integration of traditional medicine. Very pertinent issue. There's a lot of work going on in the area of traditional medicine. We know that a law has been signed on the traditional and complementary medicine by the president. For that law to be implemented, we need regulations. There has been a process of putting in place a council. I know that there is a proposal on the minister's table. So this is my advice to you. It's like a whisper in your ear, but it's in the mic. You sounded like a very strong lobbyist. Because of the work that your department is doing, you would do a great job if you're on that council. So why don't you send a petition to the Minister of Health? Because for me, where we are now, traditional medicine should be alongside, it should be in the regional referral hospitals. You know that every time an efficacious molecule has been found, let it work along, the conventional items. And we keep testing and saying, is this working? I know you get conditional approvals from NDA, but there is no reason why there should be departments of traditional medicine in regional referral hospitals to begin with, national and regional, and then it can go lower. So I would strongly recommend that one, either yourselves or Makerere University or the others are part of the council. But two, you take this very strongly forward. In me, you have a supporter, and we can always follow up this together. So I thought I should specifically respond to that, but also appreciate, the pitch, the level at which we've placed the conference, the colleagues from the Ministry of Health. That is really very, very powerful. Our colleagues, Flavia, people living with HIV, the work that you've continued to do. I think one of the missing pieces for me in the response is communication. Because, the science is there, the tools are available, the medicines are in the hospitals, the prevention, why aren't the people using them? Why is there persistent stigma and stigma and discrimination? Why do people drop out? I think there's a communication issue at all the levels, either from between the partners, the sexual partners, from the parents to the children and the newborns, from the community leaders, to First of all, certain messages are difficult to communicate. Because if you're telling a religious leader to communicate about condoms, it can be or about PrEP. You know, you need to think, how will he package that? What does he tell his audience? He has a very specific mandate from, you know, the constituency where he's coming from. So if we can figure out the communication issues, then probably they will go ahead to address the behavior interventions. I'm looking forward to this afternoon and to the additional 2 days. And I want to thank you again, especially the energy from the MCs and the co-chairs for the morning session. Thank you very much.
Thank you so much, our Director General. Chief MC, I think you are set. You are going to guide us. But Uganda AIDS Commission continues to appreciate your presence. Mbarara University of Science and Technology is happy hosting you here. Just tell you that Mbarara University of Science and Technology is married to Mbarara Regional Referral Hospital. And therefore, you'll occasionally see very many members from Mbarara Regional Referral Hospital. It comes to see a visit at home. Please, Chief MC, I request that you take us through the program. Otherwise, immediately after lunch, we have a chair because he has positive energy, is the only one who can manage us, especially after lunch. And that one is the only and the one called Dr. Edward Bitarakwate, whom we commonly call a deep diver. Please, you'll take us through immediately after our lunch. Thank you.
Thank you very much. We can give a very well-deserved hand of applause to the chair. That was a great job, Dr. Deus, 2SJ. Dr. Deus is the director of the Regional Referral Hospital. He's an old friend. That's why he was lying that I have more cows than him. He has more, but he's not telling the truth. He promised us at the beginning that he would allow the rain to rain a little to take away the dust. And you did, sir. Thank you very much. It rained a little. So we thank you and your panelists for doing a good job. So we can allow you to depart. We can clap for all of them. We recognize that there are unasked questions. You put up your hands, but because of time, we will not pick on you. But I promise you, we have 2 more days. We shall answer all those questions. I encourage you to be part of this conversation. That's why we made it for 3 days. We shall ask all those questions, or you'll get an opportunity to have your question answered. In our midst, we have 3 important leaders for this region. This is an Ankole region matter. And one has already spoken. One is the chairman of Mitoma. And when it comes to HIV response, he's a real leader. He has already had a chance to say a few remarks. That is Mr. Kalyeja. He's the former chairman of Bushenyi. So I have known him for some time. But we also have Reverend Canon Bobs. He has been introduced. We shall ask him, I will humbly request him to pray for our meal and all the food we are going to eat through the night. So that is a chance. He must speak. He's a key leader in this region. He's the dean of the Ankole Diocese. And one time, because of his testimony, I almost came close to getting saved because of his testimony. That is, he almost did it. So I have not forgotten. But there is another leader. He's a leader of few words, but sharp words. An old friend of mine. A key leader in the fight against HIV, who is the mayor of this city. I know you're hungry. Ladies and gentlemen, I beg for your indulgence. I will invite Kachebezi to greet you and welcome you to his city in less than 3 minutes. And then I will ask Reverend Bobs to pray for us. We're going to eat. My old friend, Mr. Robert Kachebezi.
Thank you, Doctor. You know, when you come late, you can't know where to begin from. and you may even make the dance upside down. The chair of the commission and your team, Canon Bobsdean and the team, doctors, professors, because I have had so many professionals who are here. My friend, alumni Karija, I'm called Kachebes Robert Mugabe. I'm the city mayor of Mbarara City, and I'm sorry the way I am because I'm from field. This is my job, that's how I look like, because I'm in the struggle. When you look at the picture of the president when he was in Ruwero, trying to fight and bring peace, which we are enjoying right now, the way he used to dress by then and how he is right now, there is quite a great difference. So for us, we are always there. That's where I'm coming from. I want to thank Mike. Where is Mike? Mike Masco, yes. My brother and my friend. We have been together. He specifically came to my office to invite me and said, please make sure on the schedule you have, I know you move a lot, at least 2 minutes come and we will welcome my people in your city. So that's why I'm here, by the way. That is an indication that there is a great improved relationship between your office and our office. I have been challenged that really as local leaders we don't talk much about AIDS. Yes, we know it's there and we talk about it, by the way. But I want to thank you people, by the way, that you have done a lot to make sure that real AIDS is there and it has drugs, much as it may not cure, you know, but you are doing what you are supposed to do. Then the challenge and whatever God is there for us. And even ourselves, we are going to protect ourselves. The reason as why even these people every day, every Sunday, Sunday or Friday there is the overnight, then there is lunchtime relaxation. They try to make sure that people don't sleep. All the time they think about God. So like now what we are doing, we are trying now to spread the gospel that AIDS is still there. AIDS, even up to now, it kills. Because we are still with it. But it has, you know. During the time of Corona, Dr. Deus, you know, we are together here. Nkandi ya kachiku. Bakakanta hunaka Corona Task Force. Kutwabe turiyaho hije kimotoka cha leta umuntu kwihamate hariya. Umuntu kuyakorire n'abapolisi abaye bagiye kwato umuntu we kimotoka. Bagwa hasi mbundu buri omwe yagisiga. Because everybody was scared. Someone coughing. Nkanta kwine, nkankwine. You were saying the doctor nkankwine. I have seen you. We are together in that meeting. Actually, the next meeting, me and JB, we said, the cover doctor babishomere baze. Erekaba doctor babishomere betegereze nitweka tubene turebera umukona yitu nkokunkuba nindeba banje ba politics. So I want to tell you that really, as the commission, you have done a lot to sensitize people that it is there. Konka orabajirwiri tichirukumanyisa ngo nokufa. When Hatoria Mnyanya Zoa Nagamba, she came to my office requesting for space. I still remember you. Urukshaba akanyako koram. Yanga mbrangwa akakwa akamanyangwa jine. 94. 94 up to now she's here. Ninkisa siriye mbundu. Debari. Nagamba no gamba ya gambo rushungu nago jejana ragona simka. Debari gumcharu guribu. And we have people who get diseases, some tomorrow they are dead. Hati nkendwara nka cancer ezo chiriyaho nko mbweno echina kubeni mbashaba imwe bari ya researchers nkamana gumwatire umuryechi na nukushomeza hata no mukansa kuriya nayo kuruntunga y'abashaho bakata ya mani iwe director munywani wanje director no nore bitinisa natandika kubishara ntagwisa kagwe konka kasta mbwenu nabaningambiwe wayemanya mbwenu bakata abamani umuntu warankezo cancer habwo ko hato umuntu kutokugira ngo I lost my parents, both of them. I'm an orphan, a total orphan. That's why people vote me, by the way. Because they know they are the only people that I can be there for me. A total orphan, I don't have a father and mother. And both of them died because of cancer. Mbenu kuna atwire mau, yajato mwanya gwa cancer shinangwa kurunarwire sirimu. As a chances. Then was shooting kasirimu shi. Irhachira chirumu. Haza tukugira ngo irhakira kirumu kugira ngo ero konka at least embaze gizireta iyo kugira ngo umuntu nabasa kurye embazi abaro embaze gizireta ero shane cyukwa mutuma orukuzambazi akagurukaho akaza kunywa amaro akazambazi akaguruka ogwenafu. I'm not saying ngo baze kushamba gutukana bakwatwe sirimba barye embazi, no. Okwerinda nukushiro kugira ki nukushiro kutambisa. At least I want to thank you so much for what you are doing. Need to cheza. The Mike and the team sometime back came here and made the research. Ha, Bob zininjira wakijwe. Ngo musitomu numwe hakuchisamu sirimu. Ai ba mu Uganda yona. Kaka trendinga. Mbwenu kano shoti ninye bajizire ngo muzengo mukijunga babyame bagikwatwe kachebeza nanye ndarebe rutindo kurukura korwa nikachebeza sirimu yakwatwe umuntu tinye ndukutwara kachebeza. Mbwenu hati konka you were doing your work, and when you talked about it we started telling people that you people don't sleep, don't think that AIDS went away. AIDS is still here. Nambwe nimanya nkumwagarikiremo mwashanga kandi abanje hata bagarikire nyuma bwo kwa bakagira ki bakatina hata bari yabaye twire nkabamani bija baturabaho kaki nanye naguma ninkisinduko mu district ntiyabo naba district banje kandi no should report here you are we. Yes, the report was from your side, not from the city. Konka because Mbarara city and the district is the same. So please, ladies and gentlemen, I don't want to waste a lot of your time. I'm very happy that you are here for this cause, which is still here. As local leaders, we are also going to improve where we have been weak. Lastly, marchers are also looking for votes. The President of the Republic of Uganda that you have been thanking has always mentioned and advised us that there is AIDS and that we need to take care of our lives against HIV. Is visiting this city here on Monday. When hati nisibo ko ndiyo munchiko ndiyo mukweyera ndiyo mukunda mahembe gente umujenye nanda kutaha mbwenu I call you ebyo byo kuzagamba rujunga rimwe abagamba rujunga umwe akarunu mukatera kuce bonkate mukatere. Please go and vote on the 1st of December. He will be here at Boma. Let us all be there, welcome him and thank him also. Abukwa kware na tusiba na tugambira ngo sirimwero akatunywanira akatukorera biya mwijetu mwakiri on 1st. Then 15th Doctor Shana orabari ya murwire orya ha oxygen naja kusigaho director wirwaro abeno we yaguma hona wabanza agende karatere karakaruru yaza katera hazeho Dr. Ndije oriya nawe hazeho Ndije abantu tutera karutugumize mu businge bwito aho kumukukora ihanga ryitondije yagumizamo. But otherwise ntukimanya Trump kuyagizira ati nashara ho buyambi nabwo twatandika kuteka teka slim by the way kuyagizire ngo ADR gawe ya abantu nkabareba n'ekanisa ekijuremu obwo bwire mbwenu kandi kuba bagizire bati hati batandika kugaruka inyuma mpora konka siri imwe iriho let us keep sensitizing the community. But I want to thank you, Mike. You have always been on the radios, on the TVs, and people know konka omweno omwaro obwo kusimuro yegwejegize. It's very expensive and costly, by the way. Okusimuro yegwejegize nobwo kumushikamizi ga fridge omukutu wena agumana agona ahabwo kuba yegwejegize konka yaba gwejegire okamushikaho twizi tuce ningo kamukanga nakanga murinka twaturiya ogwe mpaho so okusimuro yegwejegize kigumire. But otherwise I wish you well, and please you will allow me go because I have so many engagements, so many meetings in preparations of the big visit, and also looking for the votes. Kuturuku rwomka president mugarichi munterera karuru nanye kantine shongani nashangwa ndinefuzi mbwene mumpereza karuru abwo kwa nimwe banje mwe bari munonga mukama bampero mugi mwe bari doctor ogo Dr. Kesimba ninye nabende campaign manager batwiba.
Thank you, Mayor of the city. We are going to pray for the lunch. I can promise you we have lunch. I thank you for your patience. Our Dean, it's an honor to invite you to pray for the lunch and all the food we are going to eat until tomorrow.
Okay, let us do some bit of exercise, and we do stand up so that we can pray for the meals. Our loving Father, we thank you for this great symposium that has been located today, tomorrow, and Friday in this great city of Mbarara. We thank you for all the journey mercies that you have given unto us, and we thank you for the panelists that have taken us through this exercise till now. We thank you for the great men that have prepared this, and we thank you for the great man, the President of the Republic of Uganda, His Excellency President Museveni, for this great work of Uganda AIDS Commission. And we thank you because you did
I have
create
the honor
us
to welcome
in your own image as our Father. And we thank you because you did give us knowledge to distinguish, and you gave us that great will to say yes or no. And Father Lord, we greatly understand that if somebody sees something bad and you say no to it, it cannot enter you. And Father Lord, give us that courage and give us that knowledge and give us that power to distinguish between the bad and the good. We are here for you, Father Lord, as we prepare ourselves. Take the meal that has been prepared for us this afternoon. Bless it, and even other foods that we shall be taking later on. And Father Lord, give us the courage to stay here so that we can hear these great men and women telling us what to do. And we also repent where you have been weak so that we can be strengthened and go back and talk about it. Father Lord, bless the food as we are going to take it. And Father Lord, we also pray for those people who don't have food. Father Lord, extend your gracious arm so that you can also feed them. Feed us today, tomorrow. We praise you and thank you through that great and wonderful name, the name that is above other names. Through Jesus Christ our Lord we pray. Amen.
For us to be orderly, I request that you sit.
I have the honor to welcome you to Mbara University of Science and
So we shall be ushered in an orderly way.
At MUST, we believe in success. Our motto being,
so we can resume our seats and wait for the ushers.
Why should you choose?
Let us be orderly.
The program Health Science
so we want some order to make sure the guys who have come from Taxi Park do not eat before you.
Under the Faculty of Science. Engineering programs
so we'll be ushered in an orderly manner, but it will not take long.
Technology. Computing.
So as the ushers do their work,
offered under the Faculty
I want to take this opportunity to let you know that we have exhibitors. We have several exhibitors, tents, where we can go and receive some information and services
studies.
So you can visit the
Our
tents at
emphasis
leisure.
as we offer these programs is on
We have
community engagement.
service
Our
providers
students are
like
trained in the communities
the Joint
where they
Clinical
can
Research
get
Center.
hands-on
They are here.
training and experience
The tent immediately
real-life
after us.
settings.
We
Some
have
of the
TASO.
programs in that category
And
are
specifically, I want to
community-based
thank TASO
research
together with Mbara University
The other reason why
for
we
partnering with
have
us
is
in
we
organizing
have
this
highly
event,
qualified
in making.
and very friendly. We also have good
Okay,
administrators
so this is
who are key
for the guys online,
our students.
participants online. We can break for 45 minutes.
We offer
So we look
affordable
forward to resuming
our tuition and fees
at 15:45. 15:45, we shall resume.
Students, faculty, and management is cordial. We aim at supporting students to complete their studies. A student can choose to walk into the office of the academic registrar, the office of the vice chancellor, and ask for whatever service, and they'll be welcomed and supported. At MUST, we guarantee uninterrupted education. During the COVID-19 pandemic, we did not stop interacting with our students. We went online and our students studied and completed, graduated on time, and took with them their transcripts and certificates. So we do guarantee that when a student chooses MUST, they will walk away with their academic documents.
We have human diagnostics.
Finally,
Human diagnostics, they have a tent, they have Aura Quick.
we offer an
You can test HIV, you can go and learn about them.
at an affordable
We have a tent.
Should you choose
We have
MUST
Nafofano,
as your university,
the forum for
we
people
guarantee
living with HIV.
success.
We have ICWEA, International Community of Women Living with HIV, East Africa. As I said, we have JCRC, which is a tent immediately next to this big tent.
HIV is still with us. In
We have
2017,
AIDS Information Center.
President Museveni launched the fast track initiative
We have Red
in
Cross Society.
2030.
We have a tent for Mbara
The best way for young
Regional Referral Hospital
is to abstain.
and the AHF Uganda Cares. So when you are done with your lunch, you can check on these tents and receive the services our partners are offering.
Which you may live with all your life. Why don't you wait, hold on, you study, finish your degree, and then you look for a partner at the right time.
Protect yourself. Abstain from sex until you're ready. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066. This message is brought to you by the Office of the President.
If you are pregnant, go for antenatal care services at a health facility. Take the HIV test with your partner. If you test positive, take ARVs to protect your baby.
Because if they take those medicines, then the baby is born HIV free.
Join the effort to end AIDS in Uganda by 2030. Take the HIV test with your partner today.
Fellow men, support your pregnant partner to go for antenatal care services.
For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066. This message is brought to you by the Office of the President.
My wife tested HIV positive. Does it mean that I'm also HIV positive?
My wife tested HIV negative. Does it mean that I'm also HIV negative?
Your partner's HIV status is not yours. In other words, your partner may be negative, but you may be positive. So everybody must test individually.
Join the effort to end AIDS in Uganda by 2030. Take the HIV test with your partner today. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066. This message is brought to you by the Office of the President. AIDS is still with us, and Uganda has 1,000 new infections and 500 deaths every week. The estimated total number of people living with HIV is 1.4 million.
We had relaxed when it had come down, but I think we should go back. Because now we have a chance to completely defeat it. So we should talk more.
As a leader, I plead to support the struggle against
HIV/AIDS in Uganda. The great support to ending HIV/AIDS by 2030.
Join the effort to end AIDS in Uganda by 2030. As a leader, play your part in the fight against HIV. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066. This message is brought to you by the Office of the President. The estimated total number of people living with HIV is 1.4 million, and about 1.2 million are on treatment. People with HIV can still live a healthy life if they adhere to treatment.
Health is wealth. Help Uganda become prosperous by remaining healthy.
I take my ARVs every day. I am healthy and strong.
Join the effort to end AIDS in Uganda by 2030. If you are living with HIV, take ARVs daily as advised by your health worker. For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066. This message is brought to you by the Office of the President.
The Presidential Fast Track Initiative to End AIDS by 2030. Young people should strive to get comprehensive knowledge about HIV/AIDS. Quite often, young people have been heard contemplating the choice between pregnancy and HIV.
This question of saying pregnancy is more dangerous than HIV, what is? There's no logic. They are all risks. They are all risky living, and this is something I don't recommend for the young people.
Young people, speak to a health worker near you about your sexual and reproductive health challenges. HIV is still here and has no cure. End AIDS in Uganda by 2030. The Presidential Fast Track Initiative to End AIDS by 2030. From the late 1980s, the country managed to reduce the HIV prevalence by relying on the ABC strategy: A for abstinence, B for being faithful, and C for condom use.
To avoid catching HIV, abstain from sex. To avoid catching HIV, always use a condom in case you cannot abstain. Although the condom itself is not, it may protect you against HIV, but there are some other sicknesses like herpes.
Despite the presence of ARVs, they are still expensive and not sustainable. Let us prioritize the ABC strategy. End AIDS in Uganda by 2030. The Presidential Fast Track Initiative to End AIDS by 2030. Currently, about 1,000 people acquire HIV every week. HIV is still a threat and may affect your ability to achieve your maximum potential.
Health is wealth. Help Uganda become prosperous by remaining healthy. Because when you are young, you should aim at prosperity, living a prosperous life. Prosperity, first and foremost, comes from health.
Remember, your HIV negative status expires every time you have unprotected sex with someone whose HIV status you do not know. Avoid HIV. Let us end AIDS by 2030. End AIDS in Uganda by 2030. The Presidential Fast Track Initiative to End AIDS by 2030. Currently, about 1,000 people acquire HIV every week. HIV is still a threat and may affect your ability to achieve your maximum potential.
Health is wealth. Help Uganda become prosperous by remaining healthy. Because when you are young, you should aim at prosperity, living a prosperous life. Prosperity, first and foremost, comes from health.
Remember, your HIV negative status expires every time you have unprotected sex with someone whose HIV status you do not know. Avoid HIV. Let us end AIDS by 2030.
For advice and more information, please call our toll-free line on 0800 200 600 or 0800 100 066. This message is brought to you by the Office of the President.
Define the health of a family. Mommy and daddy, we the youth should close the tap for new infections. No more death in Uganda related to HIV. Together we win as youth in fighting HIV. Together we win as men. Everything we can do. Saomuzano, Saomuzano. Together we end the scourge of HIV. Together we end the scourge in the whole of Africa. Jenga nchi yetu inaomba afya njema, marafiki tusimame tupiganishe ugonjwa wa ukimwi leo. Naomba tuungane tusaidiane kidole, moje chawa. Naomba tutetee, naomba tujipange, tuwasiliane, kwa mwisho tujiandae, ndio wakati. Hakuna utani. Vision 2030, 1990, yeah. Mama
and gentlemen, I want to request all those that have not yet got coupons to be patient. We are bringing the coupons. We are recycling them. So let's be patient in our seats and wait for the coupons. Thank you.
Selected cities. I would like to ask them to remind the population of the 2017 commitment, end AIDS by 2030, which indicates that we are working towards no new infections, no AIDS-related deaths, and no stigma and discrimination of people living with HIV.
To be in this journey, I call upon Ugandans to follow this. If you can't be there physically, follow it through the media, the social media platforms and the print media, including the radios, as the torch is taken around the country. We are looking to making sure that we carry this torch until we hand it over to our chief champion and promoter who has always promoted this, so that he shows Ugandans that there is light, that they should be hopeful, that ahead there, although we do not have a vaccine now and we don't have a cure now, let's use what we have with the hope and light that a few years down the road, the scientists are not sleeping, they are working. I'm sure you've heard of the injectable preventive treatment called pre-exposure prophylaxis, and that is very close to the vaccine, because if you have it, it really protects you. But no intervention in HIV prevention works alone.
And I want to express my pleasure for the partners who have partnered to have this function be what it is today. The government of Uganda has done a lot, enormous, in response about HIV/AIDS. In the first place, what you are seeing here is a testimony of what the government is doing by way of attracting so many partners in the fight against HIV/AIDS. As you can read for yourself around, there are so many partners in this fight against HIV/AIDS to ensure that they combat the spread of HIV/AIDS in Uganda. Now, the president himself is a role model in the fight against HIV/AIDS. And the vision of the country today is that we should not have any new cases of HIV/AIDS by 2030.
We also have been working with the cultural institution to train the surgeons so that they can pass on good protective information to our younger people during Imbaru and after Imbaru. Sometimes it is before, during and after. So we want that to help us that we reduce all the infections in our region.
Yeah, today we are commemorating the World AIDS Day, trying to give out information on HIV. So we are calling upon various implementers to be able to support communities, so that I know communities can do well, especially contributing to the fight against HIV. Treatment of HIV cannot be successful alone not until we add on some social services like counseling, follow-up, and other services that may support persons living with HIV.
Eno network y'abavubuka whereby omuvubuka wajja asobola okuyambibwa mu ngeri ezitali nyingi nga okubudaabudiwa, okufuna obujjanjabi, okufuna services ez'okwekuuma nga condoms, n'ekirala nkubiriza abavubuka mwenna abatala okumanya status zammwe mujje mwekebeze. Ezo services za free era ziri ku malwaliro gonna.
Stepping up the best, no turning back. Defeating the scourge together. No giving up, no losing hope. Sharing all the challenge. Rolling every stone to win the war. Give it up to researchers. Stigma down, infection go. Stepping up the pace. Stepping up the best, no turning back. Defeating the scourge together. No giving up, no losing hope. Sharing all the challenge. Rolling every stone to win the war. Give it up to researchers. Stigma down, infection go. Stepping up the pace. Sirimukwe, ogenda di. Abantu be Uganda twakukowa. Otudansiza, otukaliza. Buli wempita bali mu miranga. Katufungize, opakinge. Emigugu odya gye wafeeyo. Tusise nnyo, tulwazisa. Katukulwanyise. Ajagenda. Mbasabye mumutayize. Ajagenda. Sista tewegabangula. Ajagenda. Owaye tosumagira. Ajagenda. Batayi musibezi. Ajagenda. Batayi malabula. Omusajja wali awo. Yeekwese mu banyirivu. Mwasinzira okutubaka. Abo abaana tabataliza. N'abakadde n'amiringusa. Oyo akukwana gwe mukebeze. Mwagaana musegulire. Sirimukwe, ogenda ddi. Abantu be Uganda twakukoowa. Otugasiza, otukaliza. Buli wempita abali mu miranga. Katufungize, opakinge. Emigugu odya gye wafeeyo. Tusise nnyo, tulwazisa. Katukulwanyise. Ajagenda. Abalwadde tumira empeke. Ajagenda. Ngambye tumira empeke. Ajagenda. Kale akapiira tokafumita. Ajagenda. Amajiiko mugakozesa. Ajagenda. Guno omulanga gwe makuutira. Kugenda erimu abamekesi. Neggumba tonnameketa. Sooka okebere obali agaga. Tokozesa ngalo z'okumeketa. Asiika obulamu tassa mukono. Tuzimbe Uganda engulumivu. Kale siriimu tumulwanise. Sirimukwe, ogenda ddi. Abantu be Uganda twakukoowa. Otugasiza, otukaliza. Buli wempita abali mu miranga. Katufungize, opakinge. Emigugu odya gye wafeeyo. Tusise nnyo, tulwazisa. Katukulwanyise. Ajagenda. Kati omusaayi tugukebeze. Ajagenda. Abasawo tubawulire. Ajagenda. Abaana mubaleete. Ajagenda. Let's take a stand and fight
Ladies and gentlemen, we are ready to resume our afternoon session. So this is to invite the participants back in here. I'm glad to announce that our guest of honor is back. So the Vice Chancellor is back in the room. So you had better do a summary something and rejoin us and we resume. We are glad to have you back, Madam Vice Chancellor, and thank you for coming back. So, in the next 5 minutes, I want to invite the Tasso Choir or the Uganda Cares Choir. Come and be singing, come and sing for us one song each as the session chair joins us. Tasso Choir, if you're ready. Uganda Cares Choir, if you're ready. Whoever arrives first, they take the platform. Uganda Cares Choir. I can see that also people here are looking at me. They are not worried. Yeah, you are eating. I can see that you're eating, by the way. So take your time if you're still eating. Uganda Cares, if you're through with the eating, please come. You can sing one song each, and then we shall create another opportunity for you to sing for us another one song or two.
Good afternoon, community class.
Good afternoon, community teacher.
Today, we are going to revise one of the most important HIV studies in the world, and that is START study of the inside. Can somebody tell us what is START in full?
Me, teacher.
Yes, tell us.
Strategic. Timing.
Of antiretroviral
therapy.
START is very important because it's going to find out the optimal time when to start antiretroviral therapy.
Nobody knows the truth, no one knows the time, but start of insight, we surely tell the truth.
Daphne Komisha, a pharmacy fourth year student here at Mara University of Science and Technology. First of all, it was about the name itself. It's so mind and eye-catching. Science and technology. I hope to find here, focused individuals, and I wasn't disappointed from the day I got here till today. I've not been, disappointed. My colleagues I'm learning with, my classmates and, people of my faculty and other faculties are really focused individuals. They are focused and they know what brought them to the university from day one to day last.
My name is Alinda Ingrid, a student at Bara University of Science and Technology, doing a course in petroleum engineering and environmental management, and I'm currently in my final year. And I love why I came to MUST. Yeah, MUST is that university whereby you cannot remain the same when you come, because there is a certain quality of students. And being that petroleum engineering was a pioneering course, I'm so glad that I'm among the pioneers of petroleum engineering, and I know that out there jobs are waiting for us because they have laid a good foundation for us as petroleum engineers, and we are so expectant for whatever is outside there. Our lecturers have engaged us in a lot of things, fieldwork studies, and a lot of information has been given to us. I personally, as a petroleum engineer, have gained a lot. We have laboratories, we have studios, we have gone to field trips which have really engaged us, and we have equipment that you cannot find elsewhere, and we are so honored. We feel blessed that we are in MUST, and you can never find this elsewhere. We are at international level, and we thank you so much, the administration of FAST, the administration of Bara University. We are forever grateful.
Okay, my name is Efrata Shuro. I am a second year clinical pharmacy here at Mbarara University of Science and Technology. So as a postgraduate student, I have benefited a lot from here, and I'm really enjoying my study time here in MUST. So before joining this clinical pharmacy program, I was a pharmacist, but I always had this interest to be a clinical pharmacist or to engage more in patient care. So while I was looking for institutions which I can pursue my dream, I found this MUST. So that's how I joined the clinical pharmacy course. So I found this as I was expecting it. It's more, pharmacy previously is known for products centered, but now it's more patient care. So we do more of things on patient related, specifically pharmaceutical care. When I say pharmaceutical care, it's a very broad term. These days we work with other team in the hospital. In the patient care, the outcome is for increment of the patient care, the quality of patient care. So we collaborate with different healthcare professionals, with the nurses, with the physician, with the seniors, with the physiotherapy team. We work with them together for the best outcome of patients. So I hope, or I believe, our presence, clinical pharmacy, in the hospital has a great impact in the patient care, especially during this COVID area.
Why I chose
Ladies and gentlemen,
Science and
thank
Technology
you
IT
for returning back to our afternoon session.
the world is going digital.
We welcome
and I
you
know
back.
that
Welcome
if
back
at all
from
I come
lunch.
to MAST,
The afternoon
I
session,
am able
the
to
chair
become
is already in the
the
house.
person I want in future,
And
like
is none
software
other than
development and even
Dr.
do
Edward
some
Terakwate.
maintenance with her.
You will be
All
co-chairing
in
the
all,
session
I have been privileged
with
to attend MAST, which is the best university, and I encourage
be co-chairing the
everyone
session
out there to come
with
and
Henry
join
Mutebe.
University of Science and
session
Technology to
has
be able
two
to
parts.
attain the
A plenary
professionalism
session
that they want.
on sustainability dialogue, followed by a panel discussion still on the same topic area. So I want at this juncture to invite the chair and co-chair to take up their seats
why I chose Uganda
at the front.
Ethiopia. Honestly speaking, I didn't know anything about Mbara University of Science and Technology at first.
So I want to invite the chair and co-chair
in the place, in the
take up their
university I
seats.
used to work, I had a
Madam VC, while you are away, our guest of honor, they told us that on the 95, we had the JAR report presented. Our target was by 2025, we shall have attained the 95 targets. But it turned out that we have achieved 94, 90, 96%. So as a professional teacher, you know whether we failed or passed. The answer, everybody knows. But nevertheless, we patted ourselves on the back and said it was not bad. At least in one score, in one subject, we got 96%. But we are so close, and we had a good discussions on what we need to do differently in spite of the funding cuts, the innovation, including the traditional ways of doing things that we started with in the early 90s. Thank you. We are ready for you, sir.
Thank you very much, MC. Good afternoon, ladies and gentlemen.
Good afternoon, sir.
I can see you all had lunch. There was no coffee at lunch, but I hope all our energies are up. I'll maybe ask people to stand up for just 1 minute, just to get the blood flowing and get into the mood of the afternoon. Cortisol levels are rather low, and we know how blood moves from vital organs to the gut after lunch. We'll start when everyone has stood up. We're going to do a small stretch, and I'm looking at the team on the other side. Okay, since I have all your attention, you may now sit down. Welcome to this afternoon. I know today has been a very long day. Adult learners don't like going this long. But we're going to touch a very sensitive topic. Virtually all the morning speakers touched the issue of reduced resources for our HIV response. And this is not only a Uganda problem, but it affects virtually all the high-burden countries. With the reductions in official development assistance, we need to rethink how we resource our programs. We heard today that we need to be scientific. We use disease burden data, service output data to design our programs. Now, more ever than we've seen, we now need to use financial data to think about how we are going to sustain the program. We need to start thinking about not only the source of the money, but also efficiencies. Efficiency in the use of the resources, efficiency, allocative efficiencies. And so this afternoon we are going to have a panel of presenters and discussants. Some are online, some couldn't make it. But despite the short time, we'd want to have this as interactive as possible. We may not have time for questions, for everyone to ask a question, but even as we start, we're going to request each one of you to write down their top question. What's the most burning question you'd like to ask? We'll collect those, and even after the panelists have made their presentations, we'll try and run through those so that everyone has an opportunity to interact. We all know that our HIV program has been largely externally funded, donor funded, to the tune of 80% plus. And if that is reducing, we had this morning various donors are reducing this from anywhere from between about 10 to almost 30%. What do we do? Are we going to, do we fold up and sleep, or do we try and do something about it? So the discussion today is how we respond in ways that will sustain our response despite a reducing externally funded program. And with me this afternoon, I'll have Mr. Henry Mutebe from the Global Fund CCM will be my co-chair. And I'm going to invite him to come and introduce the panelists for this afternoon. So, Henry, please.
Thank you so much, Dr. Edward Bitarakwate, for inviting me to co-chair as we moderate this session. Once again, my name is Henry Mutebe. I work with the CCM for Global Fund Secretariat as a technical advisor in charge of program development and resource mobilization. We've had a very vibrant leadership for the first sessions, so we are also going to try our best to make it as vibrant, even when we know that our stomachs are full. And where we fail, it will not be for lack of effort, but the earlier moderators may have been very excellent. So this afternoon we have a panel of very distinguished ladies and gentlemen who will be talking about sustainability. As the chair has already shared, we are talking sustainability. Sustainability to mean the ability of a health program to both maintain and scale up service coverage to levels that are appropriate to the epidemiological context, even after the funding has stopped. And we couldn't find better people to take us through those sessions than the ladies and gentlemen that I'm going to invite. We have Florence Roquea. Florence is a co-executive director at the Global Network of People Living with HIV, and she's a frontline soldier in the HIV response. Before joining that organization, she worked with Medicines Sans Frontier and International Community of Women Living with HIV. She holds a Master of Arts in Communication from the University of Nairobi. Ladies and gentlemen, put your hands together as we welcome Florence. I have been informed that she's online, so she's going to present from online. But let me also invite Mr. Mugisha, Dr. Mugisha Charles, who is the HIV focal person for Rampara, who will also be joining us to share some success stories on HIV mainstreaming. Charles, you're welcome. Charles holds a Master of Public Health. He also has a diploma in clinical medicine and community health, and is also a proud owner of a Bachelor of Social Work and Social Administration. You know, when I first saw the list, I saw doctor, so I was worried that I was going to be alone at this side. Our next panelist is Benjamin Musita. Dr. Musita Benjamin is the head of Department of Economics at the Faculty of Business and Management Sciences at the university which is hosting us tonight. He also serves as the Deputy Chief of Research at the Mast Policy and Economic Data Center. Put your hands together as we welcome Dr. Musita Benjamin. We are also supposed to have Dr. Kirungi from Ministry of Health, but he's delegated Mr. Otai Charles from Uganda AIDS Commission, who I'm very sure will ably represent him. So, Mr. Otai, you are also welcome. And finally, we are supposed to have Mary Bogman, who is the Acting Director Global Health Diplomacy from the US Embassy, but who, due to other competing priorities, she wouldn't make it here. But ladies and gentlemen, I think we already have a good start. Ms. Florence Reako, the ED of Global Network of People Living with HIV, will be telling us about the role of community and civil society in domestic resource mobilization for the HIV and AIDS response. I would like to ask the IT team to help us and get Florence online. Okay, I could see I still have more seats here, so I'm going to invite more people. Also on the panel, I would like to welcome Dr. Silvano Samba Trinomojuni. Dr. Silvano holds a Bachelor of Pharmacy, he holds a Master of Pharmacy, and is also a PhD. He lectures at the Department of Pharmaceutical Services at the Faculty of Medicine, Mbarara University. Together, let's join our hands and welcome Dr. Silvano Samba. A round of applause as he joins us. Like I said, I'm not a doctor, but today is one of those few opportunities. Every time I interact with doctors, they are on the other end asking questions. But this time round, I'll be the one asking questions. And I'll make sure that I enjoy and maximize that opportunity. Ladies and gentlemen, I would like to welcome you all. I'm going to ask the IT team to play for us, to connect us with Miss Florence.
Good afternoon, can you hear me? Just a confirmation that I can be heard.
So as we wait for the projection, I have a few quiz questions to our colleagues from the local government. I have no prizes for the correct answer, but I'm looking at the team here from Chigezi. What proportion of the 0.1% contribution from MDAs were you able to efficiently utilize in the last fiscal year, 2024-2025? Just note your answer on the side. I don't know if our colleague from Ministry of Gender is still here. I'll also ask the same question. IT, how are we doing? If the okay. So are we on? Okay, thank you. So let's listen to our first presenter for this afternoon. Florence Riako, please proceed. The audience, the room is quite full. There are hundreds of people here eagerly waiting to hear from you. So go ahead.
Thank you so much for this opportunity. Distinguished Director General of Ugandan AIDS Commission, Honorable Ministers, local government leaders, development partners, fellow activists, leaders of networks of people living with HIV, colleagues from civil society, community leaders, and friends. Good afternoon. I'm deeply honored to join you today as a person living with HIV, as a leader of the Global Network of People Living with HIV, GNP+, and as someone who believes with every fiber of my being that the leadership of people living with HIV is not just needed, it is now. This year, through the People Living with HIV Leaders Now initiative at GNP+, together with my co-executive directors, Bongile and Kosi, I have walked alongside hundreds of people living with HIV, peers globally, across regions, while staying grounded to the realities of my own beloved Africa. And we have declared one truth boldly this year. This is the era of people living with HIV leadership. And if you allow me, today I will bring you that voice. We meet today at a very historical and deeply challenging moment. The UNAIDS 2025 World AIDS Day report released yesterday lays bare the stark reality. Progress towards ending AIDS as a public health threat by 2030 has stalled. New infections are rising in many regions, ours included. Global funding for HIV response fell by 5% last year alone, leaving 10 million people without life-saving treatment and threatening to reverse hard-won gains. Globally, 630,000 people living with HIV died from AIDS. Yet, amidst this urgency, the report calls for transformation through renewed political will, community leadership, and bold domestic investments, echoing that communities are at the backbone of the AIDS response and must drive accountability and innovation to get us back on track. I stand unapologetically to this truth. People living with HIV are not just part of the HIV response. We are its very foundation. This year, Sbo and I made it our mission to shout this truth from every platform. Why? Because having had to quickly recover and work with our networks, country network leaders of people living with HIV, we realized that because of this new bold chapter we have to now write, that includes integrating HIV services into primary health care, on the road to universal health coverage, we will only succeed if two forces lead together. Government, with its political will, policies, domestic resources, to drive quality, sustainable care, and if we truly know who we are, people living with HIV ourselves. The people who will walk to these transformed systems, feel every friction, face every barrier, celebrate every victory, and bring to you all real-time, unflinching, lived experience data that turns our good intentions into the services that actually work. Without government ownership, there will be no systems. Without people living with HIV at the forefront shaping that system with our daily realities, there will be no success. Biomedically, the HIV response has never been at a better time. HIV science has delivered something our predecessors could only dream of. A person living with HIV who is on effective treatment and virally suppressed cannot sexually transmit the virus. Undetectable equals untransmittable. U equals U. This is not an opinion. It's not a slogan. It is settled science endorsed by WHO, UNAIDS, CDC, and over thousands of organizations worldwide. It is adopted by many of our countries. And yet, it is more than science. It puts people living with HIV movement at the heart of achieving HIV epidemic control. For too long, we who live with HIV have carried the twin burdens of illness and stigma. U equals U lifts both. It tells the young woman newly diagnosed in Kampala that she can dream of love, marriage, children, without fear of passing the virus to her partner or her baby. It tells the man in Gulu, who stopped treatment because of shame, that returning to care will protect his life, his wife, and restore his dignity. It tells entire communities that HIV is no longer a death sentence or a moral sentence. It's a manageable health condition where we have access to treatment. U equals U gives us the greatest narrative shift we need now, even as we invest into the HIV response going forward. And if we seize this moment, we can do these three transformational things, I believe. One, drive massive increase in HIV testing because people will no longer fear a positive result the way they once did. Science shows us U equals U has been useful in promoting testing. Motivate rapid treatment uptake and lifelong adherence because people living with HIV and their communities will understand that treatment is not just about our own survival, it is about protection and freedom and love. 3, achieving population-level viral suppression, which gives every person living with HIV a gift of a long life, but drives down new HIV infections, directly impacting the costs of HIV response and its impact. This is how we will end AIDS as a public health threat, not in 50 years, not in 20, in this decade. But we must dare to lead, because science alone will not get us there. Global funds are shrinking. The old promise of external support is fading. It's been shared that the whole morning. I was here a little bit and heard of it. That's why this theme that I've been asked to speak on, domestic resource mobilization for HIV response, is not just important, it's urgent. And that's why the community of people living with HIV and civil society must be at the center of how countries pay for, design, and deliver HIV responses. We are not just beneficiaries. We are also investors. We invest our bodies, our time, our stories, our leadership. I just echo what Flavia said right before lunch. And we must have a return on these investments through services that work, budgets that reflect our priorities, and accountability when promises are broken. So how do we, people living with HIV and civil society, drive domestic resource mobilization? I will offer a clear practical pathway born from our regional experience and our daily realities. I'm from Kenya, so I'm technically just here, next to you. First, we lead from within through 4 powerful roles that only we, people living with HIV, can play. Advocacy inside collaborative health governance. This year, we have had to sit down and internalize the realities of what must matter to people living with HIV. People living with HIV are service recipients, patients if you will. Our advocacy must be that which collaborates with our governments, fellow community groups and civil society and partners to share. We will all ensure people living with HIV are on treatment across the course of life, remain adherent, and achieve viral suppression. And our communities access HIV prevention. We have progressed over the years from consultation to co-design. We work with you in CCMs, in National AIDS Control Councils, in parliamentary health committees, among other spaces. We agreed in our Global People Living with HIV Leadership Summit in April, for which Flavia was a representative of the country, that we will work to shift our mindset to work collaboratively with our governments in our advocacy moving forward. Number 2, self-care and treatment literacy. When we understand our own health, when we are proudly able to say, I am undetectable, we become the most persuasive advocates for testing and treatment in our communities and in our families. Number 3, health literacy and demand creation. We translate complex science into our local village understandable language. We turn the community message on U equals U into songs and drama. We turn complex messages and motivational treatment adherence messages into WhatsApp messages and radio calls in, among many others. The fourth, which I believe is most important, real-time data and lived experience. Through community-led monitoring, we document various things. As we go into the adaptations of this change, this documentation will be needed now more than ever, because we have to tell you if the systems work or not. Then together with every other community organization and civil society, there are these 3 key impact strategies that I believe can be useful to serve and work together with you for domestic resource mobilization. Continued community task shifting and differentiated service delivery. We know that for HIV, the impact has also been through high impact differentiated service delivery. We also know integration does not mean one community health worker has to have knowledge of 10 diseases. We have to find innovative ways. Some will include digital opportunities to keep our peer support and community level work going. Smart advocacy for progressive sustainable financing. Uganda has shown leadership with the AIDS Trust Fund. Now we must fill it and protect it together with you all. Number 3, which I alluded to earlier, is the community-led monitoring and accountability glue. When communities are able to track every shilling, every pill, corruption fears drop, and donor confidences arise, which in turn will unlock more domestic political will to fund the response. Transparency is the best friend for resource mobilization domestically. Colleagues, what I've learned this year as I close is that this opportunity may seem tough, but it's one filled with so many opportunities. The old HIV response model said, wait for donors. The new model says, we are the owners. We people living with HIV are ready to own this response. We are ready to lead it alongside our governments. We are ready to help support governments, partners, everyone working in this field through our taxes, our innovations, and our unbreakable spirit to keep the work going. So my call today to Uganda AIDS Commission, to government, to parliament, to partners and donors sitting in the room, please invest in our leadership now. Resource community systems alongside the broader health systems as a mechanism for strengthening primary health care, and trust us with decision-making power and budgets. Because when you invest in us, you're not giving charity. You're making the smartest public health investment any country can make. Thank you very much.
Thank you very much, Florence. Give her a much louder applause. She needs to hear it through the airwaves. And thank you very much. I think that was a very, very thoughtful keynote address. And I've learned a few words today. I have learned that people living with HIV are the real owners of the response. Flavia is smiling. You can't see her, but she's smiling. And she's really emphasized this over time. I've had new terminology, collaborative health governance, and how communities can help drive accountability and effectiveness of the response. But most importantly, the U equals U. If once we reduce community viral loads, we start breaking the transmission acquisition cycle, and therefore start reducing the burden of additional resources for everything. Thank you very much, Florence. I think you've set the stage for the rest of the panelists. Charles, you've heard from the owners. Let's now hear from you, the scientists. The floor is yours. Thank you.
Thank you, Chair. Allow me to observe the protocol which has already been mentioned. I'm not Dr. Chirunji Wilford. Dr. Chirunji Wilford would have wished to be with us this afternoon, but due to circumstances beyond his control, he's not able to join us physically, but he's online. My name is Charles Otai. I'm the acting head of resource mobilization at the Uganda AIDS Commission. Substantially, I'm the M&E officer also at the commission. I've been working with Dr. Wilford Chirunji and other members, some who are here, developed the Uganda HIV response sustainable roadmap. And with his absence, he asked me to step in for him to share with us what the roadmap entails. So that's my outline of my presentation. We shall share the background of the roadmap and then discuss the priorities that we've selected to give us that roadmap, taking us to our destination, and then shall discuss the transition, what we are going to do to take us where we want to be, and then shall look at the implementation of the roadmap, and then I'll share with us the next steps. So as a country, we've had HIV for over 40 years, and from previous presentations, we've really made great progress as a country. We've seen the new HIV infections coming down by about 61% since 2010 to last year. We've also seen that the deaths associated to HIV and AIDS have also come down by 63% in the same period of time. And with the government efforts, we've also been able to scale up treatment. Maybe I'm disadvantaged by the height. Thank you so much, Co-MC. Yeah, so we've seen a lot of progress by the country in the HIV response. We've seen a scaling up of programs like circumcision, PrEP, PMTCT, and the rest. However, this progress faces some challenges. One is that we all have a goal of ending AIDS by 2030. But before we end that goal, we've got a milestone that we should achieve, and that is the epidemic control. Epidemic control means that we should have fewer new HIV infections compared to the AIDS-related deaths. And from what Dr. Bagambi presented this morning, the deaths were 20,000 as in 2024, while the new HIV infections were 37,000. So for us to achieve epidemic control, we have to have fewer new HIV infections, less than the 20,000 AIDS-related deaths. So much as we have made progress as a country, we are yet far from achieving epidemic control. It has also been mentioned here that the response is heavily funded by partners to the tune of about 80%. So that means that we are not in control of the response. Whenever there are shocks, we shall feel them. When somebody says something in the US, we shall feel it from here. So we are not making good progress because of that. But there are also fiscal pressures, not only by our partners, but also by government. You've seen government is prioritizing things like infrastructure, agriculture, PDM, and so on and so forth. So the fiscal space is also under pressure. Then we also have system bottlenecks that are also affecting our progress. So for us to actually attain our goal of ending AIDS by 2030 and achieving epidemic control, we came up with a sustainability roadmap that gives us options to us attaining that goal of ending AIDS by 2030. But we want to see that how do we attain the goal of ending AIDS by 2030, but also sustain those gains beyond 2030 to about 2035. We don't want to get to 2030 and end AIDS and be in a comfort zone. But we want to see how can we sustain those gains beyond 2030. So I want to share with us the roadmap, how we came up with the roadmap. There are two sections, or two parts. The first one is part A, where we came up with a vision and also determined high-level outcomes across domains. And we had a dialogue with the key stakeholders and asked ourselves, where do we want to be in 2030? Where do we want to be in 2035? And what are the outcomes that can help us to reach there? So after we determined those outcomes and the vision, it was approved. We now came to part B, that how do we reach there? Now part B has got the transition. It spells the interventions that we should undertake as a country for us to achieve those outcomes and our goal. So the part B is a transition plan, and this is how we can operationalize our part A. So we identified change objectives that we should achieve to reach our goal. It also gives us the priorities that we should undertake. So our roadmap is aligned to other national and global frameworks, like the National Strategic Plan that starts from 2025, 26, up to 2030, but also the Health Sector Strategic Plan and other global and the NDP4. So our roadmap is aligned to all those frameworks. So after coming up with our part B of the roadmap, these are transformational shifts that we want to see, that the country must undertake. One, we want to see a situation where we have a top-level political leadership and weak enforcement of laws to a stronger political leadership that supports advocacy and resource mobilization. Uganda has been credited for having a strong political leadership in HIV response, led by His Excellency the President in the mid-90s and thereafter. But these efforts have been diminishing. And it was mentioned here earlier that we have so many cadres, and we want to hear more than the President's voice. We want the RDCs, the religious leaders, cultural leaders to add that voice. Okay? We're not saying that they're not doing nothing, but we want them to add their voice. We want to also see a situation from a predominantly donor-funded HIV response or program to one that's domestically funded. We mentioned earlier here that the response is heavily funded by partners to a tune of about 80%. But we want to see that for us to have this response sustainable, the government should be in charge of the response by about 80%. To HIV services and vertical HIV programs to one where we have services integrated. And for HIV, we want HIV to be integrated into the primary health care. The response is in a way that when you go to a facility, you'd find an art clinic. You'll find an officer in charge of the art clinic. You'll have an M&E officer for art. So that's a vertical program. Having that kind of program is very, very costly. So I want to move from that to a situation whereby an HIV client would go and get services from a one-stop center and will be seen by one clinician, be served by one pharmacist, and have one person taking the records. We also want to see a situation from a weak multi-sector coordination to one which is strong. Uganda AIDS Commission has got a mandate for coordinating the response, and I think it's doing a very good job. But we want this coordination to go down. We have strong district AIDS committees, but the sub-counties are weak. The parish committees are weak. Even sector committees are not strong. So we want to strengthen that coordination at that level. We also want to see a situation where stigma and gender inequality are also addressed for us to address domestic violence, behavior, and community structure that are barriers to our response. We want to see a situation where vulnerable adolescent boys and girls in society are also empowered. We've seen high new HIV infections among the young people. And one of the reasons attributed to this is being vulnerable economically. So can we empower these young people through programs like DREAMS, although it is going off, but we've got programs like the Presidential Hub Skills. We've got programs like the Youth Livelihoods. Can we benchmark on those to empower our young people so that they're able to make strong decisions and not be vulnerable? So for us to get where we want, our vision, our goal, and our milestone, we had to map out the best route that we should undertake, given the dwindling resources. I'll try and fast track. So we came up with some 3 scenarios to give us the best that we can undertake as a country to help us, to take us to where we want to be. And we used we used modeling, spectrum modeling to give us those scenarios. And we came up with about 4 scenarios that I will take us through. And this is, the first one is the status quo as we are right now from 2024. That given the challenges financially in the response, we've got partners declining their support or reducing their support, our fiscal pressures. How do we end AIDS by 2030 in Uganda? That's the first scenario. And we said, okay, if this might not take us to where we want to go, can we prioritize scaling up life-saving interventions? We don't have enough money, but what we have, can we invest in life-saving interventions, like continuing to provide art to people living with HIV, providing HIV testing services, and PMTCT. And then we can put others, not put them at the parking yard, but maybe not invest so much in them like circumcision, condom programming, and so on and so forth. That's mainly prevention. Then the third one is where we scale up both prevention and treatment. Means that we scale up treatment, HIV testing, circumcision, condom programming, name it. And then the fourth one is where we say, as a country, we are having challenges with resources, and all we can do is let's even reduce on what is available on the HIV response. So I want to share with us what the scenarios would look like. If we maintain the status quo, we would have about 280,000 new HIV infections by 2035, and about 151,000 deaths due to AIDS. And this situation, we are not likely to meet our epidemic control. The second one, where we are scaling up treatment, we shall avert 81,000 new infections and also avert 43,000 deaths. But we are likely to meet our epidemic control by 2030, where we are supposed to meet our goal of ending AIDS. So we shall be late with that one, scenario 2. Scenario 3, where we scale up art and prevention, we shall have about 100,000 new HIV infections and 43,000 deaths. You can compare the number 3 and number 1. Number 1, 280,000 infections. Number 3, 100,000 infections. So there's a very big difference. And with number 3, by 2027, in 2 years from now, we'll be able to hit our epidemic control. And that now will enable us end AIDS by 2030. So in determining which is the best scenario, we also have to look at what's the resource envelope like. We realize that scenario 1 is a low resource envelope. We can spend money, but we shall not reach where we want to go on time. Number 2, a medium resource envelope, where we are spending money on life-saving interventions. Number 3 is very costly, but we shall reach where I want to be on time. In the interest of time, I will not spend much time here on the scenarios. I want to share some graphical. So this is scenario 1. The blue line is showing us the new HIV infections, and then the orange one is the deaths. But you realize that from 2025, we are far away from meeting epidemic control. Even by 2034, we are not likely to meet epidemic control. Scenario 2 shows us that by 2027, the 2 lines will be crossing. We'll have met epidemic control by 2030. Scenario 3, the lines are crossing in 2027, meaning that by 2030 we'll actually meet our goal. I will not dwell so much on scenario 4, because it's one that we would not want to really think about, because it will reverse us from getting our gains. Yeah, so as a team, we agreed on scenario 3. And we said, now how do we take ourselves, how do we adapt scenario 3? So these are the shifts, but that by 2025 to 2030, we accept the response will be donor-driven. But from 2030 to 2035, we shall be having co-financing. Uganda pulling half, 50%, and also partners pulling 50%. More than 60% of non-commodity costs being made domestically, meaning that the government should be able to meet things like human resource, trainings, capacity building, and so on and so forth, and then leave the rest on commodities to the partners. By 2030, 80% of the recurrent costs should be met domestically. These are operations in the response. Then by 2035, we want the donors to remain providing us with the technical assistance, innovations, and new discoveries, while we take charge of the response by 2035. So how can we finance our preference or our priority? 1 is domestic resource mobilization. My director here mentioned earlier that we want the government to increase the tax base to GDP ratio from 20 to 20% from the current 14%. Increasing the health sector budget, right now it's at 7%, to about 15%. There's been an increment in the support to the health sector in terms of the funding, but we want to reach the budget declaration of 15% because we know HIV will also benefit from that. We have HIV mainstreaming by local governments. Our colleague here, Charles, will tell us his experience, where all sectors are supposed to allocate 0.1% of their budgets to HIV response. But we are saying, can we increase this to 0.5%? So that local governments are able to fill in the gaps that the partners have left to carry out things like support supervision in the facilities, to have our quarterly meetings where our partners have been supporting. So can we scale up on that 0.1% to 0.5%? Can we integrate HIV interventions into our midterm expenditure financing and the public financing management and align our allocations to budget cycles? Number 3. Harmful products like alcohol, tobacco, and then the money from that can go into health, and eventual HIV will also benefit from that. Debt to health swapping, where someone can buy off our debt and say, instead of giving him back my money, can you inject it on HIV? Then co-financing. Much as our partners are going, we want them to do it in a systematic manner and say, can you have a very smooth transition from where we are right now and where we're going to take over, but leave us when we're able to take charge. So this is our implementing plan. I've talked about it. Phase 1, finalizing the financing strategy, harmonizing with other frameworks. This has been done. Strengthening M&E systems, and then launching community-led monitoring platforms. Our colleagues have talked about the CLM here earlier. And then to begin integration of HIV services, which the ministry is already undertaking. That's phase 1. And then in phase 2, scaling up the interventions by expanding DSD models, talked about earlier, mobilize domestic resources and public-private partnerships. We shall also carry out a midterm review of our roadmap and also strengthen district-level capacity and governance. And then consultation beyond 2030, we shall evaluate our roadmap and see how to improve on it. So the lead institutions are there: the AIDS Commission, Ministry of Health. So this is just an outline of how stakeholders will be involved in meeting the 5 objectives. Under political leadership, we want to strengthen sectoral leadership and accountability. And who will be responsible there? Office of the President, OPM, USC, and Ministry of Local Government to strengthen our leadership and accountability. And then enabling environment. This is about reforming our legal system. We have Minister of Justice, the Ghana Law Reform Commission, Parliament, Minister of Education, Civil Society, and ADPs. Services and solutions, providing services to our people living with HIV. Here, the Minister of Health would be responsible, civil society, development partners, and community of people living with HIV. Equitable financing, or sustainable financing of the response. Here, we are looking at the Minister of Finance and Parliament to pass budgets that will actually enhance funding of the response. Then delivery systems to make sure that services, quality services reach our people. We are looking at the Ministry of Health here, civil society, and development partners. So why does the roadmap matter? We are saying, it's up, okay, I'm winding up. So these are the returns on investment, that the combined scale-up will avert 100,000 new infections and 40,000 deaths. The cost of maintaining someone on treatment is about 1 million shillings. Sorry, 1 million shillings per year. Last year, we had 37,000 new HIV infections. That meant that on our budget, we had to add 37 billion shillings to cater for the new HIV infections. So if we implemented this roadmap as it is, we shall save 100,000 new infections by 2035 and save on that money. Fiscal space, if the ideas we are coming up with, like National Health Insurance Scheme, taxing on those harmful products, we shall be able to raise more money, about $37 billion to health. Then sustainability, with the dwindling resources, we shall ensure that our 1.5 people who are living with HIV will continue to get services as they are supposed to be, without any disruptions. So these are our next steps. Some have already been accomplished. The roadmap has been validated. We are now carrying out the costing of the roadmap, which is also in the final stages. And then we shall take through all structures to reaffirm the roadmap. And then we are going to submit to Cabinet for endorsement, such that the stakeholders I've mentioned will own up their responsibilities once Cabinet has approved the roadmap. So as I conclude, I say that Uganda needs to lead the sustainable HIV response, but sustained partnership is critical to protect the gains and achieve epidemic control and meet the 2030 targets. Thank you so much.
Thank you so much, Mr. Otai. Mr. Otai is tall, and the moderator is short, but today is one of those days when being short can also have advantages. But another round of applause for Mr. Otai for walking us through and giving us a mind map of what the country is thinking in terms of how to sustain the response. I also want to thank Florence, who gave us a very passionate call. And like I think Dr. March said, that science gives us the medicine, but community gives us the courage to take it. So it's important how each of us supports people that are living with HIV. And just to keep the momentum, I'm going to invite Mr. Mugisha Charles. We have heard about HIV mainstreaming. There are a lot of questions around how programming at that level, local government level especially, is happening. And it seems Rwampara district seems to be an outlier that is doing exceptional work. So we are happy to have Mr. Charles come and share with us how they are responding and how they are using HIV mainstreaming as we talk about sustainability. Put your hands together as we welcome Charles.
Yeah, thank you, moderator. Protocol observed in the interest of time. My name is Mugisha Charles, and I coordinate HIV services in Rwampara district. And my topic is about HIV/AIDS mainstreaming. HIV mainstreaming. Yeah, HIV mainstreaming, it is nothing else other than integrating HIV services into the existing structures and programs. And when you talk of integrating, we are not only integrating some services and then we leave out others. It includes all the aspects of HIV services, which includes prevention, treatment, care, and support. Why mainstreaming? Why mainstreaming? The major reasons why we mainstream HIV/AIDS is to sustain the efforts in HIV response and also to increase domestic or local HIV financing as an international funding is going down. These are some of the things we expect once we implement the HIV/AIDS mainstreaming. One of them, increase awareness and knowledge on HIV/AIDS among the workforce and the community. Secondly, we shall have reduced HIV incidence among the community. We shall also have a reduced related mobility and mortality in the community. And we shall also have HIV/AIDS related stigma and discrimination in our community. Then we shall also have improved institutional coordination of HIV/AIDS response by all sectors. As a district, this is Rwampara. What have we done as far as HIV/AIDS mainstreaming is concerned? First and foremost, as a district, we developed a 5-year HIV/AIDS strategic plan and was also approved by the district council. We also developed a workplace policy, and in addition, we have a functional district HIV/AIDS committee. How do we do this? For us, to have a functional, sometimes it becomes very difficult to invite, to conduct HIV/AIDS district HIV committee alone. But what we have done as a district, we have integrated this into the TPC. Because the TPC, for us, we sit weekly. Every Monday we have a TPC. And all departments and sectors actually present in that TPC. And whatever we present, actually, it is always implemented. And we have seen it as something that can work. Because in the TPC, we don't only have the technical people, but we also have the chairperson of LC5 and the DEC members. And once something is passed there, then we know that thing can work. The sub-county and town councils committees were selected and oriented as a team, as a DAC team. We actually moved sub-counties and oriented the sub-county and town council AIDS committee, and they are actually functional. Then the HIV mainstreaming has been also integrated in both district and also sub-county budgets to a tune of at least 0.1. But we still have issues with 0.1 utilization because we don't receive it all, but at least we receive something. And maybe through the Uganda AIDS Commission and other stakeholders, we need to come up with the strategy of how we can really receive this funding, and if anything, also increase it. Every department or sector and local government entities implement HIV/AIDS mainstreaming because they have it in the budget, and we try our level best to make sure that there is something is done as far as HIV/AIDS mainstreaming is concerned. And also all health center 3s and health center 4s offer both preventive treatment and care and support services. And also they are extended to health center 2s as kind of outreaches so that we make sure that every person is actually served. Because of doing this, what have we achieved or realized? So as a district, on 95-95 strategy, the first 95 we are at 96%, the second 95 we are at 95%, and the third 95 we are at 94%. So we are also almost there as far as the national targets are concerned. Maybe the third 95, it's where we need to put more effort, and of course on other areas. The district using the local funds, the district has actually commemorated two World AIDS days, previous years, which attracted actually masses of the communities, and many people were oriented and sensitized as far as HIV/AIDS is concerned. And we have had several dialogue meetings, especially with religious leaders and local leaders, that has increased the awareness among the communities. We have also moved schools and other institutions for HIV sensitization and testing, facilitated by local revenue from the district. Local government entities have been mobilized and has also started supporting with some small supports because of the budgets that we have that have been realized at local councils. They are now supporting health workers as far as HIV/AIDS mainstreaming is concerned. And HIV testing, especially self-testing, is being encouraged in the district in most gatherings, and this one has actually yielded significantly. So I think self-testing really should also be enhanced. Then our political leaders, of course led by the chairperson of LC5, who is also the chairperson of DAC, have been oriented and equipped with knowledge. And in most cases, and I also moved with them on the radio stations where we actually talk about HIV/AIDS. Then people with living with HIV have been mobilized and also somehow supported, but not well supported, but we try our level best to support those that we can, and they actually give a hand in community mobilization, care, and treatment. And we are actually encouraging people living with HIV to form groups. Some of them have already formed groups, and they have benefited some government funds, including PDM. So I think it is also important that we encourage our people living with HIV, because they really help us. Because I remember when we commemorated our World AIDS Day in the district, these client experts actually gave testimonies. And I think our zonal coordinator, Uganda AIDS Commission, is a witness, and I think he knows this. And actually he took their names, and I think they're even waiting for you to come maybe, and you give him more hand. All departments and all government entities have actually included mainstreaming in their budgets, and implementation is going on, and we are yet to see the significant yield at the end of this financial year. Thank you very much for your listening.
Thank you so much, Charles. I know that sugar levels are low, but if you carried your fingers, let's give him another round of applause. Charles has been talking about, he's a frontline soldier, he's on ground, he's telling us what Rwampara is doing, and if you've seen how they are progressing on the cascade, the 95, 95, 95, they are on target. So it's good to listen to them and hear what they are doing different and what others can learn. Now, you've had people say health investment. Way back we used to say health spending, health costs, but there's increased framing that tends to the word investment. So just to help us appreciate why it is important to invest in HIV, we have on the panel Dr. Msita Benjamin, who will be walking us through the economic case for investing in HIV, showing us the cost-benefit analysis and long-term returns. You will appreciate that when you go to Ministry of Finance, there are so many, now that all of us are going to Ministry of Finance to ask for resources, there's a lot of pressure. The people who are doing roads want money. The people who are doing coffee want money. So we want to go to the Ministry of Finance with a better answer in terms of the returns on this investment. And we couldn't find a better person than Dr. Benjamin to take us through the session. Welcome with me, Dr. Benjamin.
Thank you so much, MC. The moderator, protocol observed. I want to take this opportunity to highlight some benefits or the costs to show you some costs which are related to investing in controlling HIV. I'm a person who loves data. That's not my slide. I don't have slides. I will take little time here. Thank you so much. We are looking at the economic burden of HIV when it comes to Uganda's context. We know that 78% of Ugandans are between the age of 15 and 49. This is the most productive age, 15 to 49, and they are 78%. When you look at that age, it's the one which is most affected by HIV. And when they are down, we find ourselves with less labor force in the market. Leave the analogy where they say there are no jobs. In Uganda, there are so many jobs. And we find ourselves with low levels of income at household level. The business output is low because these are sick people. If you have a sick population, there is less you can reap from it. And Uganda itself loses 1 billion, more than actually $1 billion US per annum when it comes to HIV-related illnesses and deaths. The total budget of Uganda is 19.6 billion US dollars. We normally like reading it in our language, Uganda shillings, which is around 72.3 trillion Uganda shillings, but in US dollars is very little money. Dangote's income is bigger than your income here. It's around 23 billion US dollars. So if Dangote brought his money here, Aliko Dangote, the richest African man, he would run your economy for 1 year and some months. So when I'm saying that your budget, you only need 19.6 billion to run your economy, and you find that HIV treatment and death cause us 3.7 trillion, which is almost like 1 billion US dollars, you see how much you are losing. With that amount, you run the entire of must budget and other government institutions. So it is very important that we need to look at the cost. And we know that the cost benefit analysis is that every $1 you invest on treating HIV or controlling it has a return on investment of 3 to 7 US dollars. If you spend $1, you benefit from it around 3 to 7 US dollars. That's the return. So it is very important to invest in controlling and treating those patients with HIV. Because once you do that, you find that there are much more gains. You have a healthier workforce. You find yourself with reduced absenteeism at work, and you have lower health care expenditure. You can now reallocate this money into other productive sectors of the economy, like agriculture, agro-industrialization, tourism, and maybe mining and science and technology. So it is very, very important to have a healthier economy or a labor force, because this will help us to revamp our economy. If there is any biggest asset Uganda has, it is the labor force. It's not the oil. It's not your agriculture. The Philippine country earns 60 billion US dollars per annum from its labor force. If you have a healthy economy from the age of 15 to 49, who make around 78%, and you train these people and they are healthy, trust me, you can get much more from them. But the challenge with us, which I don't know how many of you have gotten a copy of this book. This is the NRM manifesto, which is entitled Protecting Our Gains. In this book, Muzai has issues on page 16 concerning the health sector. And his problem is saying they are stealing the drugs. When you go on page 40, they repeat the same scenario and indicate that the health issue is theft and medicine and absenteeism of health workers in the same manifesto. He provides solutions for it. The doctor mentioned wonderful statistics of how they are controlling the HIV and how they want to achieve it maybe by 2035. They believe that they will have solved the problem. But if this, what Mzai has mentioned in his book, this NRM manifesto, if it's not worked on, there are less chances of receiving such statistics. So I believe when it comes to safety, absenteeism of these doctors at work and everything, to me it goes back to, it's a character issue. The character, it's not through the level of education you have attained. A PhD person or a professor, if he doesn't have aligned character, he will still steal. This one goes beyond the levels of education and you going to school. I don't know what they are preparing to, how they have prepared to answer that problem. Those statistics, we shall always read them and say they had planned. The target was that one, but it is this one. What makes a doctor with a PhD in medicine? You find him smoking. Stand somewhere smoking, and on the paper he's reading, cigarette smoking is harmful to your health, and it leads to cancer and death finally. But he's smoking. That's beyond the level of education. It's past that. There is something that calls for that. And that is called the mindset change. You can grow and reach at that high level of education, go to Harvard and get the best degrees, come to Mbarara University and get those PhDs, but if your character is not tuned, you may not solve the problem of poverty, and those are our targets. We keep on saying a $500 billion economy by 2040 will not be achieved. And those targets of HIVs will not be achieved too. What I'm calling for is to strengthen the Ministry of National Guidance. We need much more of sensitization. We need much more of teaching the spirit mind. And also, this one has to go. I don't know what you are doing at primary level of education, but this starts with the young ones. The Bible teaches us in Psalms 11:3 that if the foundation be destroyed, what can the righteous do? These doctors, you see them smoking, some of them, of course not all of them, but those who smoke, the question may be the foundation. Those who are stealing the drugs, the question may be the foundation. What are we doing on the grassroots? Thank you so much.
Thank you so much. Thank you so much. Another round of applause for our presenter. For me, I am not a friend of economics, but what I picked is that if you invest $1 in the response, you're likely to get a return of $3 to $7. And I know I'm not alone in this room who is not a friend of economics. But just to move on, the next presenter is going to be talking about leveraging indigenous herbal medicines and local pharmaceutical innovation for a sustainable response. Recently, I think I was following online and I saw that there are about 3 people who have presented about their PhD defense in witchcraft or something like that. So when I first saw this topic, I thought we are going to talk about witchcraft, but I need to be clear that here we are talking about leveraging indigenous herbal medicines and local pharmaceutical innovation. So we are not talking witchcraft here. So epistemologically, I want you to know that we are on target. And just to add that, for example, when you look at the Global Fund, the current grant we are running, it was about $600 million for 3 years to be ending next year in December. But out of the $600 million, it's now come to, after the funding cuts and reprioritizations, about $550 million. But over 75% of that money is going in procurement of commodities. And over 80% of those commodities are bought from abroad. So I think this is a very timely topic. We need to be talking about how do we manufacture from here so that the money remains in the economy, we create employment and so forth. But Dr. Silvano is a better person to tell us more about this. Welcome with me, Dr. Silvano Trinomjun.
Thank you, MC. My name is Trinomjun Silvano, and let me make it clear, I am not a witch doctor. I am a pharmacist, and I happen to have a little knowledge about the science of drugs, including herbal medicines. I have been told I am the last presenter, and I know people are tired, so let me make this short. I am presenting to us leveraging the indigenous herbal medicines and local pharmaceutical innovations for sustainable HIV response. Now, since morning, we've been talking about the gains we have made, how we are on course to ending AIDS by the year 2030. But then you remember in January 2025 this year, there was a shock in the funding of HIV programs and other programs, that some donors were either halting or withholding funds. And that put a lot of strain on HIV programs and other AIDS programs. So that gives us the opportunity to go back to Mother Nature and look at what do we have, what indigenous knowledge, the knowledge that for us who used to grow up in the village, our mothers would tell us, use this plant. It wasn't written anywhere though. They also got this knowledge from their parents and great-grandparents. And now is the time to apply the science and validate the claims that these indigenous people claim that the plants or plant parts help to manage illnesses, including HIV. So this presentation is on two pillars. Pillar number one is on indigenous herbal medicines. These are medicines which are claimed to have medicinal values. They can cure diseases, they can prevent diseases. And the call for action in this era where funding may not be sustainable. Okay, sorry. Yes. So I was saying that in January 2025, we had the largest global donor temporarily withdrawing funding. And of course that disrupted the services in the management of HIV. And that was the best point for us now to go back and use what we have to manage our patients. So specifically on the indigenous plants, we need to urgently validate the claims. Validation here means we bring the plants from the herbalists or from the local people and scientifically prove that they're efficacious, that they are safe for use. And here is where the research institutions come in. But the second pillar is the local pharmaceutical companies, where if we had innovations done in these institutions, and then the pharmaceutical companies which have money, which have the capacity to produce these medicines to help our people. And so that is the two pillars of reliance. This is possible because I'm going to present to us an innovation that has already been done here at Mbarara University, funded by Farm Biotrack. Yes. This was a study done in HIV positive patients. The 282 patients were randomly assigned to three groups. Group number one, they were given Artemisia annua alone. That's a herb. Group number two, they were given Artemisia annua combined with Moringa aurifera. Group number three, which was a control, was only on standard of care. Standard of care meaning the normal ARVs that they were taking. But all the three groups remained on their standard of care. And so what were we measuring? So these people were given these drugs. They were given instructions on how to use these drugs in addition to their herbal medicine, their ARVs at home. So what they would do, in the interest of time, let me go to what we did. So those are the three arms, and the instructions were, take this drug at home, mix it with your preferred porridge, whether it's maize or millet, every day in the morning at 8. But they would be given reminders by way of an SMS to make sure that they have taken their drugs, and in return they would respond by sending an SMS. So they were followed for a period of 12 months. We measured the CD4 count. We measured the CD4 count, measured the viral load, and the blood hematological indices at baseline, that is at enrollment, at 6 months, and at 12 months, that was exit. And this is what we found out, that the CD4 count increased in the 2 treatment groups compared to the control. The hematological indices improved, especially complete blood count. And there was also increased platelet count, especially where the complete blood count increased. It showed that the remedies were working in as far as increasing the immune system of the body is concerned. You know, in this we are looking at, are these remedies able to boost the immune system so that the body's system can be able to kill the HIV-infected cells. So in this, what we are investigating was that these plants are not a cure for HIV. They may have viral activities, but that's not what we're investigating. We are investigating these 2 plants to be adjunctive to treatment, to boost the effect of ARVs. And the other important part, which I didn't mention, we also looked at the ARV levels in these patients. Because remember, there could have been a potential interaction between these herbal plants and ARVs. So we found that there was no significant difference between the ARVs levels across all the groups, meaning there was no statistically important interaction between these plants and ARVs. So the conclusion is that Moringa oleifera and Artemisia annua, if combined with the ARVs, can boost the immune system and improve the well-being of people living with HIV. And so the next steps with this innovation is that there is a lab at UMRO. The innovators are looking at ways of improving this innovation by making tablets and capsules from this research. Finally, as a way forward, what we need to do is to boost the clinical and preclinical studies in these herbal medicines. If there are herbal medicines that are known to have effect, or are known to treat HIV, or are known to have antiviral activities, or are known to boost the immune system, what we need is to make sure we validate that they are safe, they are efficacious, and they can be used to manage or sustainably manage our people, especially when we are beginning to get shocks in donor funding, that we get remedies that are here. These plants grow in our backyard. We don't need to pay a lot. All we need is to add value so that they can be used to help our people. And here, the key partners that we need to look at are the research organization like Natural Chemotherapeutic Research Labs, the universities to carry out these researches and partner with universities, rather with the industries and government, so that we move forward. But we don't need to forget where this knowledge came from, so we need to have some communication frameworks so that people who gave us this knowledge can have whatever proceeds coming from these innovations to go back to them. I thank you very much for listening.
Thank you very much. I'm glad you're all still here. No one ran out of the room because of the money issues.
We also had a null hypothesis, and I like the way we connected the morning discussions. Benjamin here made a null hypothesis that you will not achieve your global targets unless you do certain things, and that was to Uganda AIDS Commission. But we've also we had from Florence at the beginning that we need to achieve community viral loads, and the community is an investor that can help us do that, and we've heard how adjunct therapy can help with immune restoration and better efficacy from the ARVs that we are taking. We are going to, I know it's pretty late, but we can't let these people walk away without any questions. And I hope we have a few hands up. Someone is going to help collect those either written questions or those who would like to ask, but I have a few of my own, if you don't mind. And again, I'm going to speak from the null. For those who listen to Professor Pauline very carefully in the morning. So, I am not sure, and this is to Charles Rwampara. I am not sure I understood how you mobilized domestic resources to strengthen the HIV response in Rwampara. You spoke about the 0.1%, but you didn't tell us how much you spent. What did you invest, and what was your return on investment? I know you've got a 5-year strategic plan. I'm not sure if that ended this year with all the other national plans, but at the end of the 5 years, what's your return on investment? Is it as much as $3 to $7 we get for each dollar we spend? But more directly, how have you utilized the health component of the parish development model to strengthen HIV programming? We know the parish development model is quite broad. Everyone just speaks of the capital, the financial capital. But how have we tapped into that if we're thinking mainstreaming, if we are thinking multi-sector? And I think for the audience, we're looking at mainstreaming beyond the 0.1%, because health funds are spread out to the other ministries. So that's one question from me. Just say something about it. You don't have to answer everything literally, but a lot of this is to challenge the way we hope to raise domestic resources. The other question I have is, we've heard about the what and the how on the HIV sustainability roadmap. Benjamin, I know you drove us in the direction of other sectors participating in mindset change, not only in the health workforce, but I think we also need it in the population. So how can what should we do at the community population level to raise more domestic resources? If the stop work orders had continued for 12 months, 365 days, Uganda would have lost over $230 million. That's what we are trying to raise. And we are trying to raise that just to do life saving. Or are we trying to raise that to do a whole combined approach? That's the elephant in the room. Thank you. And this is just to open the discussion as we get hands coming up.
Thank you very much, moderator. I have two issues. One is about budget allocation to HIV, to AIDS services at local council levels. In the budgets passed, resources are there, but they are tagged to the local revenue. And when the local revenue performance is poor, then it dies a natural death. The little resources that come in, they could go to having council meetings other than putting money on aids here. So budgeting and allocation, they are two different issues. Therefore, if government could provide the conditional grant for HIV/AIDS activities, that one would not be diverted to any other level. Two, there is a man from Rwampara. Where has he gone? This man from Rwampara tried to, I was outside, but I had him trying to beat about the bush. How do you bring in the TPC, you mix it with the deck, and yet this DAC is not only composed of technical and political. There are other people from the civil society, religious people from the community. So do you make them relevant to keep on coming to that level? Therefore, you need to revise and have time to sit and discuss these issues of AIDS. Lastly, when we come to these figures, 95, 95, 95, really we need to be very specific. How do you arrive? What have you done so that you have these figures? How many have tested? How many have remained? So we need to come up with statistics which must quantify the end result. Otherwise, we may come here and have a blanket presentation. At the end of the day, we may not do well. My brother here who was talking about the rain, I believe in the last presenters, the other one, I believe in this herbal medicine and others. Because when it was too hot, I skipped here, called my people at home to do something for you. And this is not by luck, but is inherited. I raise my case. So thank you for the clapping for the big man of the clan.
Thank you very much. I will just build on what has been shared, and I would like to allude to the fact that we have been part of developing the National HIV Response Sustainability Roadmap. We have also been in national and global conversations around health financing, but of course our major discussion point, us as NAFOFANO, is around our community structures. 2 months ago and until last week, we are doing CSO mapping, or community-based organizations mapping. We are going to all those districts and we are finding that those organizations and networks that were getting money outside have actually closed and left. The people who are doing the community mobilization and who are there, who are immobile, who are static, who are volunteering in their support groups, in their individual leadership as champions, the people with HIV, they are at facilities. One gentleman told me in Kasanda, he said, I cannot sit home because I know what it means for a man to come to a facility with HIV and they are not supported to be sustained in care. And now I'll go to the 0.1% money that comes to the local governments and to the different MDAs. Can we purpose to have this money go to support the community health workers? We are not asking for additional money in this instance. We are saying use what is there to facilitate these processes. Ladies and gentlemen, let me a bit bo omuchiga. We can be facilitated or not, but we are sure HIV will continue to spread if we are not given that support, to look for our colleagues, to support them, to support this young woman who has just delivered and needs to get nevirapine and sustain that baby on nevirapine to avoid new infections. The second level is we are now doing a lot of online trainings, online education, online. And we have engaged and we are saying IPs, can you facilitate the district coordination structures of people living with HIV and other local structures that have been there before integration to continue doing this work? We need to be part of those discussions to give you the reality on the ground so that we try to eliminate HIV in this community. I'm glad to note that IDI has agreed to support our district forums on a monthly to give them data to continue participating in the weekly meetings. We have actually weekly meetings where we take stock of what's happening around the country from the community perspective. And so also how we can engage and advocate and lobby to make sure that things are getting better given the funding cuts. The third thing we are talking about is don't give us money. You have space in your districts. You have space in your organization. Give us a desk for the coordinators, for the champions to sit, where when they really need your support or you need their support, they are able to come to you, you are able to come to them, and then they do the work. So the resources are there. And we are not talking about only financial. We are even talking about infrastructure. We are talking about collaboration and partnership. And we are saying, let us try to make sure we are using efficiencies. If you have that car going to the field, if you have a community outreach, you don't just carry the RDC, you carry the LC5, you carry the DHO, you carry the community outreach, and then you reach there, you are talking to yourselves. The people living with HIV and the other communities which are vulnerable are not at that place. So you are talking to yourselves, because when the meeting is there and has a little money, definitely you know who will be invited. And for the choose, the selection in some places, including Barara, it was like a rally. So they told the LOC person at the parish chief, please, we need VHTs and choose. Choose, actually. And people were lining up like the yellow, the cap. They came and were lining behind the people. And you know what that meant? People had to buy themselves into some of those positions. Those people who have been working, the VHTs, the community health workers, were left out because they don't have money. They are not very close to the LOC. So these positions, some of them, and this we were even witnessed when we came for mentorships. In some of these trainings we went to, the VHTs didn't even understand what human rights is, what patients' rights are. We had a few who had been co-opted. So some of these things is not about money, but is how we approach the systems and structures. But what I'm trying to emphasize is we have the structures. They are known to work. They have been tested for 30 years. You ask me a person from Koboko now at the village, I will call my coordinator, he will call the sub-county, and in the next 30 minutes you have that person. Can we utilize these structures and ensure that we invest in them and support the people to work? And finally, as we do the discussion around investment, it is a moment now for the government to take leadership and invest in community systems that exist. Like we have been doing for the road networks, when there is the road works, they identify a civil society, is given money to do the education along that path. We used to have the roads projects. We can do that in all the MDAs, so that we are able to support from whatever is available. And finally, we also need to have money to sustain staff. And like I said, we are public servants. We are not just people who are working. We are doing that work of government that government is not doing, but we are driven by passion. Because we have lived it, we have been there, and we know what it takes. So let us see investments from the partners, but including the other local ones, the commissions, petroleum, the oil, the gas, all these who have money that they can, and we would like to continue working with the government institutions, Uganda Youth Commission, Ministry of Health, to ensure we are facilitated to do our work, which is supposed to be government work, that we have offered to do over the last 40 years for free or subsidized cost, and we need to be facilitated now to further and ensure we end AIDS by 2030 at the public health rate. Thank you.
Thank you. So Flavia has answered one question about how we can mobilize domestic resources, and I'm sure as Charles is working to refine the investment case, I'd be curious to learn from the health economists how much domestic revenue would be realized by providing in-kind resources to the networks, be it office space, but then also I think the key question is how can they get a share of the 0.1 that's being collected locally? People like meeting them and thanking them for their work and waving at them, but they don't have operational resources. So can we build that into our economic models and determine how much would that be? So I know you said many things, but you've answered a few questions I was asking. Because I'm not sure I learned how we're going to raise domestic resources. And, but this is only to provoke the panelists to speak like Flavia. There was one hand at the back. Prof. Stephen, Prof. Ngonzi. So let's have those two, and then, not Stephen, Prof. Chiria. Then gender balance. So we are going to have these three. We are going to get responses. Then we'll have two more. But how, the question is the what and the how. Very practically.
Thank you. Thank you, Dr. Silvano. My question goes to you. Thank you for that presentation on indigenous herbal medicines, Artemisia and Moringa. And I appreciate your effort in developing herbal medicines. However, the way you presented your work seems like you're presenting a randomized, controlled clinical trial data. Was this this type of study? We know that in order for us to concretely say that this works, our gold standard is an RCT. How did you control for all other possible factors that could influence this patient's outcomes? Adherence, other drugs that they could have been taking, and so on and so forth. I didn't hear that. But you came out boldly with a very bold conclusion, which to me I think is too bold for now, but I'd like to hear from you. You also mentioned that the herbals did not have any effects on the pharmacokinetics of the drugs. And I'm not too sure which hypothesis you were testing here in terms of pharmacokinetics and what particular drugs you tested and which PK parameters you looked at to actually say they did not have any effect. Thank you very much.
Yes, thank you very much, Dr. Silvano, with your colleagues. My question goes to you, my brother Silvano. It's exciting to know that interest in developing local remedies is picking up. And I want to extrapolate your mind to how we are going to navigate through the pharma politics, PHARMA. When we get breakthroughs, would you please educate some of us how we'll be able to have some of our remedies hit the global market, since you're in that area?
Okay. Dr. Chiria, quickly then we'll have, make your responses very direct on the what and the how.
No, one of the comments I had has been taken
dealt
away by
with.
colleague.
Yeah,
So,
okay.
I hope Silvano will be able to perhaps address it.
Okay.
I think the easy way is to say
Yeah.
it's premature to conclude. in that
Okay,
way.
yeah.
But in connection with Flavia's concern, when we were developing this roadmap, I remember one of the things that we laid emphasis on in terms of strategic shifts was for us to, in the next 5 years or so, to change the way we perceive communities as being recipients of services to being deliverers of services, because there are so many HIV/AIDS services that communities can deliver with the support of the technocrats. And I think, Charles, that needs to be emphasized over the next years. In itself, there is a resource mobilization aspect in it, but there is also an aspect of ensuring that the response is owned. That way, we will be able to bring down the new infections. Of course, the last is to do with the fact that the issue to do with HIV IEC for behavior change is absent across. And it is something that we need to emphasize, whether in terms of scenario testings and so on. HIV education, communication for behavior change is extremely important. And so it needs to be reflected, because our preoccupation is largely we need to protect the 95% from crossing over to the 5%.
Very great points. And I know in the morning there were lots of lamentation about communication. And I hope by the end of the 3 days there will be some concrete actions around that. I think it's something we need to take care of. Flavia keeps saying they're public servants. Florence said they're investors, they're the owners. And I guess for me the question is, how do you cost that? How do you cost that service? How do we optimize it? How do we benefit from it in a sincere way? But over to you, quick responses. In whichever order. Yeah, there's a mic there.
Okay, let me go first. Let me answer Professor Pauline's question. This was a randomized controlled trial, the gold standard for generating clinical data. What was the design of our study? Sorry?
Of 37 patients?
The patients were 282. Those are the numbers we had. So we randomly assigned them to the 3 treatment arms, and the one which had the lowest number of participants was 88 patients. So it's not 37, the numbers were more. And so we feel there was, with those numbers, there's enough power to talk about the effect when there is. So there were weaknesses. Number one, what we did, we gave patients these powders to take them home to last 1 month. They could only come back to the clinic if they felt unwell or when it was their clinic day. So what we cannot tell for sure is if they 100% took the powders, because we were not there, but we relied on them responding every time we send them an SMS in the morning to remind them to take their medicines, and they were supposed to respond back to say, taken. These instructions were given to them at enrollment, and they were reminded every time they came to the clinic. So the confounders you're talking about is, were they adhering? Did we measure that? No. But there was a control group. If there was if they were not taking the remedies well, then their outcome should have looked more or less the same as those who didn't take anything. So the measurements we took, especially viral load and CD4 count, they were way higher compared to those who didn't take these remedies. And that's what we based on to conclude that is the drugs that were working, not merely chance. The the ARV drug level, it's possible for herbs to interact with the ARVs. And so that would have been very bad, because one of the instructions that was given to these patients was, these remedies were not meant to replace ARVs, but they were supposed to augment. So they had to remain on their treatment in order for them to remain in the study. And so the fear was, what if the ARVs, what if the herbs were reducing the drug levels of ARVs? So what we did was to draw blood samples, analyze the drug samples using HPLC to detect the drug levels across all groups. And when we analyzed, the drug levels were more or less the same in those who took the drugs and those who did not take. Dr. Ngonzi's question is, are we not going to have a war with Big Pharma because we may be eating on their business? For us, of course, that war can always be there, but what I said is that we can partner with these pharmaceutical companies, meaning that will be gain on their side, gain on our side, and we move on.
Okay, thank you. Any other response there? Would want to make a hard stop in the next 8 minutes.
Thank you so much. I received a question from you regarding how to increase community incomes. It's a wonderful question, but I want you to agree with me that Uganda is far, far better than what the statistics shows. We have a challenge in this economy that the data is not well captured. And this is what even Mzee states in on his message. In this manifesto, that many Ugandans have jobs, but they don't know that they have jobs because of the colonial mindsets. The mindsets of the colonialists that they planted in us, or the message that they gave us, is that unless you are hired by an institution, formal one, then you don't have a job. He says it is this colonial thinking that about jobs and money making that the disorienting our people. You ask someone, what job are you doing? In the Runyankwari says, no korachi. The answer, I am not employed. I'm just a farmer. That's what the president said. So there is a lot of money among Ugandans, but we are not collecting it. A farmer who earns around 10 million net from his cows, that money is not registered anywhere in the national budget.
Okay.
Thank you.
Thank you.
Thank you. I'm responding to some questions raised by the chairperson, Mitoma. One of the issues actually was resource mobilization and the 0.1%. Actually, that one I talked about it, that the 0.1% actually is more dependent on the local revenues that we receive in the district. And from the guidelines, though, it shouldn't be that, it should be any release, even from the central government, so long as it's not wage and conditional grants. But it is still a very big issue, and I think the ministry and the Uganda AIDS Commission, they need to do something as far as the 0.1%. It should be actually conditioned and maybe tagged as HIV funds, but if we leave the district and the heads of department to decide on that, sometimes they do not. Then secondly, they also raise the issue how we have mobilized people living with HIV and associate them with the PDM and other sources where they can earn the living. Yeah, we have mobilized these people living with the HIV to make some associations, and we have actually linked them to DCDO and commercial officers so that they can also gain from these funds that come from the government. Then lastly, the issue of discussing issue of mainstreaming in TPC other than the dark. We are not saying that we don't have dark meetings, but TPC oftenly take place, and when it takes place, actually we discuss most of these issues, and by the time we will go to dark, most of the issues are already resolved. You know, there is doing things right and also doing things rightly. So sometimes, since it is integration, we don't, we use any chance, any opportunity that comes across. Thank you.
Thank you very much. Jotham had a burning question, but it's now gone. So, yes?
Yeah, thank you. To Professor Kiria about the engagement of the involvement of civil society and community in the response and the roadmap. Yes, the roadmap details all that. If you get an opportunity to read it. I've not had the chance to share with us the interventions in detail because of time, but we've talked about it, and the involvement of community has been successful in Lesotho, where the community people living with HIV are taking lead in HIV testing and prevention interventions. They're taking lead and taking over those responsibilities from government. In Malawi, the faith-based institutions are actually taking lead. So it's also there in the roadmap, and it's working. Then I just wanted to say something about the 0.1% because those are some of the areas where we had an engagement with the Ministry of Finance. And some of the ideas coming up here, we shared them with the Ministry of Finance. But we were guided that some of those cannot be possible because the 0.1% is supposed to be got from a vote, and the vote is a law. If it has been given to a local government, you can't again remove that money to cross it to another. So it's not possible. And the spirit behind mainstreaming is that if you are doing construction, whatever you're doing is likely to drive the HIV in that area. So can you allocate something within that? So the money should actually remain within what you are doing. But other options are that if we raise money from the sin taxes, can we empower, can we have a basket fund and maybe support civil society organizations, that kind of basket fund? So some of the options are what we are looking at with the Ministry of Finance on how we can involve the civil society.
Yeah.
Thank you.
Thank you very much. Ladies and gentlemen, it's been a tough afternoon. And I'm very happy you're still attentive, very eager, you still have questions. MC, we have 2 burning questions in the room.
Thank you. I'm back to Dr. Silvano. Thank you, Dr. Silvano. I have special interest in herbal medicines, and I'm a principal investigator a co-principal investigator on the clinical trials of natural therapeutics program of Uganda, funded by the government of Uganda. So I promote clinical trials of natural therapeutics. I wanted to make a comment on your presentation, and I'm sorry I'm going to say this, having read your paper before your presentation. What I found in your paper was that you had another apparent clinical trial of 267 participants, randomized to the 3 arms. In that trial, you nested 37, you made a nested study and analyzed samples from 37 participants on what you presented. So the sample size was actually 37. And therefore, from my scientific perspective, the results from the 37 participants generated a hypothesis, which I would imagine that then you bring these drugs into a robust clinical trial if you'd like to make bold conclusions. Otherwise, when you make bold conclusions like that, people living with HIV will go away saying, oh, that is the drug to take. And unfortunately, as a clinician, internal medicine specialist, I have seen patients on the ward who even go ahead to abandon the antiretroviral therapy and take these herbals because they have seen data like that. And they end up coming back with advanced disease several months later. So I wanted to make that correction. Thank you very much.
Okay, thank you, Dr. Kasima. Yeah. So what I understand is there's a lot more opportunity to refine the study, the results, as we work our way towards trying to reduce community viral load and reduce the burden of long-term resource needs. Dr. Kasima?
Thank you, moderator. Building on what Professor has just said, Dr. Silvano, from your presentation, there are so many unanswered issues that you might need to consider before you use one point to judge whether you are drawing a straight line or a curve. And among them, we know there are many immune enhancers or boosters. To what extent can we attribute your findings to your interventions? I know you never had time to share with us how you selected your participants, how we decided who goes to which arm and which arm. Besides, I don't know whether it was open label or double blinding. Secondly, what aspects were you looking at? Were you looking at safety alone and efficacy, or you combined both? Because when you said the blood parameters were not affected and so on, it leaves a lot of issues unanswered in relation to safety and efficacy for any of your trials. I did not pick so well your next steps after your findings. I think you need to be more elaborate. And like the professor said, if it's your hypothesis, then you need to take it further. Thank you very much.
Okay. Thank you. Jotham?
I'm Jotham Mbangizi from United. So I thought I didn't want to leave the room. I'm not a scientist, but from where we stand at such an engagement, because we do not want the 1.5 people living with HIV plus those in East and Southern Africa to quickly run into this and pick, because that is a breakthrough study that was presented at this. So my hand was area. I actually wanted to say this side is stigmatized, this side. So thank you for seeing us. But to me, that's the key thing, because everything that comes out, we must be, because we are talking about the life of the people. And it is important that we don't draw back. Whatever study was done, it is important that those findings, especially the last conclusion, to me touches me. And it is important that we carefully reflect around that recommendation. Otherwise, we may cause something. If it is finally done and well robust and we've ventured it with the WHO United and all others, I have no problem. But I wanted to make that reflection. I submit. Thank you.
Thank you very much. A lot more scientific or non-scientific caveats, but I think a lot of those are comments. And I think for the presentation, I think that's quite rich, yeah. And any feedback only improves the efforts at hand. Ladies and gentlemen, join me to give the panelists a very big hand clap. But most importantly, give yourselves also a hand clap for staying alert, awake when people are discussing money issues, investment cases, and the like. I'd like to take this opportunity to hand it back to the Masters of Ceremony, who are going to walk us through the last portion of the day. Thank you.
A hand for Dr. Terakwate. Round of applause, ladies and gentlemen. We thank you, Dr. Terakwate. In Imbara with you, in Kampala we are with you, in Karamoja we are with you. You are always with us, and we thank you for that sacrifice and commitment. And the clap for yourselves. I think we should have the symposium in Imbara all the time. The people stay. You are still very many here, so clap for yourselves. You are staying, you are still attentive, a meaningful and rich conversation. So we thank you for being such a nice audience. In fact, nkakarabo ninza kubeta abana babeshongoro mwakeshongoro kamwe. The choir, come and sing for our people. We have never seen such a good audience, attentive. You are not discouraging our presenters and panelists. You are such an amazing audience, and we look forward to getting much more of this tomorrow. So we are almost coming to an end of our meeting. So I will allow the main MC to say one or two words. You stand. You can go to the podium. Go to the podium, maybe. Run. So before the kids come, run. Before the children come and start thanking our people.
Yes, sir. Let me even take a shortcut. Thank you so much, my co-MC, for giving me this opportunity. Day one has been really, really educative to us all. And we've seen how we can conquer HIV/AIDS. I did not want to leave this day without extending my gratitude. I started this day with a very thoughtful and heartfelt gift from Dr. Stephen Watiti, who has not only kept my life with his story in terms of fighting against HIV, but also given me this very book. This book is titled Conquering HIV and AIDS. And I can assure you, it highlights his personal experience of living with HIV, and it is impactful. I request each and every one of you to get a copy. He has another one, and also he made 71 years. 71, let me see people who are above 71 in the room. Anyone? Yeah, quite a number. So that was it from Dr. Stephen, and I want to encourage all of you to get a copy, just at 25,000 shillings, as we continue to spearhead this fight against HIV. Thank you so much. And MC Mbara is a nice place, not just nice with the rain, but also the people.
Yeah.
And that has been evidenced by the wonderful audience we have.
We had confirmation that we had another person in the room in charge of the rain. So that makes two. One is the district chairman, another one is the director of the regional hospital. So we are safe. We hope tomorrow we will be okay. Tomorrow we need very little rain, Mr. Chairman, Mr. Kalieja.
That's it.
Just like at lunchtime, but let the morning be clear and the later afternoon clear.
That's another order, and he has given me
Thank
feedback.
you. Tomorrow on Friday, as part of our pre-World AIDS Day events, there will be a run around Mbarara. So there's a tent where they're selling the kits for the run. And as part of our jar of our symposium, we have scientists whose papers could not be presented in the plenary. They are posters in the tents around there. And they are service providers in those tents. So tomorrow we commit to the researchers whose presentations are in posters that we shall walk around and pay attention to your posters. It is not in vain. We shall create time for you, and for the service providers, we shall create time for you to really be with you and make use of the service. It's not in vain that we asked you to come here. And finally, before the music comes on, I want you to join me to thank our guest of honor and our board chairman, our key leaders. I am very sure by them sticking here, that's why we all stuck here. If they had gone, we would have gone. So thank you. Thank you for sticking with us, and we look forward to you sticking with us tomorrow so that we can have another very successful day. Today it has been a successful day, and we are hopeful if you come on time tomorrow, the sessions are equally engaging. We have a richer conversation. I am almost convinced that I will convince the board chair that even the next jar, we are in Mbarara. This is the maximum, the best we can ask for in terms of performance. So the young people, it's your turn to thank the participants with a good song. One of your best. Thank you.
Thank you very much. Thank you very much for this opportunity. Ladies and gentlemen who are here, we are the young people from Masaka, and we decided to be part of this because we are the successful story of the 30 years ever since HIV has been with us. So we are very energetic and very healthy, as you can see us. Some of us, we are fathers, but with our slogan, HIV stops with us. We don't have any intention of transmitting it. We have the intention of living with it and we continue that life. We are here to give you a poem. Unfortunately, it is in Luganda. Konka twagezaako to learn how to speak Runyankore. It failed naye. The good thing is that we are Bantu people. Bino byakuno luno mulumanyi lwasookera wano ngamba okululaba luno lwenjogerako lwasooka bwe luti enviiri ku mutwe ngamye ensusu kwe kufa okolola lukonvuba omusujja lutentezi wulira bwe tugereesa mbu babba mukene Tanzania ne bamukukusa paka kuno olwo ne babaweereza eddogo erika siriimu tuguse buseke era tuvudde mu buddu waliwo ekitukeese gye tuvuddeyo mu buddu tweswanta twekyaye olwolwo olumbe olwo lwasiriimu olutufumitanga amatutu olwo olutukeese olutuwunyiranga zizi olumbe kyekiki
olumbe kyekibi
obeera kyekiri
ekyakolwa luli
Adamu wa luli
ne Eva be bali
abaakola akabi
omwava ebibi
kale abakabi tubabuulira ebibi siriimu wakabi akwatira mbibi n'ateeka ku ndiri n'ofiira mbulumi aleeta ebyakabi ensusu zifa bubi ne tibyo wakabi ayitira muli siriimu wakabi
mumwewale mubi
okwewala ekibi kya siriimu katira ebifumita bibi ebikadde bitula obwenzi kyekimu mwayitira ddala omusaayi gukebeze
kirungi kya ddala
okwesigaŋŋana
mu bafumbo kyankizo
okwesigaŋŋana
mu bafumbo kyankizo
obuwala obuto obusoma bwantama obweyiniguza buwoza twamala baali tubajjamu mbaawo nyaabula butya mbutoze bwetanga abaabwe mujja ku byaffa mugira mwekoza asosola omulwadde bambi olabe embugundi kamuyoola n'oseka bangi mu kufuna endwadde tebaamanya kale budaabuda alwadde muyambeko eddagala mire bw'ateera akule siriimu akyaliwo baaba kyetere neegoola baati baabwati yafaakala leero abagagga ba leero mwabagala okukuula muli kyevuma ffe wamma tubawulidde muwulidde nti muwulidde wamma minisitule gwammwe mukoze minisitule y'obulamu tubeebaza Uganda Care nammwe mwebale mwetuyise naffe okubuulira
atawulidde lwaleero
bwato bwalifa kati tubagambye
n'abo mubagambe
bambi mwekuume
neeka mubagambe
ogwaffe guwedde
ogwammwe gutinte
mukama akuume
Ssaabasajja alamule
keyazeebeewo
tubeere mirembe
tusiibula tugenda nno mutwebaze nga tubasomeseza nnyo mutwebaze muteeke mu nkola byonna bye musomye ate amanye oli amanye tumanye akadde tekaludde ekidde kitukutte tetudde omukama abeere nammwe